Dr. Rajiv, sir. Would you please unmute yourself, please? Hi, sir. Good morning.
Morning, everybody. For this panel moderator of this panel discussion. Now I am switching over to Dr. Madhukar for initiation of this panel discussion.
Thank you so much, sir. Hi,
I
everyone.
hope panelists have joined.
I think they are finding it difficult to join. A few of us is finding it difficult to join because they find it invalid login details. So maybe in few minutes they'll be joining us. But I would start the session. Hi, everyone. Very good morning to all of you. Ladies and gentlemen, I would like to draw your attention to a very interesting story about a young, beautiful 26-year-old girl from aviation industry with bright career perspectives of flying piloting from India to Dubai. But before she could take her career perspectives further, she is diagnosed to have pulmonary tuberculosis with symptoms of low-grade fever and chronic cough. She started on ATT, but she didn't have much of improvement in her symptoms, and after 1.5 months, she is told that she is having MDR pulmonary tuberculosis. She is shifted to RNTCP entitled hospital where she has been started on MDR tuberculosis regimen. And initially she had improvement in her symptoms and was doing fine. But after a few months, she again had symptoms of low-grade fever and cough. However, after a few months, the center had her culture specimen, her specimen collected for the culture, which came out to be negative, and she was told that she is doing fine based on the culture negative report, and she was told that she would recover from her disease very soon. But on an unfortunate day, she had massive hemoptysis with respiratory failure and is admitted in a private hospital, underwent intubation with a mechanical ventilation. And during her hospital stay, she had her ET spirit collected and was sent for the culture. Fortunately, she survived the episode, was discharged, but after 1.5 months, she is told that she is having this XDR pulmonary tuberculosis. She is again shifted to the RNTCP entitled hospital to receive the treatment of XDR pulmonary tuberculosis, the same institution where her culture report was negative and was undergoing treatment for MDR tuberculosis. But the hospital had her bronchoscopy performed and her sample was sent again to confirm the diagnosis of XDR pulmonary tuberculosis. But she kept on deteriorating, and before the report could arrive, she died of tuberculosis. Friends, every minute, 3 patients with tuberculosis die. And every 1 minute, tuberculosis takes life of 3 persons, and which is huge. All of you will agree that tuberculosis, as amongst all the infectious disease, has the highest mortality. I, Dr. S.K. Madhukar, at the outset would like to thank API Chopra for having such an important panel discussion on such an important topic, which unfortunately has been missing from few of the previous BAPICON meetings. And I'd also like to thank Chopra API for asking me to moderate this session, which, believe in me, is not an easy task if you see the proceedings further and the kind of discussions we are going to have. But fortunately, we have eminent and learned experts in the fields with me. And I'm sure the audiences and the delegates are going to be benefited a lot by their inputs. If you see the topic is like, can we meet the target 2025 of tuberculosis control? And what are the obstacles in obtaining this target? Before we could have this discussion further, I would like to introduce this topic to you. You know that India has the largest global burden of tuberculosis, 26%. If you combine the second and third country with the largest global burden of tuberculosis, Indonesia and China, combining them, India has 2 times greater burden of tuberculosis than they have. So India has the greatest global burden of tuberculosis. And we had this national tuberculosis program since 1961. But this national tuberculosis program in 1961 failed to have improvement in the success cure rate, and they failed to achieve control over the mortality in tuberculosis. So around 1994, 93, 94, India adopted the WHO strategy of DOTS, and under a program, RNTCP, Revised National Tuberculosis Control Program. DOTS was very, very successful. It improved the success rate of therapy. It decreased the mortality in tuberculosis. But more importantly, it gave us the basic idea of the infrastructures that we should have to have a good TB control. But unfortunately, implementation of DOTS didn't decrease the incidence of tuberculosis. So in around 2005, India adopted the WHO strategy of Stop TB strategy under RNTCP, which consolidated the gain from the DOTS, involved the private healthcare practitioners into the program, had the political commitment, fixed the accountability, started treating HIV, tuberculosis, and drug-resistant tuberculosis, and also started funding the research in the field of tuberculosis. However, in around 2015, UN Assembly, together with the WHO, thought that we should try to end this tuberculosis, and they came up with the idea of end TB strategy. India too adopted this idea of end TB strategy, and they formed a governing body. They formed a program, and they shifted their ideas from RNTCP to the National Tuberculosis Elimination Program. We call it NTEP. The global NTB strategy fixed the target by 2030. But National Tuberculosis Elimination Program of India fixed the target 5 years ahead of 2030. We call it 2025 goal. And the goal is to reduce the mortality in tuberculosis by 90%, to reduce the incidence of tuberculosis by 80%, and the target is to have a 0% expenditure on exuberant cost by the patients for the treatment of tuberculosis. And this is what we are discussing today. And this is what the goal has been fixed to us. The point is, are we going to achieve this goal by 2025? Is it a realistic goal? And what are the obstacles in achieving this goal? And I really hope that this discussion is going to be a milestone, and this discussion is going to give all of the audiences and delegates to have certain important take-home messages so that our dream can come true to end tuberculosis from India. Dr. Rajiv Ranjan sir and Dr. Sri Mohan sir has joined us. I can see on the screen. Sir, as all of us know that there are 4 pillars to achieve this target: diagnosis, treatment, prevention, and build. The first component is diagnosis, and it is planned to have Dr. Sakit with us to highlight the importance of correct diagnosis of tuberculosis based on a case which could help us in achieving the target 2025. So is Dr. Sakit with us? So is there anyone to guide me if Dr. Sakit is there?
Hello.
Hi, sir.
Hello.
So, I welcome Dr. A.K. Das, sir, with us.
Dr.
Dr. Sudhir, sir, is already with us. Dr. Sri Mohan Mishra is with us. It was planned to have initial discussion about the diagnosis and the obstacles in the diagnosis, and it was planned to have Dr. Shakit presenting the case, but I am not finding him in the panel till now. So he's finding it difficult to log in somehow. Doctor.
There are 2 sessions going simultaneously, and I am on this session. So I just chipped in here. I wanted to request Dr. Mishra to chip in with some of his inputs regarding the DOTS program. Dr. Sriman Mishra, are you there, sir?
Sir, would you like to please unmute yourself?
Dr. Mishra, please chip in.
Sir, I would request you to please unmute yourself.
Good morning, Dr. Madhukar and Dr. Das and Dr. Sailendra. We all are going to discuss very important program. As you already told, that tuberculosis is a great burden for our country and our world. We are committed to eliminate TB by 2025 from our own country. We have discussed many aspects of the RNTCP program, or now this is known as the National Tuberculosis Elimination Program. I think all of us are seeing cases of tuberculosis in our OPDs and personal clinic also. I'm sorry to say that we are not following, most of our colleagues are not following the standard protocol of diagnosis of the tuberculosis. We have already told that we have failed in the first phase, we have failed in the second phase, we failed when we adopted the alternate day regime, we failed in the initial phase of the RNTCP program. Later on, Delhi regime was started in our country. Initially, only AFB, sputum microscopy was available in our country, but now a number of different types of tests are available in our country. CVNet, TrueNet, culture, and sensitivity tests all are available in our country. But unfortunately, as already I have told, that the standard protocol of diagnosis and treatment is not followed by our colleagues. I want to give, I want to request all my colleagues and seniors to pass on this message to our colleagues and organize not only this state level or national level meetings, but meetings in the district level to sensitize our colleagues to follow all kinds of protocol. As already, Dr. Madhukar, what are you telling?
Sir, there is a question coming up in this session to you. Would you recommend uh, every physicians to have smear microscopy as well as sputum microbacterial culture test to every patient suspected to have pulmonary tuberculosis?
Sir, as already all of us know, under the national program, this is available. The sputum microscopy, TrueNet, CVNet is available in almost all the district level and some of the subdivisional hospitals. Culture and sensitivity test is required when you find a case, positive case of tuberculosis, microscopically confirmed case of tuberculosis, then only culture and DST is required. But initially, in all cases of presumptive tuberculosis, we must, and this is our responsibility, to advise these tests. That is the sputum microscopy, X-ray, and TrueNet or CVNet. This is, as already I have told, this is available in almost all district hospitals, free of cost. Any even private practitioner, private qualified doctor can send the patient to the different designated laboratories of their area for diagnosis and investigation and diagnosis. X-ray is also available in almost of the all the countries, all the district headquarters and the subdivisional hospitals. TrueNet have been, the services of TrueNet have been expanded in different areas, and now almost all subdivisions have been covered by TrueNet availability. So definitely, I would like to advise all the physicians, all the colleagues, if any case of presumptive TB is seen, first, first of all, sputum microscopy oblique this TrueNet or X-ray must be done. Only X-ray does not help, and it gives wrong diagnosis in most of the cases, as all of us are treating the cases of chest infection and other different chest diseases. We all know just on the basis of the chest X-ray, we should not confirm a case of tuberculosis in first phase. And even if the sputum microscopy is positive, immediately TrueNet or CVNet must be done, since chances of, or we are seeing a number of cases of MDR tuberculosis in our state and country. So in the first phase, we must advise sputum microscopy and TrueNet, and if required, the sample must be sent for culture and DST. And appropriate treatment must be given depending on the report of the culture sensitivity, TrueNet or sputum AFB.
Sir, there is another question coming up about the diagnostic obstacles in pulmonary tuberculosis. The question is there any condition where the sputum microscopy can be negative, but the patient is likely to have active tuberculosis?
Yeah, definitely. In that very case, if the sputum microscopy is negative, but there is high degree of suspicion of tuberculosis by clinician, we must submit the sputum sample for the culture and DST. That is most important. And since just on the basis of the hello,
yes, sir.
Hello?
We are listening to you, sir.
Yeah, that must be sent to the for the culture and DST. That may give positive result.
So the message has been very clear by sir to all of us that any patient with suspected pulmonary tuberculosis must have a sputum microscopy performed. And if it is positive, the patient should undergo CBNAT and culture. And in the conditions where you suspect a sputum microscopy to be falsely negative, subject the patient for the sputum culture, it is must. Sir, the last question about diagnostic obstacle in pulmonary tuberculosis to you coming up is, we have shifted our focus from passive case finding to active case finding.
Yeah.
What does that mean to all of us?
It means, as already we have seen, patients, even if we say that to a particular person that you are suffering from the tuberculosis, sometimes they say that, no sir, I am not suffering from TB. There is no history of tuberculosis in my family or khandan, or in the nearby family members. So, a number of cases of tuberculosis are hidden or suppressed, and they do not come for the treatment to clinician or the doctor. So in these cases, active case search that have been conducted time to time by the government of India, that is a must. And as per active case search, all persons who are in contact of the tuberculosis patient must be screened for the for active tuberculosis and must be given complete treatment after confirmation of the disease.
Thank you so much, sir. Dr. Rajiv, sir, would you like to please unmute yourself? Would you like to add up something about diagnostic obstacles in achieving the target 2025 in pulmonary tuberculosis? Sir, would you like to please unmute yourself first? Sir, would you like to please unmute yourself? You are muted.
Yes, for rapid and accurate diagnosis, molecular based diagnosis is must. If we want accurate diagnosis of tuberculosis, whether it is sensitive to rifampicin or not, we have to have the molecular based diagnostic process, and that is available in India at least is every district center in southern hospitals. This is available, and this is very nice. Before that, the diagnosis was a dilemma. If a patient was positive or negative in both condition, this was dilemma. But now it is rapid test appearing in every district. That is very important for diagnosing tuberculosis cases.
Thank you so much, sir. Welcome, Dr. Dipendra. We have just not with us, but we are moving to the second pillar, important pillar about of National Tuberculosis Elimination Program, and that is the treatment. We have Dr. Prashant with us, and he would like to discuss the obstacles, therapeutic obstacles in achieving the target 2025 based on a case. So, Dr. Prashant, would you like to please join us and present your case? Dr. Prashant?
I would like to say something about the treatment part. Actually, that is lacking from the part of ours. Most of the time, when we receive tuberculosis patient, they are mostly malnourished. They develop most of the time complication after starting ATT, and they do not complete their course. So that is the problem while we are getting more and more resistant cases, because leaving treatment before course, that is not good for curing the tuberculosis patient. And many patients miss their treatment due to adverse drug reaction, like acute gastritis, hepatitis, and so many complications, because all tuberculosis medicines are toxic, and government should incorporate these kind of patients. 11 to 12% of patients while starting ATT, they developed adverse drug reaction. So that is big quantity of the patient, and that should be at least admitted in government sector, and consequently their treatment should be supervised in hospital. That is necessary, because this is major part while patient stop their treatment.
Okay, Dr.
I would,
Dr. Rajiv, I want to add something. We have already discussed the diagnostic regime, diagnostic sequence, that we must conduct a sputum microscopy, and later on, as per present guideline, universal DST is suggested, and that is recommended. That's why all the positive patients must be subjected for the sent for the TrueNet or CBNet test for of the sputum to confirm the diagnosis of the rifampicin resistance, or sometimes the sputum AB is positive, but the CBNet or TrueNet is negative. That indicates that this may be a case of non-tuberculous mycobacterial infection. So all the as per present guideline, all the positive cases, sputum positive cases, must be advised TrueNet or CBNet for the confirmation of the rifampicin in the earliest phase and further treatment. Second part, you have already told that adverse reaction is one of the most important cause of discontinuation of the treatment, and malnourishment is the second most. As per I suggest, as per the guideline of the tuberculosis NTEP, all patients must be given supervised treatment by our health personnel or dot provider. They must be counseled regarding the all possible types of adverse reactions, and if any of the symptoms of the adverse drug reaction is reported, they must consult his medical officer immediately. Now, the facility of admitting patients with symptoms of adverse reaction in different hospitals is available, and even the drugs, separate drugs or individual drugs, are available under the program of NTEP to manage the cases of adverse reaction. Since in some of the cases, rifampicin, pyrazinamide, or any one of the drug or two of the drug are considered to be the producing the adverse reaction or hepatotoxicity. So now this is available in our program. Second thing, as you have already raised the question of this malnourishment, as per Government of India program, financial support is given to all the patients through the healthcare system. And here is our Commander of Tuberculosis Management, Dr. B.K. Misra sir. I welcome him. He will give more and more light on this very these benefits given to the patients under NTEP program. Welcome, sir. Dr. B.K. Misra sir, welcome. Dr.
Welcome,
Salim,
sir.
Dr. Dipender Rai, and Dr. Saket. Welcome.
welcome, Dr. BK Misra, sir.
Good morning, everybody.
We had very important questions related to the obstacles regarding achieving the target of 2025. We'll be coming to you within few minutes. But before that, I have a very important aspect to discuss with both Dr. Saket and Dr. Dipendra. Dr. Dipendra is working in a government institution. Dr. Saket is working in a private sector framework. A patient who is diagnosed with pulmonary tuberculosis, the CBNAT comes to be positive, detects Mycobacterium tuberculosis complex. Rifampicin resistance is not detected. The patient is started on ATT. As you know, the national survey has been conducted and it has been found that 70% of the patients prefer to consult the physicians first in the private sector. And this is true in India. And the patients do agree to continue the treatment or ATT in consultation with the private care physician. However, the patient doesn't respond to the treatment very well. The patient undergoes the collection of the respiratory specimen for the culture of microbacterial tuberculosis, and then the patient is found to have multi-drug resistant or XDR pulmonary tuberculosis. And now the patient is being referred to the RNTCP entitled hospital to undergo treatment of drug resistant tuberculosis. One of the very important aspects of the National Tuberculosis Elimination Program is prompt initiation of therapy in the drug resistant tuberculosis. Once the patient reaches to the designed hospital, they again sample the patient to confirm the presence of drug-resistant tuberculosis. And as you know that if it is a liquid culture media, it has to be minimum 42 days for the report to arrive, and then additional 20 to 30 days for the drug sensitivity test report to arrive, so almost 2 months. So don't you find it really important where there is a big controversy between the primary practitioner or primary care physician in the private sector who has diagnosed the drug-resistant tuberculosis, and the government sector where the patient is again subjected to reconfirm the diagnosis, and these 2 months of delay in the treatment of drug-resistant tuberculosis is already there with the patient. It is a very common practical problem associated with the primary care physicians dealing with the treatment of tuberculosis. So Dr. Shakir, first you. Dr. Shakir, would you like to unmute yourself? Dr. Shakir, we are not listening. I mean, would you like to unmute and keep your volume in the correct? Raise your volume somewhat so that we can listen to you, we can hear you.
Hello.
Yeah.
Okay. So thank you very much for asking me to join this webinar. First of all, thank you very much, Rajiv sir. And
we are unable to listen, Dr. Saket. I think you are not unmuting yourself.
I've done that, sir. Are you able to hear me now?
Yeah.
Yes, now we can listen.
Right.
Yes,
right, sir. Right, sir. So thanks very much. Thank you very much for asking me to join this meet. It's very nice to be.
No, we couldn't.
Still, you can't listen me?
We are actually listening to you. So, Dr. Dipen, would you like to check it from your side, please? And I would like request Dr. Saki to continue.
So this is a very important issue, and we are facing it day to day. And personally, what I feel, it's plain and simple wrong. I mean, program managers have to look into it, that why they are making patient run from post to pillar, and moreover, it's very, very callous. Patient has already received a diagnosis of MDR tuberculosis, which is a very, very shocking thing to accept. They have got a life-threatening infection. Now, the private practitioner who does not have means to treat MDR tuberculosis because he does not have access to the newer drugs is doing the right thing to referring the patient to a government center, DRTV center. But it does not make any sense that he has to undergo the diagnostic procedure once all over again. And it leads to all sorts of problems. It leads to unnecessary delay, patient losing confidence in the program. So I believe that the program managers have to look into it. I don't think so it's there in the program, but it's happening because people who are doing it are not sensitized enough. So I would like Dr. B.K. Misra sir to respond to it. That, I mean, is it really necessary to repeat the diagnostic procedure once all over again? Because getting, I mean, it's not easy to perform a diagnostic test in tuberculosis. I mean, you cannot perform bronchoscopy every other day. bronchoscopy, once it has been done and ball has been taken and ball shows that patient has got mycobacterium tuberculosis with or without resistance, it has to be respected. So I would really like to know someone from the program who is doing it. Is it really necessary to repeat the test all over again? And I think it's callous. The program has to look into it.
This question will definitely go to Dr. B.K. Mishra, sir. But before that, I would like to know what the experience is with Dr. Dipendra, who is working in the government institution, where you have to repeat the diagnostic test again to confirm the diagnosis of drug-resistant tuberculosis and thus delaying the treatment for almost 2 months for such kind of patients. Dr. Dipendra, please.
Silent करके
Dr.
I'm not
Dipendra,
able to
please.
hear anyone voice. I don't know what could be the issue with the audio part. I'm unable to listen anything.
Are you listening to me? Are you able to listen to me?
Am I audible?
Yes.
Yes, yes, you
Absolutely.
are audible.
Yes, you are audible, Dr. Dipender. There is no problem.
Am I audible to you, Dr. Dipendra?
Hello?
Yes.
I think Dr. Dipendra will have to check from his side the connectivity. And so I'm with this question, I'm moving to Dr. B.K. Mishra, sir. Dr. B.K. Mishra, sir.
Probably he is not here.
Sir,
Just I
Dr. Mohan Mishra, sir.
yes, just I
The
want
same
to
question.
same question. Just I
Yeah, of
want
course.
to add that as per the guideline after 2021, if the tests are conducted in the designated or standardized lab, then there is
accredited level lab.
then there is no need of repeating the test. That must be accepted, and drug-resistant tuberculosis treatment must be provided even on the basis of the report from the private sector doctor. But criteria is that lab must be accredited by the NTEP. First thing. Second thing, it is our responsibility, all private practitioners or government sector, that all the cases must be reported or registered in the NTEP. And now it becomes the responsibility of the district tuberculosis officer or CDO of the concerned district to follow up all those patients who are registered or NTEP. And as soon as the progress or is not up to mark on the all those patients must be subjected for the drug sensitivity test. And again, I want to repeat, as per national guideline nowadays, no need of repeat the test if that all those tests have been done in a standardized lab and the lab that is approved by the NTP program. Thank you.
So,
Yes.
so I think the message has been very clear to us that even
Two
if
lines-
yes,
two
Dr.
lines
Sarendra, sir,
from-
please.
Dr. Madhukar,
Yes, sir.
very rightly Dr. Mishra has pointed out that tuberculosis is one of the disease, one of the program in which time-to-time correction of problems has been done at programmatic level. And in 2021 guideline, it has been clearly mentioned that if the test has been done by national level accredited lab, because tuberculosis control program give accreditation to the lab for such kinds of tests. So if the test has been done by national level accredited lab, there is no need for repeating the test, and directly when it comes to government level in SKMC, there is our MDR treatment center. So we do not repeat the test in such cases and directly start the MDR treatment after doing pre-treatment evaluation. Pre-treatment evaluation is must, because liver function, hepatic function, every function should be evaluated before giving the MDR treatment, because they are toxic on most of the system. So this question is related with awareness of the program. So doctors should be aware about the timely changes in the guidelines, and guideline corrects itself almost as rapidly as a cardiology guideline or more rapidly than cardiology guideline. So it is a general phrase in our control program that nothing corrects as rapidly, change as rapidly as tuberculosis guideline. So this message should be conveyed to all the doctors and patients that test will not be repeated. If it has been done by a national level accredited lab. Thank you.
I'll come one by one. Dr. Shakir, Dr. Prashant, Dr. Razi. All of you seem to have some questions. So Dr. Shakir first. You seem to have a question to Dr. Sailendra.
Now we have raised the issue of accreditation of lab. That test is only valid if the lab is accredited by RNTCP or NTEP program. I totally accept that. I mean, we cannot accept substandard test and substandard cultures. But when it comes to gene expert platform, now it's no matter which the lab is, gene expert platform is going to be the same, whether it's a government center, whether it's a private center, and the sensitivity and specificity of this test are going to be the same. So why a patient who have got gene expert positive test and a gene expert report from, let's say, Lal Path Lab, some other private lab, gene expert platform is same, no matter where the machine runs, and the results of test and their sensitivity and specificity are going to be the same. So even these patients are being denied TB center, and that's very distressing. Now we have done the right thing. We are not diagnosing TB on the basis of MAN2 TB Gold. I have done a gene expert test. Gene expert test shows that patient has got rifampicin resistance. And now when patient goes to a government center, he is denied treatment and made to do the test again. Because somehow something, I don't know what exactly is being conveyed and by whom it is conveyed, but it's a constant problem. They are saying that Niche ID is not there, something else. So that's what I'm saying. I don't think so it's there in the program, but people who are doing running the program at the ground level, they are not sensitized enough, and they are denying because of some logistic issue, and program managers have to look into it, that this process is taken out. Otherwise, you cannot, if we are talking about TB control, and if you intend to achieve TB control, then you have to include private sector, which is the major stakeholder when it comes to health of country's people. Now, if you cannot exclude them, 65% of patients still go to private sector. In Bihar, maybe it's even more. So you have to partner the private sector and smoothen out the process of cross references, so that we can have better patient could have better experience, and they are not afraid of going to a government setup.
Correct,
Can I
Dr.
add
Shakir,
points?
your point will be taken. Dr. Sailendra, sir, would you like to reply to him, please?
Should I reply?
Dr. Sailendra, sir, please.
Dr. Dipen, this issue has been well taken in 2021 line. Private nursing home, if you provide the minimum necessary facilities for treatment of MDR, the government program will give you permission to treat MDR.
I think there is some
audio issue.
Yes,
I think
there is some kind of audio issue. Sir, Dr. Sri Mohan Mishra, sir, would you like to explain what Dr. Shakir is asking? All of us, the question he's putting.
Can I add points, Dr. Madhukar, if you allow?
Sure. I'm waiting for you to correct. So you can very well go ahead with your points. Dr. Dipen, please.
Yeah. So I am totally agree with Dr. Shakir's point. I think there is no difference between the gene expert perform in the private sector and the government sector would be different as far as sensitivity and sensitivity is concerned. But guidelines, those patients who are CB showing a rifampicin resistance, guideline doesn't do the gene expert again. If you're sending the sample, they are doing the LPA for the second line DST and first line DST, but they're not, I think, repeating the gene expert. So they are accepting probably the gene expert which is performed either in the government sector and private sector, to just identify the pre-XDR. So I don't think they're doing again the gene experts. So as far as culture is part is concerned, definitely the accreditation for the culture lab is required. The culture, because it is an exhaustive process and there are so many things, there may be a problem of contamination. So the accredited lab, as far as culture is concerned, so all the lab which are accredited by NTP for the culture, that should be used. So for the culture facility, I don't agree that that if it is performed in the private sector, that can be used. But for the molecular test, I think especially for the gene expert, we can accept if it is performed in the private sector. But again, for the LPS, second line DST, again, it should be performed only in the NTP accredited lab. Thank you.
Dr. Devender,
Yep.
I would try to highlight one thing. Okay, I just recently encountered one issue. I would like to raise two issues. Firstly, as a private practitioner, I am accepting that very notification is very poor in private sector, and we are responsible for that. But as a private practitioner, I always try to enroll all my diagnostic TB cases with Niksha or WHP. Recently, I have a patient, okay, from Buxar, 27-year-old male, and I have diagnosed him as a case of tuberculosis based on lavage bowel fluid report. Gene expert was positive, okay, and resistance was no detected intermediate, okay. So we wait for DST reports, okay, it will take 1.5 months. When it comes, we send this patient to one of our Apex Institute partner, and they denied this report, okay. They denied and they further plan for further bronchoscopy lavage. So unnecessary is this delay, and who is accountable for this delay of treatment, and consequently left this patient as a potential source to disseminate MDR bug to community. These are the how can you overcome this issue?
No. If you
We are
a-
frequently
you are a-
encountering this issue. Okay.
No, yeah, you are an expert in TB. You are designated an expert in TB, Dr. Prasad. If you are labeling the patient as TB, I think the TB center cannot deny. But probably they are asking to again send the sample for LPA for the DST, and then we can detect the pre-XDR in early stages. Otherwise, I don't think they deny for treatment. If you're recommending that this is the MDR basis on bowel fluid, so
They not denied.
they can't deny.
They did not validate that report, and they plan for further bronchoscopy and DST. And you can assume how much delay in treatment can occur for this. Okay.
Do you think that in the basis of that you can put the patient on MDR treatment, which is
No,
showing
I never
MTP
started
detected low
in
and
my clinic in my hospital. I never given any cases
So
of
both
MDR.
Dr. Dipen and Dr. Prashant,
yeah.
I
Can
would
I
like
chip in?
to finish this part of discussion with a note to all the delegates who are attending this panel discussion, that if you diagnose the tuberculosis,
I am frequently encountering this issue. Okay.
yeah, correct. Everyone
Dr.
is
Madhukar.
finding this. Everyone is finding with this, and this is why the discussion has been about this through. But I would like to what discussion has been going on, and what the conclusion I have withdrawn from all of your discussion is that all the physicians who has diagnosed tuberculosis, and if they want to have the culture performed and the drug sensitivity test performed, they should obtain the sample and should send this sample to the National Tuberculosis Elimination Program accredited lab, so that the delay in the treatment can be postponed, and the target 2025 as per the guideline can be achieved. So you diagnose tuberculosis fine, but if you want to have a culture and sensitivity test performed, send the sample to the National Tuberculosis Elimination Program accredited lab as per the guideline, so that the patient can find it easy to get the treatment.
Dr.
initiated.
Madhukar,
just one point, Dr. Madhukar, just one point. Program is not for one group of the doctors. We just thinking that this is a program for all of us, all of our Indians, all of the doctors. Only if you come out, then we can control the TB. So if you're saying that the patient from government sector and private sector, I think both are same. So that should be taken care. Otherwise, we will not achieve this target of 2025.
that way we should have to
Dr.
highlight
Madhukar.
the, problem of private partner mix strategy. Okay.
Now we should
already
now we
WHO
should
has
listen
adopted.
Dr. B.K. Misra on this
Uh,
issue.
Dr. B.K. Misra, sir, is with us. And
Yeah.
I have a very important question for Dr. B.K. Misra. The third the third domain of the program. Sir, as you know that most of the developed countries achieved TB control before the advent of curative chemotherapy and before the advent of the vaccine. Most of the developed countries. In India, we had the program which have extra emphasis upon the diagnosis, curative treatment, and prevention. But developed countries achieved TB control before the advent of all these things. So are we missing some domain of control of TB in India besides diagnosis and treatment and prevention? Dr. B.K. Misra, sir.
Thank you very much for asking me this question. I will respond to this question before this Deepankar has raised the fight between the they and us. So TB bacillus is on one side and the entire humanity. Am I audible?
Yes,
Yes, sir.
Yes, sir.
Yeah. So entire humanity, be the scientists, be the doctors, be the politicians, we all are on the one side, and on the other side is only Mycobacterium tuberculosis. So we all should follow the standards of TB care in India. And recently, this fight, we have become very much accustomed to this they and versus us, that delay in starting the MDR TB treatment because government institutions or the NTEP accredited laboratories do not respect basically the private sector lab. No, this is not correct. So once any patient is diagnosed by a gene expert or TrueNAT, we collectively say NAT, nucleic acid amplification test. So they come to the lab, and of course, the second line DST is done by the line probe assay, and also the first line DST is done by line probe assay, and some of the samples are taken for the culture DST, for the extended DST for linezolid and other drugs, or bedaquiline if it is supposed to be sensitive. So we have to overcome this issue of the delay and lack of confidence in the private sector this way. And Dr. Prashant, I will request you to send my number is 7759860705. You can give me a text message whenever you find any kind of difficulty. That much I can say. But I'm not going to take that all the patients are repeated the test. So this is not fair. Second question, an important question, that most of the developed countries could reduce the incidence and mortality of TB much before even the streptomycin was discovered. That is very true. So I would like to remind you the articles written by or the books of the Michael Marmot. So Michael Marmot, he emphasized the social determinants of the disease. So tuberculosis is one of the problem where we say that it is Mycobacterium tuberculosis. As such, Mycobacterium tuberculosis is very slowly multiplying bacillus. It is very, you can say, obligate aerobic bacillus that does not multiply in a media or a tissue where the oxygen pressure is less. So that way, only the 10% of the infected people, say if 40% of 25 to 40% of the people in Indian population is infected with TB, only 10% develop active disease. lifetime until unless they are HIV positive or taking some kind of immunosuppressive therapy or living in contact of microbiologically confirmed TB or so even the COVID positive they are. So this way. But social determinants with our population density, our family size, how many of us have adequate size of the room or the adequate number of the rooms. So when the home isolation, one of the very much important key component of COVID was envisaged. So the most problem with the home isolation was that 80% of the family do not have the separate toilet even. So in that context, social determinants, including the malnutrition, is gaining the importance. And the government of India right now, irrespective of the patient diagnosed in the public sector or private sector, they are offered rupees 500 per month at the rate of rupees 500 per month for the full course of treatment. But at the same time, in the private sector also, so except some of the patients who are having skeletal tuberculosis or the neurological tuberculosis, most of the time it is not it should not be more than 6 months. So this way it's going on, and we will have to come together and follow the standard tuberculosis care set by the Indian community of the physicians and surgeons, pediatricians. We should respect who else will come to rescue us. And we will bridge the gap only when have such opportunities like today we are having. I'm very much acknowledging the Dr. Prashant or Dr. Saket's question. As a program manager, I can say I'm not insensitive or careless. It is another matter that at least say 10% of the doctors are not notifying, which is very much mandatory that we should notify all the TB cases. So if you notify, the entire profile of the patient can be tracked and the public health action can be started at the very much earlier. So thank you very much for giving me chance that much. Thank you, sir.
Thank you, sir.
So my question is, this whole program is depend upon production of a sputum. Few patients are not producing a sputum, but even though they are drug-resistant tuberculosis, so clinician judgment is much more important. After all diagnostic tests, clinician judgment is important. That should also be considered, because most of the time, the advanced facilities are not there in remote periphery. So clinician judgment is also important.
Dr. Rajiv, I want to
Mr.
respond.
Mr. Rajiv, let me respond. Let me respond.
Okay.
Dr. Rajiv, your query is very important, but in this program, there is ample of space for your clinical diagnosis. But your clinical diagnosis should be based on X-ray and clinical feature, not on the basis of your lacking of necessary facility. This plea is not valid, because nowadays world is very small. A patient living in Muzaffarpur can have a test from Delhi in few days. So lacking of test facility necessary is not a valid plea. But if the patient is not producing a sputum, if X-ray finding is suggestive of active tuberculosis, if clinical feature of active tuberculosis is there, if all history and everything is suggestive of tuberculosis, you make the diagnosis, and in program, every person will give an anti-tuberculous no one will deny. So clinician judgment of clinical diagnosis on the basis of clinical feature and X-ray is valid in the program. Israel, now you may respond.
Thank you. Dr. Rajiv and
Yeah.
Dr. Saket, Dr. Prashant, all of us are seeing cases of tuberculosis daily in our OPD. I am very sorry to say that I have seen a number of prescriptions in my college OPD with streptomycin given in the first line of treatment. 5 or 6 drugs are given in the first line of treatment. Rifampicin, AKT3, AKT4 along with the levofloxacin and streptomycin is given. And there is never they have advised patient to go for the sputum examination. Just your clinical judgment is very important, but you have some social responsibility. You must not use or misuse the drugs. There is no need of giving levofloxacin along with AKT4 and streptomycin in the first page of treatment. It means you are considering this is case of MDR. Why not you are sending that very case for the culture and DST lab when it is available in almost all the district hospitals or district TB labs. Second thing, just I want to say that there sometimes repeated courses of tuberculosis are given to the patients just on the basis of the X-ray findings. All of we know that radiological changes persist for the whole life after the tuberculosis infection is over, and even if the patient is completely treated, there are chances of reinfection or recurrence of the infection. But in most of the cases, if completely treated and the regular sputum follow-up as per guideline of NTP is done, then there is chances of detecting the cases of recurrence or relapse in the earlier stage. But without, as we know that in cases of previously treated cases, the incidence of MDR is very high. So just on the basis of radiological finding, we should not give ATT in the to the patients. And as per different records, if only on the basis of radiological changes, ATT is given, in most of the cases, almost 70% of the cases, the diagnosis may prove to be wrong later on. So my request, your clinical judgment is not challenged by anyone. Everywhere in the program, as Dr. Salendar have already told, that clinical judgment have very important place in the treatment of the medical science. There is no problem, but we must exclude other things also. We should not give repeated courses of tuberculosis just on the basis of radiological changes in the chest X-ray. And if you give, then these are the cases where we are finding that sometimes the MDR is found in that very cases. So whenever it is possible, kindly suggest sputum microscopy and other things. There are so many methods. Dr. Saket is here.
His question was that a
1 minute
is not coming.
1 minute.
Is not coming.
Dr. Saket and Dr. Madhukar, Dr. Prashant, all are experts in the pulmonology. All they know how to collect the sample. They bronchial lavage, they have already discussed. There are so many methods for inducing the cough, and so we must try our level best to collect the sample properly. Otherwise, this is not a lame excuse that patient is not able. Even if you will give some simple measures, you will suggest, they can produce this sputum. There is no problem.
Dr. Mishra, I have a question.
Very nice, sir.
Thank you so much, sir.
Can I ask a question, Dr. Mishra?
Yes, sir. Hello.
Thank you so much, sir.
Sir, I have a question.
No, boli.
Dr. Prashant, you can raise your question if Dr. Mishra will be.
Although I am trying my best to notify all the TB cases, but still I am not doing that. I am accepting it. Okay? So how can I overcome it? Any system to evolve that we can notify 100% of our patients?
Yes, definitely. Already Dr. BK Mishra, I have told you that his phone number is there, And if you go to the website of the NTP, there is email of all the patients, all the district tuberculosis officers, and even at the STO. You can directly notify on that very case. And if concerned DTO or CDO do not respond, then kindly report to the nearest medical college or STO, Dr. BK Misra, sir.
Sir, my concern is that it should be on the administrative basis only. Okay.
Hello.
Only clinician can't notify all the cases. Sometimes we are very much busy. Okay, I'm trying to notify as much as possible, but at hospital level, at administrative level, there is some system that they must notify you. Okay?
Dr. Prashant, I would not take this as an excuse. Every TB case must be notified, and this
you should know Nischay portal.
I have it. I have Nischay portal. I am notifying all the patients.
Yes, every cases.
Dr. Prashant, if you are getting problem, you are busy practitioner, you can give this very responsibility to your any of the staff of the hospital or the clinic, even the receptionist. They are sitting on the computer, they will notify. There is no problem.
Because it's our responsibility.
You may notify directly on WhatsApp to your DTO, concerned DTO. On WhatsApp, the patient name and patient mobile number. We have created a system in our Muzaffarpur that the doctor of private practitioner, they can notify TB cases directly on WhatsApp of district TB officer, and they will accept it. And further, by doing further queries, they will get further information about the patient.
Yes, those patients who come to us diagnosed, certainly notify. But sometimes in OPD, we used to see many patients. We send a sputum.
Dr. Prashant, I would like to interrupt
and that
you.
patient lost in follow-up. And
Dr.
after 6 months, 5 months, they come that that report was positive.
Dr. Prashant, I would like to interrupt you. Dr. BK Misra has to say something to us.
Dr. Prashant.
BK Misra, sir, please.
Yeah, please.
This is something notification. It is mandatory since 2012, but there was no punitive action. And I was in a view that one should not start like PCPNDT Act, because the TB problem has been for millennium. And so personally, I do not recommend any kind of punitive action. But you must be aware of the fact that more and more TB patients are being treated and diagnosed by the private sector. And it should reflect in our indicators also. So in Bihar, right now, we have engaged patient provider support agency in 14 districts. So Patna, Gaya, Nalanda, and many districts like Bhagalpur, Katihar, Munger, Begusaray, Samastipur, many districts. And since June 2000, 15 districts, yesterday we opened the technical bid. So 29 out of 38 districts, we will be paying at least 2,495 rupees to the agency. And these agencies are mapping the private physicians, they are talking to them, and they are engaging the compounders of the same physician, so that the TB notification should be 100% notified from the private sector on the Nischay web portal. And then the rest of public health actions, like taking the bank account, contact detail of the people who are living with them, close contact and the household contacts, everyone. So this and the payment to the beneficiaries in the Nischay. So it will take time, but Bihar is one of the state where because of the out-of-pocket expenditure and the nature of the poor health system in the government, I acknowledge on the public forum also. So it will take time, but the immunization, whether it is a COVID vaccine or the vaccine our children get for the routine immunization, and education of the medical education, I mean, so is always beyond the question in the public sector. The same way care of the HIV positive people, the care of the TB patients is at least 5 times better in the public sector. People depend. So, but unfortunately, they come very much late, and the system is not very much quality sensitive. So the people who are going to Paris hospital, they will definitely find better hospital care, nursing care. But whether the diagnostic algorithm or the treatment protocols are followed as per the international norm, that is always a question of evaluation. And I'm assuring you that I have talked to Dr. Madhukar Pai. He is a professor in McGill University, Canada. And many people that we are training the structured patient, and they will go to your private sector clinics and simulative X-ray, everything, and we will have understanding why private sector is not aware of the international standards, and they are not following the practice. So we want to compare when the Dr. Zarif F. Udwadia of the PD Hinduja Hospital, he published an article where the only 6% of the physicians of Mumbai were prescribing correct diagnosis, correct treatment in the correct dose after correctly identifying the full TB cases. So we want, but that time has passed more than 5 years. So now we have to evaluate. So time will tell how much closer public and private sector has come. Time will tell that how can we accomplish TB elimination by 2025 without vaccination. But certainly the preventive management of TB infection that was previously called latent TB infection. So we are going to introduce at least in 10 districts of the Bihar, and let us learn together. We will be looking forward from Dr. Saket and Dr. Prashant. On the personal term, I will come to your clinics to visit you and seek your wisdom in this regard. That is fine. Thank you very much.
Thank you so much.
Just one question to Misra sir.
Yeah.
Can you make a comment, Dr. Madhukar?
Yeah, so we have 8 minutes left.
Yeah, we are finishing. Yeah,
before we can take your questions, I have a question from the audience side to Dr. BK Misra sir. I should take that question first, and then
yes, sure.
If the time permits, we'll take the questions from your side. Dr. BK Misra sir, the question is, in the COVID-19 pandemic, the notification rate of tuberculosis in India has decreased by almost 50%. Do you agree with this? And if it is so, how are you going to achieve the target 2025 in the context of COVID-19 and tuberculosis?
Very much a correct figure you have quoted, but in Bihar, at least it is one of the state where we did active case finding, and we tried our best that our notification should not fall much. And Bihar is one of the state where the notification has not fallen as comparison to the India. So, and again, I give credit to the private sector that PPSA districts, they have maintained the case notification from the private sector. But the challenges were definitely when all the laboratory technicians, STS, STLS, were either engaged in the diagnosis and the treatment and the containment activities of the COVID. That was that continues to be the challenge even today.
That's great news for all of the physicians practicing in Bihar. Dr. Saket and Dr. Nipen, both of you, please put up your questions as fast as you can, and I would request Dr. BK Misra to answer it before the session ends.
Yeah, just one question to Misra sir. What could be the reason for our program is lagging in our state? And I have seen we have shortage of manpower at the different level, especially at the lab level. We are shortage of this cartridge of this gene expert machine everywhere. So how can you, sir, achieve all these things? How can you tackle all these things? And then we can say in the private sector that you can send the sample to this government lab. We are already short of many things. So how can you just counter this, sir?
And Dr. Saket, your question too, so that Dr. BK Misra sir would address the answer, address both the questions together.
So we have been talking about public-private partnership. Now, what I understand that under an TEP program, there is a provision that private practitioners can have a linkage with program. And under that linkage program, they can start prescribing treatment for even DR tuberculosis. Now, why I want to say this, we are talking about tuberculosis elimination. Now, elimination won't be possible, in my personal opinion, unless and until private sector is actively participating in the program. Now, what is happening right now, that people like me who are trained to treat tuberculosis, people like Dr. Prashant, Dr. Madhukar, and many other private practitioners who can treat tuberculosis are not treating DR tuberculosis. And those who are treating tuberculosis at DRTV centers are MBBS guys who have got training for 15 days, 30 days, maybe under supervision of few senior people, but most of the time they are the first interface of program. Their understanding of tuberculosis is very, very minuscule. Their understanding of chest X-ray, respiratory medicine is very, very minuscule, but they are the ones who are treating the bulk of the DRTV, whereas people who could actually treat, people like me, many other respiratory physicians, many other physicians who are interested in respiratory medicine, they are excluded from the program. So what I believe that you should tell me that how I should be able to link with the program, and it should be actively promoted by the state TV cell and state TV officer. But so far in last 2-3 years, hardly ever anybody has communicated me even once. And I think the feeling is same. I think both of them will say that there's hardly any communication between from the program and private practitioner, between program and private practitioner. So will you please address, sir?
Dr. BK Misa, sir, again the question is about the private, public, and the government sector partnership
I
strategy.
Want to treat DRTV. I don't treat because it's very costly. Patient cannot afford and he can't get the treatment. I want to be partner of program. I want to participate and contribute, but I'm not allowed to do so because of various reasons. So I want the state TV cell to come to me, allow me to join the program. That's what I want to say. Hello.
Yeah, Dr. BK Misa, sir, we are able to listen to you.
Now the
I think we have 2 or 3 more minutes with us.
Yes.
And within 3 minutes, we are going to finish this panel discussion, beautiful panel discussion. So Dr. BK Misa, sir, would you like to answer these 2 questions before we can end this session?
ये क्वेश्चन का तो आपने आंसर खुद दे दिया कि the answer partnership I mean cannot happen when it is extensively drug resistant TB, or even the bedaquiline and delamanida is not responding to the patient's need. So partnership happens when the person has a cough, and then we should say that it could be TB. If we are diagnosis TB, then we should say it is a drug resistant TB, at least the INH resistant TB, until unless proven otherwise. So that much. Again, the specific question respond to the how we managed CBNAT cartridge shortage. Of course, government of India was supplying CBNAT cartridge, and all of a sudden they said that the state governments will be procuring it, and it is a proprietary item. So one cannot purchase proprietary items for 6 crore rupees until unless cabinet nod is there. So there was a delay. But how we responded here, that a TrueNet machine, it is another mobile lab product, that a TrueNet lab machine, earlier 37 Duo machine, and then at least 134 TrueNet Quattro machine has been distributed to the districts, including we have sent it to IGMS, PMCH, and many medical colleges, and the AIMS also. So
no, we didn't get, sir.
Yes,
we didn't get, sir.
Also. No,
sir, we didn't get. No, sir, I'm in charge of that, sir. I'm knowing all the things.
Which medical college you are talking to?
AIMS, sir, AIMS Patna.
AIMS. So go and see when it was received. And another.
No, it has not received, sir.
No,
it has not received. It yet to get, sir.
Okay, I will respond to your, give me
Okay,
your
okay.
call. My number is there in the WhatsApp. So give me call. I will take immediately. Okay, we'll
Okay,
send you
thank
the
you.
receipt also. Okay, so next question. But I'm not a person who can lie at this stage. So my age is above 60. Okay, please don't take this way. So this is one thing.
Yep.
If you have not received the kit, we will ensure that you should receive the kit. Machine is there, or if you have not received the machine, we will send the machine today, even today. So I cannot this one. So, but the problem is not solved. What Saket told me, they want to come forward. So I will be happier that whenever a drug resistant TB case or anyone who goes to private sector, you manage the adverse drug reaction, but never tell them that this medicine is wrong. You know that the medicine is not wrong. The diagnosis in the government sector is done by MBBS. I am also MBBS. I have not done I could not complete my post-graduation. That much I can tell you. But since 1999, I have been associated with TB. And I invest quite at least 3-4 hours every day in reading the journals and the recent things. So give me a chance, and we will be looking to have a discussion at the different forums with people like you. That is the only way when we can come closer, and the gaps will be minimized to the greatest extent. And that is very much required for overcoming the obstacles for TB elimination before 2025. Thank you very much, sir. Thank you.
Thank you so much.
Please,
I cannot
please.
take more questions now. I'm going to end this session.
One line I would like to add. One line I would like to add, that in government sector, in DRTB center, a single doctor who is in charge of DRTB center as a senior medical officer, or most likely most of them are MBBS. They only do not treat the DRTB case. There is a DRTB committee, and in DRTB committee, all HOD of all departments are present, and a cardiologist. It is not practically in every case, but this is the guideline that in DRTB committee there should be a cardiologist, whether private practitioner, part-time or full-time. So government guideline is not at fault. We are most of the time at fault that facility are not available as per guideline. So guideline is not fault. We may be at fault.
Yeah, thank you.
A person may be fault, an individual case may be at fault.
Thank you so much, sir. I do agree that the knowledge and credentials has to do something is not actually associated with the kind of degree you have. That is entirely different issue to discuss about. But I thank all of the eminent panelists to have a beautiful panel discussion over a topic which was quite difficult to moderate upon. I certainly agree upon this. But before leaving this panel discussion, I would like to have what take-home messages that came for the audiences to know, so that we all together can make our dream come true to end this tuberculosis by 2025, and hopefully we will be able to achieve this. The number one, in any case of suspected tuberculosis, try to have a sputum microscopy performed. Try to know the limitation of sputum microscopy and know the conditions where it can be negative. And the conditions where it can be negative must perform the culture sensitivity at the outset. If the microscopy is positive, perform the CBNAT and culture drug sensitivity test together. If the patient has to go the culture test for the ease of the treatment and for the prompt initiation of the treatment, send the sample to the accredited lab so that the treatment cannot be delayed at the designated institute. And third one, you must notify all the TB cases so that the dream of 2025 TB control can come true. And the last one, we must partner with the National Tuberculosis Elimination Program to achieve the dream. And if you find it difficult, to partner with them. The persons enrolled with who is actually looking after the tuberculosis elimination program in Bihar are with us. They have their phone numbers and contacts. We can directly contact them in case we find any difficulties. Thank you, all the brilliant panelists, and thank you so much to have such a wonderful discussion. And I'm sure that the people and the audiences must have been benefited by listening to us. Thank you so much, and thank you so much for it.
Thank you, Dr.
Thank you, Madhukar.
Thank you.
For the next session, moderator is Dr. Samrendra Kumar Jha, and he will initiate the lecture of Dr. Sudhir Kumar sir, and the next lecture by Dr. Sailendra Kumar sir. Sir, unmute, sir.
Thank you very much, Dr. Chaudhary. It's my pleasure to be associated with BAPICON Chhapra. I have been given August task of introducing the brilliant speaker of Bihar, Dr. Sudhir Kumar, who will be dealing with biologics in the treatment of asthma. Dear friends, two things that I would like to speak upon is that never get tempted with the latest treatments. We know that with the advancement of science, we have come to know the different levels of stages where we can intercept the progression of asthma. Pathophysiology of asthma has been deciphered, but not a single day is such where we can say that our knowledge is perfect. We are pandit for that very day. The next very day, some changes may occur. So, with the advancement in the field of biologics, which is being used for more than 15 years now, omalizumab, and so many biologics, benralizumab, and so many indications that will be dealt with. Dr. Sudhir Kumar, a brilliant speaker and clinician over here. Not wasting much of our time, I will hand over the mic. I will request Dr. Sudhir Kumar to proceed with his lecture.
Dr. Sudhir, you just unmute yourself. Yes. Dr. Sudhir, phone करो. इस पे भी जुड़े हैं लेकिन अनम्यूट नहीं कर रहे. हाँ वो करता है, बोल दिया ना, वो आई नहीं.
Probably some issue with internet.
What we should do, Dr. Sailendra is there. So Dr. Sailendra's talk will be.
But his topic is different one.
Dr. Shamrendra sir, by the time Dr. Sudhir join us for the discussion.
Yeah, that is what I also wanted to tell you, by the time he joins, we should talk something about biologics. So, Madhukar is available.
Sir, I'm not, sir, I won't be talking about biologicals now in asthma, but I have a very practical question to you. You are working in a government institutions. You are seeing thousands of asthma patients in a week. You know, our institutions do cater the needs of the population which is poor, and you also know the cost of the biologicals in treating the asthma, even if it is a severe asthma.
Exactly.
So, how feasible do you find it to talk about biologicals in asthma to with the physicians who are working in the private sector on a large basis?
That is what I hinted at in the initial of my talk. Actually, biologics is needed only in 5% of cases. 95% cases can be dealt with very well if we take the proper history and examine the patients, and we rule out the possible causes which can be dealt with at a very cheaper cost. And since we are a poor country, we cannot afford such a costly treatment to our populace. And since this is restricted to the biologics in asthma, it will not be proper to deal with other aspects. But prior going to biologics, proper investigation, absolute eosinophil count, sputum, blood, everything should be done. And the history where patient is working, if the patient is working in paddy fields, we must rule out helminthic infestations and all. That is major cause of asthma in our cases. And to detect which type of asthma is going to be held by biologics, we will have to know the different types of phenotypes. And that is different phenotypes are there. And in that rule, we will have to point out certain types of asthma that is going to be held by biologics. That one endotype type 2, T2 high. That is the subgroup of asthma that is going to be relieved by biologics. T2 low is not going to be helped more by giving biologics. In that case, we will have to give corticosteroids, and if need be, bronchial thermoplasty is given in that case. Biologics is of no use in that subset. And in that group, macrolides, azithromycin is useful. And restricted to the T2 high group.
Dr. Rajiv sir, I would like to interrupt you, sir. Dr. Rajiv sir, can you find if Dr. Sudhir sir is ready?
Okay.
We are consistently calling him, but his mobile is switched off.
So, Dr. Shamrendra sir, do you find it feasible?
Yeah. Dr. Sudhir has appeared, and now he has come.
Our pleasure.
Yeah. Dr. Sudhir sir. So well, we are waiting for you.
Sir, yeah. Dr. Shamrendra sir, are you looking forward to it that is there any plan for the government to make biologicals free to the patients for the severe asthma in government institutions in the near future?
Since cases are very few, I said only 5% cases need biologics. Omalizumab is quite old, 15 years back it was started using it. So probably cost of this is some group of section may afford. But you know, we all see social media and news. If for a child IONS, one can contribute crores of rupees, I think our popular government can afford some fund for very needy persons. I don't have any doubt in the leadership today. If need be, this may be made available to our hospitals also. But newer omalizumabs quite costly, and it is time when only time will tell that what is happened.
Thank you so much, sir. Has
But
Dr. Teresa
inputs
joined
are
us?
from your side. You're a brilliant pulmonologist. You have worked in such high institutions, and we feel elated that you were also attached with our Patna Medical College Hospital, and you are a very updated person. You add something.
Sir, before that, I would like to know if Dr. Sudhir sir is ready with his slides to present.
And one caution, I'm in hospital. Anytime my internet may give me this. So if I disappear, don't think that it's my deliberate.
No, you cannot disappear, sir. You are moderating and chairing this session.
I have taken permission from my HOD for this session.
Yeah, that's wonderful. But you have to be here. You are actually the pillar behind this session. Dr. Sudhir sir, are you ready with your slides?
Hello.
Yeah, we can see him on the screen.
Sir, actually, the session is of Dr. Sudhir Kumar, pulmonologist. He is from Patna, I think. But I am
If
from,
Dr. Shailendra is available with his slides, he can proceed with his topic.
right. I am from Bokaro, and I am
diabetics. He is a brilliant speaker.
Sir, session आपका जा रहा है. Already going on. Your session is already going on. आपको 12 से 1:30 नहीं.
लॉगिन ओवर सब हो गया है, तो मेरे को म्यूट करने का प्रॉब्लम है. हेलो.
Dr. Razi, can we go for another session, the session just after the Sudhir session? So
yeah, definitely, because time is much more important. Dr. Shailendra is available, so why not we should start with Dr. Shailendra. Meanwhile, Dr. Sudhir will be ready. Dr. Shailendra, sir.
Yeah. If Dr. Shailendra is ready with his slides, there is no harm in going with his lecture, because it is time factor. Everybody, if you lag behind, things will be.
Yeah, definitely, sir. Definitely. Another lecture will be.
So, another speaker is Dr. Shailendra Kumar, Associate Professor and Head of the Department of Pulmonary Medicine and SKMCH, Muzaffarpur. And incidentally, the chairperson of API Bihar too. And he is a versatile, genius personality. He is master in many subjects. Apart academics, he is a musician internationally. What do you say? Acclaimed.
वहाँ पे कोई जा सकता है क्या? हमको तो दिक्कत हो रहा है लॉगिन में बड़ा करना।
And this topic is very interesting, which is required in day-to-day practice. Every day, patient will come with cough and he will say, no, I don't have kidney ki bimari. But once you go for HbA1c, you will find that is diabetes. And unless until diabetes is controlled, TB is not going to be cured. So where are you, Dr. Sharan?
Good afternoon, everybody. First of all, I would like to thank the organizers, organizing chairman and organizing secretary for giving me the opportunity to speak in this prestigious platform of BAPICON 2029-21 at Chhabra. Honorable Chairperson, sir, respected seniors, and dear colleagues. My topic is managing tuberculosis with diabetes. We know that management of tuberculosis is now a programmatic subject. Government of India takes care of every aspect of tuberculosis management, right from free drug supply to nutritional support, free investigation, and everything free. So here, programmatic management is understood in my topic. But at the very outset, before starting my presentation, I would like to remind you 2 or 3 things. You all know it, but I would like to remind again and again. First, tuberculosis is a notifiable disease. So it is our legal as well as moral responsibility to notify each and every tuberculosis disease which we treat, whether at government setting or in our private setting, and make others health service provider to aware about the notification and importance of notification. It is our duty also. Second, tuberculosis elimination program is running in our country with the support of WHO and other international organizations. And we are committed to eliminate TB by 2025. But we are lagging behind due to many factors, due to awareness factor, awareness amongst mass about the tuberculosis and tuberculosis treatment, awareness among health personnel, and up to some extent, poor resource setting and poor manpower management or manpower. Thirdly, tuberculosis is the only disease which is totally covered by national government. So every tuberculosis case must be searched and treated. But among so many hurdles, associated comorbidity with tuberculosis is an important hurdle which very adversely affects the outcome of tuberculosis treatment. Among those, diabetes is very important. And our country, India, has the second largest number of diabetes cases after China. At present, there are 80 millions of diabetes cases in our country, and about 2.6 million tuberculosis cases has been estimated in 2019. So this unhealthy relation of tuberculosis and diabetes is by chance also due to its large number, but there are physiological basis and clinical basis for this unhealthy association. And in WHO Global Tuberculosis Report 2019, it has been stated that about 10% of TB cases globally linked to diabetes. It has been observed that diabetes accounts for 20% of smear positive tuberculosis. So smear positive more and more in diabetes cases. Increase in diabetes mellitus prevalence in India is an important obstacle in reducing the incidence of TB in India. Several recent studies suggest that diabetes mellitus increases the risk of developing TB by 2 to 3 folds. In a recent Indian study, prevalence of diabetes in tuberculosis patients was found to be around 13%. So tuberculosis with diabetes needs special attention. How they affect each other? The basic mechanism is this: diabetes mellitus has weaker immune system, so more and more latent TB converted into active tuberculosis cases. We know that India about 40% of the population are affected by latent TB cases, and latent TB has 3 fates: either it heals by itself, or it may fulminate and causes tuberculosis of any system, or it may remain latent for years and years. And when immunity depresses, it becomes active tuberculosis cases. So latent TB activation is the most important source of increasing the incidence and prevalence of tuberculosis in India. Diabetes is complicated by presence of any infectious disease, and tuberculosis is one of them. Hyperglycemia favors the growth viability of tuberculous bacilli, and increased availability of glycerol and nitrogenous sulfides, which adds to the growth of tuberculous bacilli. TB is associated with worsening of glycemic control in diabetes mellitus. Diabetes can lengthen the time of sputum culture conversion, so theoretically it could be the cause of development of drug-resistant TB. Likewise, TB may provoke hyperglycemia and may result in overt diabetes mellitus in susceptible persons. So, clinical spectrum of TB is very adversely affected by a diabetes mellitus, right from clinical presentation, which is more aggressive, increased incidence in elderly, male preponderance, prolonged duration of fever, and more significant weight loss. So whenever we see more significant weight loss in a tuberculosis subject, we should always suspect for diabetes. A sputum examination, sputum positive cases are up to 5 times more in diabetic cases, more infective, higher pre-treatment bacillary load. Culture conversion time is lengthened by more than 2 to 3 months. Chest X-ray, more and more fibrocavitary lesions are found in diabetic tuberculosis cases. Frequency of fibrocavitary lesion in both upper and lower zone is more in diabetic subjects. More often, lower lung is affected in tuberculosis diabetic subjects, and more often, multiple fibrocavitary lesions are found in tuberculosis who are diabetic also. So these are results of some national as well as international studies and published in JAPI 2009. So how to tackle? In 2009, the government of India has launched an integrated national program for prevention and control of cancer, diabetes, cardiovascular disease, and stroke for addressing these issues. A screening, diagnosis, and treatment of diabetes has been incorporated in RNTCP, now it is NTP. A screening of tuberculosis for diabetes mellitus, who should be screened? Ideally, as per WHO and International Union Against Tuberculosis and Lung Disease, every person who has diagnosed diabetes or at the time of diagnosis should be screened for diabetes mellitus. But this is not feasible in our country due to resource poor setting. So, in selected and targeted population should be screened. Those above 40 years of age and above, those overweight or obese, those who have family history of diabetes, those who are alcoholics, those who have history of previous gestational diabetes mellitus or previous pre-diabetes mellitus. These persons must be screened at the time of diagnosis of tuberculosis. So these are the algorithm for diagnosis of diabetes mellitus in tuberculosis patient. And what should be timing of diabetes mellitus screening? Ideally, it should be at the time of diagnosis of tuberculosis, at the time of registration, every patient should be screened for diabetes mellitus. And this is the ideal time, but it has certain disadvantage. Chances of false positive diagnosis of diabetes mellitus has increased due to stress-induced transient hyperglycemia. However, this transient hyperglycemia also needs treatment. But after that period, the screening for diabetes mellitus has disadvantage more and advantage less. So in our country, in this program, the screening is done at the time of diagnosis and registration of a tuberculosis. These are the threshold and cutoff points for diabetes mellitus or pre-diabetes mellitus. As usual, there is nothing new in tuberculosis diabetes cases. For postprandial equal to or more than 200 mg per deciliter, fasting equal to or more than 126 mg per deciliter, and HbA1c more than or equal to 6.5% is diagnostic of diabetes mellitus. Whereas fasting more than 140, fasting more than 110, postprandial more than 140, and HbA1c in between 6 to 6.4 is diagnostic of pre-diabetes. How diabetes mellitus affects response to TB treatment? Sputum has been conclusion of various studies. Sputum bacterial conversion delay up to 2 to 3 months. Patients becomes sputum negative more late. Adverse drug reaction, diabetes mellitus is associated with higher risk of hepatic and renal side effects of ATT. Also overlap some GIT adverse reaction between oral hypoglycemic agent ATT, especially metformin and rifampicin, adversely affects TB treatment outcomes. Does TB causes hyperglycemia or diabetes mellitus? Yes, TB causes hyperglycemia, but it does not cause diabetes mellitus as per definition. So, stress-induced hyperglycemia may be a factor after diagnosis of TB. Some ATT drugs are known to causing hyperglycemia. For example, isoniazid, which adversely affects the secretion and effect of insulin. So it may cause transient hyperglycemia, but that is not diabetes mellitus. So diabetes mellitus per se is not caused by tuberculosis infection as such. Management of diabetes mellitus in TB patients, some general principles that are same as management of diabetes mellitus in non-tuberculous subjects to reduce the short-term and long-term complication of diabetes mellitus. That is our basic aim. Lifestyle counseling, that is diet, weight loss, physical activity, smoking cessation, and avoid excess alcohol. Glucose lowering drugs, oral hypoglycemic and insulin are basic drugs. Measures to reduce the cardiovascular risk and associated complications. Antihypertensive, lipid lowering effect, antiplatelet drugs, diabetic feet, and eye complications. So, management of cardiovascular risk factor of diabetic factor is also an important thing while managing a case of tuberculosis, diabetes with tuberculosis, because more and more patients get complicated or may die due to diabetes-related complications than tuberculosis-related complications. So diabetes-related complications should be monitored in a timely manner in programmatic management. This is the management of diabetes by ADA guideline 2021. This is ideal situation, but while managing tuberculosis with diabetes in programmatic setting, this ideal situation is not available. So these ideal things cannot be done in each and every case. So our target of monitoring, ideally HbA1 should be less than 7, but some guidelines suggest that HbA1c less than 8 and fasting blood sugar less than 180 mg is okay. Use of insulin ideally requires SMBG, and it has some drawbacks also. The insulin is not used in each and every case of tuberculosis with diabetes. It is used in a specific situation. The benefit and potential risk and cost of additional effort to achieve more stringent glucose control and reach the accepted target is currently unknown. This is oral hypoglycemic and anti-tuberculous drug-drug interaction. Metformin has clinically no pharmacological interaction with anti-tuberculous drug. Rather, it has a weak anti-tuberculous activity also. And now there are many studies in which metformin had been used as anti-tuberculous drug. But the side effect of isoniazid, especially gastric side effect or renal side effect of aminoglycosides may have additive effect with metformin. Sulfonylurea has important pharmacological interaction with rifampicin. Its blood level, many sulfonylurea, especially glimepiride, gibulide, glipizide, blood level is reduced by rifampicin because they are both metabolized by same hepatic pathway. So more and more dose of sulfonylurea is required while treating diabetes with tuberculosis. Serum concentration of glimepiride is increased by isoniazid. Insulin has practically no important drug-drug interaction with anti-tuberculous drug, but it is very notorious for causing hypoglycemia, and hypoglycemia in setting of tuberculosis may be problematic. So insulin and diabetes mellitus, insulin is the third choice in programmatic situation, except there are some compelling indications for use of insulin. If patient is taking insulin prior to TB, severely sick and hospitalized patient, not controlled with OHA, body tissue loss needed for increased enapolin, patient is severely cachexic, pancreatic hypofunction, liver disease. In this situation, insulin should be used. Otherwise, insulin should not be used in each and every case of TB with diabetes. Following precautions must be taken while using insulin, because in initial phase of intensive phase, more and more insulin is required because diabetes control is very poor. But as soon as the intensive phase is finished or basic infection is controlled, insulin requirement falls out, drops out drastically, and that is the time when fear of hypoglycemia is there. So close monitoring during initial weeks, initial few months of treatment of tuberculosis, hypoglycemia, because hypoglycemia may occur. Newer insulin should be better to be avoided, but few societies like American Society of Clinical Endocrinology states that newer insulin has predictable effect, and so it should be used in treatment of tuberculosis with diabetes. Frequent visit to diabetologists should not be promoted, so patient education and SMBG of crucial importance. So now to sum up, TB and diabetes are very closely associated and they adversely affect treatment outcome of each other. TB affect treatment outcome of diabetes, and diabetes affect treatment outcome of tuberculosis. We should consider drug-drug interaction while treating TB with diabetes with oral hypoglycemic agent. Anti-tuberculosis itself causes hyperglycemia, and stress-induced hyperglycemia is present in many cases, which disappear later on after a few months. TB patients with pre-existing diabetes have longer sputum conversion time than non-diabetes, so probably needs longer duration of intensive phase, and in few countries it is being followed. OHA metformin and sulfonylurea is the first choice in the programmatic management of diabetes tuberculosis. Insulin should be used in a specific situation where there are compelling indications. Insulin requirement declines rapidly after first initial phase of 2 months. Thank you. Thank you very much for patience hearing.
Dr. Sudhir has appeared. Dr. Samrendra.
Yeah.
Yeah, he has appeared.
Acha.
Yeah, I've joined. Thank you. Am I
Yes,
audible? Am I first audible?
Yeah.
Thank
Yeah.
you. With the permission of the chair, Dr. Samrendra, can I start my talk?
Yeah. Much awaited, Dr. Sudhir.
Thank you. Sorry for the interruption, but it was not my mistake. It was the mistake of, the technical person. Okay.
Yeah.
We all know you have already introduced the topic that biologics are basically the monoclonal antibodies against the relevant cytokines which are involved in the inflammation of asthma. So when coming exactly to the question, who are the patients who needs biologics, or who would get help from the biologics? These are those patients who are on step 4 and step 5 treatment, and despite optimal treatment these patients are not getting the relief from the asthmatic medications. So these are the patients who are probable candidates for biologics. But before going for the biologics, we must rule out certain conditions like associated comorbid conditions. We must confirm the diagnosis. We must rule out the alternative diagnosis. We must control the comorbidities which are associated with the patient. Also, we must ensure the inhalation technique. We have also to ensure that the patient has the allergens avoidance is to be done, and that is identified, and as far as possible the patient is able to avoid the allergens. So these are the few steps before we go for the selection of biologics in a patient. So now, why biologics? Biologics are at present against the cytokines which are of Th2 high airway inflammation. Asthma is a heterogeneous disease, and there is a spectrum of in the individual spectrum of from Th2 low to Th2 high airway inflammation. If you see this figure, you can see that around 30% of the patients definitely lie into Th2 low type of inflammation, whereas around 60 to 70% lies into Th2 high inflammation. Now, in Th2 high inflammation, airway obstruction, remodeling, and response to ICS is very high, whereas in Th2 low inflammation, exactly opposite happens. The response is also low. So once we have understood that there is Th2 high and Th2 low population of severe asthmatic patients, then we need to know what are the prominent inflammatory type of cells which are involved in Th2, and what are the relevant pathways, what are the approved biologics in this. So in Th2 high, the prominent inflammatory cells is eosinophil. The relevant pathways that we target is interleukin 4, 5, 13, immunoglobulin E, and thymic stromal lipoprotein. And we have got 5 approved biologics in this: omalizumab, dupilumab, benralizumab, mepolizumab, and racilizumab. Whereas in Th2 low, the cellular is neutrophilic, that either mixed granulocytic, or then another group is polygranulocytic. And the relevant pathway is interleukin 17 and thymic stromal lipoprotein. Another investigational biologics is tezepelumab, which work against thymic stromal lipoprotein, TSLP, and if it is approved in the market or by the approving agency, then it would be helpful even in the patients with Th2 low airway inflammation patients. So once we know the biologics, then we need to know which biologics targets what, how it is given, and what are the biomarkers to select these biologics. For omalizumab, it targets IgE. It is given subcutaneously. The usual dose is 150 to 600 milligram, 2 to 4 weekly, and the biomarkers are raised IgE and positive aeroallergen IgE specific IgE and or skin prick testing is positive with aeroallergens. For mepolizumab and reslizumab, it targets interleukin 5, whereas reslizumab is given intravenously as weight adjusted doses. Mepolizumab is given subcutaneously 100 milligram 4 weekly. And the biomarkers for all three interleukin 5 targets, interleukin 5 antibody is either sputum eosinophilia or blood eosinophilia. Because blood eosinophilia is easy to do and sputum eosinophilia is very difficult to measure. So blood eosinophilia is a surrogate marker of sputum eosinophilia, and practically we are considering blood eosinophilia as a biomarker for interleukin 5 monoclonal antibody. Regarding dupilumab, we have our biomarker is FeNO, that is fraction oxide nitric oxide. If FeNO is more than 25 parts per billion, then dupilumab has to be selected or chosen for a particular patient, and it is given subcutaneously, which is 200 or 300 milligram pre-filled injections every two weeks. Certain special remarks I would like to say that regarding dupilumab, one should never use it if AEC, eosinophil count, is less than 150 or more than 1500, and if FeNO is less than 25 ppb. Regarding benralizumab, one important aspect I would like to add is that apart from its having action against interleukin 5 receptor, it has got another mode of action. That is, it activates the natural killer cells, which is responsible for apoptosis of eosinophils and basophils. And it drastically reduces the airway eosinophils count by more than 90%, which is not done by any other interleukin 5 monoclonal antibody. So once we know what are the biologics that is available for Th2 high airway inflammation, then we need to select in an individual patients where it is indicated. So what is the approach to that? Because it is not as simple that we pick any vial and introduce and give it to the patient. So just as Gina has given a guideline of 5-step therapy in a stable asthma patient, similarly I am proposing a 5-step approach to select a biologic in severe asthma. The first step will be obviously that we need to confirm that the patient is having Th2 high inflammation, and for that we have to measure absolute eosinophil count, we have to do a FeNO test, we have to do a skin prick test or specific IgE for several aeroallergens along with total serum IgE, and another is that we have to identify a typical phenotype, clinical phenotype of patients, those patients who are dependent on long-term oral corticosteroid for symptom control. So these three, once we have identified, done this, then we go, then we try to divide the patients into 3 different groups. And what are those groups? One is early onset allergic eosinophilic severe asthma. Another would be non-allergic eosinophilic severe asthma. And third would be oral corticosteroid dependent severe asthma. Now, in allergic eosinophilic severe asthma, there are based on the age and based on the eosinophil counts, different biologics are recommended or approved. So one has to choose between those which are approved and which falls into that particular category. For example, for 6 to 11 years, it is only omalizumab or mepolizumab. For 12 to 17 years, for low eosinophil count, only 3 biologics are approved. For higher eosinophil count, 4 biologics are approved. And for more than 18 years, for eosinophil count more than 400, all 5 biologics are approved. So one has to choose between them. So similarly, in non-allergic eosinophilic asthma, omalizumab is out. So out of the 4 biologics, one has to choose based on the age and based on the eosinophil count. Regarding oral corticosteroid dependent severe asthma, only 3 biologics are approved till date, and the best one is dupilumab, followed by benralizumab, and then followed by mepolizumab. Now, once we have divided into 3 distinct groups, then we have to identify. The third step would be to identify in those patients what are the comorbid and associated conditions, whether the patient is having chronic rhinosinusitis with nasal polyposis, whether he is having aspirin sensitivity, whether he is suffering from atopic dermatitis or chronic urticaria, or patient is complicated with allergic bronchopulmonary aspergillosis, or even or maybe in rare cases Churg-Strauss syndrome, which is now called eosinophilic granulomatosis, polyangiitis. So whether the patient has got mixed syndrome with COPD and asthma overlap. So these are things we need to identify before we choose a biologic. Fourth step is that once we have identified the comorbidities, what clinical outcome we wish to target by a particular biologic. So there would be different clinical outcome target. For example, somebody would target the withdrawal of oral corticosteroid. In some patients, the target would be improvement in lung function. In some patient, in ACOS type of patients and mucus hypersecretion, the patient may be more distressed with lot of cough and sputum production. So in that patient, another biologic would be required. So these are the things that need to be considered before we select a biologic. Fifth step is the decision would the patient's choice and the family's choice regarding the biologic. Once you have given a choice that look, we have got 2 or 3 biologics or 1 or 2 biologics, which one to choose? Both of them are equally good. So the patient will have a choice. They will ask for the cost of therapy. That may be his concern. It may be concerned that they wish to have a longer gap between 2 doses, or the patient may have a feeling that I may self-administer it at my home. I will please spare me from coming into the hospital or into this. So, or the patient may be totally concerned with the safety. So, which is more safe, doctor? So, this may be the question. Which is the least hypersensitive reaction which gives, or which doesn't give anaphylaxis reaction? So, these are the certain questions which will decide based on the clinical and real-time data trials that which one has to be approved. So after these 5 steps, one has to decide. For example, here, if the patient wants that I should have minimum injections, I should be able to give it subcutaneously, I should be able to have a pre-filled syringe, I should be able to have those injections at my home only. So only benralizumab gets into this picture. If you see this, if this is the only choice of the patient or the wishes of the patient, you can see that the number of doses is only 14 in 2 years, whereas in contemporary it is at least 26. So and also it is every 8 weeks after first 3 months maintenance dose. So that also is a convenience to the patient, and he can use it even at his home because it is approved by the agencies that it can be used at home. Self-administration can be given. Now, as I said, certain aspects are required for selection. For example, age we have discussed initially also. Since Dr. Rajiv Ranjan told me that I should finish it within 10 to 15 minutes rather than 20 minutes, so I will exit this slide. But of course, you please go through this slide. Then another, the choice of biologics would be associated with comorbidity and conditions. As we have discussed, that these things will also be required to consider the choice, consider in selecting a biologic. For example, if the patient is suffering from chronic urticaria, omalizumab is a best trusted brand and best trusted drug found to be highly effective. If the patient has got atopic dermatitis, then dupilumab would be a choice. However, in those patients, higher dose will be required than the usual asthma doses. If the patient has got chronic rhinosinusitis with nasal polyposis, FDA has approved dupilumab, whereas European authority have approved mepolizumab. Benralizumab is also under consideration after good efficacy in the trial. If the patient is suffering from aspirin sensitivity or aspirin exacerbated respiratory disorder, then dupilumab is the first choice, followed by omalizumab, and mepolizumab is yet to be approved in that. If the patient has got by chance a comorbid, or I can say complication of EGPA in a chronic asthmatic patient, then mepolizumab is the only choice. However, 3 times higher doses are required to be given in such patients. If the patient is having ABPA, then you may try omalizumab, because that is the one drug which has been found to be effective in ABPA even at a higher dose of IgE. And another drug which has shown promising result is mepolizumab, and it is possible that it may also be approved for ABPA. As I said, if you are targeting hypersecretion, airway remodeling, and ECOS syndrome, that is asthma COPD syndrome, then dupilumab is the only choice, or I would say the best choice, because it controls interleukin 13 mediated inflammation, which is responsible for airway remodeling and hypersecretion. Now, what is the dose in special conditions for atopic dermatitis or for patients on oral corticosteroids, high dose oral corticosteroids? Dupilumab is a choice, is the best choice, and it is to be given a higher dose. That is, the first dose has to be 600 milligram, and then every 2 weeks it is 300 milligram. Usually, in asthmatic patients, it is 200 milligram. First dose is 400 milligram, followed by 200 milligram every 2 weeks. For EGPA, as I said, it is only mepolizumab, but it has to be given at a 3 times higher dose. Instead of 100 milligrams subcutaneous OD, it has to be given 300 milligrams subcutaneous every 4 weekly. Now the choice of biology is based on target clinical outcomes. So if we are targeting reduction in oral and in inhaled corticosteroid, we have got 3 or 4 choices. But the best first 3 choices would be dupilumab, benralizumab, followed by mepolizumab. If we are actually really targeting lung function, we want improvement in lung function, then dupilumab and benralizumab are 2 trusted ones, well documented in the trials that it improves significantly the lung function. If we are targeting the asthma symptom control and the quality of life, the first choice would be dupilumab, followed by benralizumab and mepolizumab. Now, the choice of biologics based on target clinical outcome, one of them would be, excuse me, hello, I will just take 2 more minutes, please. So, if the patient wishes that doctor, after some period of time, say 2 years, 3 years, 4 years, or 5 years, will I be able to get away from this omalizumab? What will be my remission, clinical remission rate after stopping omalizumab or any other biologics? So here the only confirmed biologics is omalizumab. It has been found that in significant number of patients who received omalizumab for 5 years, and after that omalizumab was discontinued, then the 60% remained in remission for several years thereafter. So this is the only one as till date in the real data trial, in the real world trial, where it has shown a very good remission rate even after stopping omalizumab after 5 years. So another would be certain subset of patients have got recurrent viral infection in expressions. In that, omalizumab has been found to be effective because of its antiviral activity. And another promising drug would be tezepelumab, which is anti-TSLP and which is under trial. And now the choice based on the preference of the patient. Patient would like to have cell administration, then only 2 choices are there, dupilumab and benralizumab. The patient may like to have a longer gap in 2 doses, then it is only benralizumab. If the patient is concerned with the safety, then omalizumab and benralizumab is the safest as for now, as per the clinical trials. If the patient wants seasonal pulse therapy, now the seasonal pulse therapy, the other biologicals like benrali or other mepolizumab, because they have to be given for 6 months at least before knowing their efficacy. So the seasonal pulse therapy as of now is not recommended by them, but omalizumab can be given. For example, in a particular season, if it is effective, it is because of allergic eosinophilic asthma, omalizumab can be given as a pulse therapy during that season only, and not continuous therapy in certain subgroup of patients. Regarding cost, as far as cost is concerned, if I speak about India, then in India, the cheapest as of now will be omalizumab, followed by benralizumab, in case if they continue with their policy of giving free vials. So I will just discuss these 2 cases. Each case will take only 1 minute. For example, this is a one patient who is diabetic, aged 46 years, non-hypertensive. He has got shortness of breath for 1 year. He has got cough with lot of sputum. Occasionally, blood mixed sputum is there in this patient. HRCT was done, which was negative, didn't show any bronchiectasis or any other lesion. CT-PNS did show sinusitis and nasal polyposis. So CT-PNS showed sinusitis and nasal polyps. Absolute eosinophil count was 300. IG was relatively normal at 60. However, FeNO was high. Pulmonary function test showed obstruction with FEV1 at 60%. Skin prick test was negative. Because the patient had got blood mixed sputum, had CT-PNS with sinusitis, and had eosinophilia, C-ANCA and P-ANCA was done, which was negative. Creatinine was normal, urine routine examination was normal. Now with this scenario, I would like to have some response that which biological would be indicated in this scenario. Any response from anyone who is participating? So if we see that omalizumab is out because it is non-allergic, IG is normal, skin prick test is negative, so omalizumab is out. Secondly, FeNO is high, so dupilumab can be considered. Now the patient is suffering from also comorbidity of chronic sinusitis with nasal polyposis, and AEC is 300. That is, those drugs which can be used only between 150 to 300 AEC can be used. So in this we have got only one choice, and that is dupilumab, because the AEC count is between 150 to 300 and FeNO is positive. Also there is comorbidity of chronic sinusitis with nasal polyposis. So dupilumab would be the first choice in this patient. Now this is the second case. Female, 41 years, cough with mild expectoration of 2 years. There is shortness of breath with wheeze. Cough and shortness of breath aggravates in night frequently. Chest X-ray was normal. Absolute eosinophil count was 2500. IG was 370. FeNO was 19 only. Spirometry showed very severe obstruction. Renal function tests were normal, and skin prick test was negative to aerosol. So in this, how we would approach? One is that omalizumab is out because skin prick test is negative. However, IG is raised, but skin prick test is negative. Second is that dupilumab is out. FeNO is normal, and absolute eosinophil count is very high. In a very high absolute eosinophil count, we never use, as far as recommendation is there for till now, we would not use dupilumab. So these two are out. So we have got only 3 choices now. Racilizumab, we cannot use it because the AC, we can use it here because AC count is very high. Then we have got benralizumab and mepolizumab. So out of these 3, any one can be used. It will depend on the convenience and the choice of the patient. So this is how we would approach how to select biologics. So with this, I close my presentation. So any questions, I would be happy to answer. Thank you very much.
Thank you. Thank you. So I would like to request Dr. Samrendra, is there any question?
Yes, sir. Please unmute yourself.
Am I audible?
Yes.
As usual, Dr. Sudhir, an excellent oration, well prepared, and we were waiting for you, and you proved your worth. Dr. Sudhir, since this one question is relevant, I would like to ask you in the benefit of the patients that we are dealing with presently. Number one, this is an COVID pandemic era. where damage there. Is biologics going to help some way in this scenario? Number one. Number two, is biologics useful in COPD as well?
Hello. Hello.
Ah.
Hello. So, sir, there was two questions from you. Am I audible?
Please.
Am I audible?
Yeah.
So you had two questions. You asked two questions. One is that one is regarding the role of biologics in COVID era, and second is regarding. Second was your question about. Excuse me.
Can it be used in COPD cases as well?
Okay, so I would answer the second question first. As far as till date, there is no biologics which has been approved or even tried on COPD patients. Number one. But however, theoretically, dupilumab is one which can be used if there is definite evidence of the patient suffering from asthma COPD overlap syndrome. So in such patients, dupilumab may be tried because of its mode of action. Now regarding your second question, first question, which was what is the place of biologics in during the COVID pandemic? So I am not able to find anything different from non-COVID time, because it has got nothing to do with the COVID infection, in fact, or nothing to do with the antibody which has been formed, or nothing to do with the vaccination. So in my view, it has to be selected based on the parameters that we have discussed, rather than that whether pandemic is there or not. Thank you.
Thank you very much. Now the question is to Dr. Professor Shailendra Kumar ji. And Dr. Shailendra, you dealt with your subject very nicely. And today I learned one thing, that this metformin is having anti-tubercular properties. That is very nice to learn. And is there such property in SGLT2 inhibitors also, which is being used now as first line drug in the treatment of diabetes? Dr. Shailendra, please.
SGLT2 inhibitor has no such property like anti-tuberculosis till date as per any report. But metformin is now considered one of the part of anti-tubercular drug, and in future we should not wonder if it will be used as anti-tubercular drug for second line treatment. So SGLT2 inhibitor, rather it has some disadvantage in using a case of tuberculosis diabetes, because patient is already cachexia. If patient is suffering from diabetes, the weight loss is more than anticipated by alone one disease. So in that case, SGLT2 inhibitor will not be a proper drug. Secondly, SGLT2 inhibitor is costly. So my talk was about in programmatic setting. So SGLT2 inhibitor, due to its cost factor, cannot be used in programmatic setting. Otherwise, SGLT2 inhibitor is an excellent drug for diabetes, because it is the only drug which action is not related in any way with the beta cell of pancreas or insulin. So it is an excellent drug. As TB diabetes is concerned, this drug is not of much importance. Thank you.
Thank you very much, Shailendra. Your talk was very useful for the practicing clinician. Is there any other question from the audience? That is welcome, if time permits. If none, then thank you very much. I hand over this place to Dr. Rajiv and for the further conduct of the meeting. Thank you very much. Thank you, Rajiv.
Thank you, sir. Thank you very much. So next talk is oration by Narayan Singh Memorial Oration by Dr. Rajan Prasad sir. And moderator Dr. P.K. Sinha sir.
Rajiv, already the function is started. The Narayan Singh Memorial Oration is already started. Okay. So directly switch over to the hallway and combine the program.
वो बंद हो जाएगा।
ठीक है।
Hello, Modi. Modi. Hello. Hello. Unmute Modi. Hello.
हेलो
मोदी क्या हाल चाल है?
हाँ बस ठीक है। हम लोग का इसके बाद है क्या?
अभी ऑरेशन चल रहा है ना डॉक्टर शिवनारायण
हाँ हाँ
ऑरेशन
ओके 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 ओके
के बाद होगा।
ओके। अभी मेरा इंटरनेट चला गया था ना, ये थोड़ा सा बीच में हम कनेक्शन ये हो गया। म्यूट कर लेना चाहिए।
Stop your video. Cannot start your video because the host has stopped the call research. Ask Priya sir.
तो फोन ही नहीं उठा यार। यार हम लोग बंद क्यों कर दिए हो? सब हमारा स्टॉप हो गया।
और भी मेरे घंटे से कोई एक्टिविटी नहीं।
अभी भी एक्टिविटी नहीं है, अभी भी नहीं। सब लोड करवाए, कैसे गड़बड़ा गया। हमारा हॉल भी ब्लॉक कर दियो ना, हॉल बी को चलने दो ना, प्लीज बैठे। हमारा हाँ, इसमें सब उस दिन डलवा दिया।
और भी नहीं चल रहा?
नहीं नहीं, कुछ नहीं। हॉल बी क्यों म्यूट कर दिया? कंटिन्यूअसली वॉच करते रहो यार, कोई सपोर्ट नहीं है।
वही वही हम देख रहे हैं। एक्चुअली इन्हीं के साथ अब वो डी वाला नहीं के साथ लेके लगे होंगे। डी वाला भी अभी प्ले होना सर, सोन हॉल ना पहला। हाँ, पहले ये
बी को चलने दो भाई।
सोन हॉल डी है, सोन हॉल डी है, पहले बी बंद हो गया। बी को
हम हमको अनम्यूट करो। हॉल बी को
हॉल, एक मिनट, गंगा हॉल चल रहा है।
हाँ,
गंगा हॉल
हॉल बी बंद है,
हॉल बी जो है
बंद है। अनम्यूट कीजिए आप।
सरयू हॉल नहीं चल रहा, ये नहीं सरयू, सरयू सरयू बीच आप नहीं कर सकते, अनम्यूट कर दो। सर मुझे बताइए कितनी वीडियो भेजनी है, मेरा काम खत्म कब करें? आपने आपने जो वीडियो भेजनी थी ना, एक मिनट का वो फाइल खोलो। यहाँ से तो मैंने वो पूरा आपको नाम बता दिया। एक जो चिराग अग्रवाल आपने बोला, ये नहीं जा रहा, चिराग अग्रवाल नहीं गए, राइट? हाँ, चिराग अग्रवाल यही है। हाँ, ठीक है।
मतलब ये जो हॉल बी को अनम्यूट कीजिए ना।
एक बार यहाँ पे एक बार यहाँ पे आके देखिए।
मेरे यहाँ प्ले हो रहा है ठीक से। ये लीजिए।
यस,
क्या कह रहे हैं? हाँ 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 हाँ, ये देखिए, थैंक यू सर। कितने लोग अटेंड कर रहे हैं? करीब एक बार डेटा चेक करना पड़ेगा, पर 200 के ऊपर हो गया। हाँ हाँ, अरे सर बैकएंड तो यहीं से रहा हूँ।
Sorry for delay. This is already late due to some technical fault. Now the next session is session of diabetes. First of all, I would like to call Dr. R.K. Modi sir to moderate this session.
Yeah.
And, hello.
Should I start, sir, Dr. Rajiv?
Yeah.
Good morning, everyone. This is a wonderful session, and we have two speakers. Dr. B.K. Singh, he'll be speaking on the interpretation of thyroid function, and we have another brilliant speaker, Dr. Mahavir Thakur, who will be speaking regarding pre-diabetes, which is a cardiovascular risk. To begin the session, first I want to introduce Dr. B.K. Singh, who is going to speak on thyroid function. He's a postgraduate from Patna Medical College, fellow of Indian College of Physicians. He was organizing secretary BAPICON 2016, and his past secretary for consecutive 2 years, 16 and 18 of API Bihar chapter. And he is presently vice chairman API Bihar, and he's chairman-elect RSSTI Bihar chapter. So he's going to speak on thyroid function test, its interpretation. We know thyroid disorders are quite common, and it is especially common in the women group. And we have to take help of investigation, because most of the time the symptoms are non-specific or very mild. So lab assistance is very important. We know that T4, that is total measurement, is a poor, has got poor sensitivity, and TSH is the first abnormality which can tell so many hidden things in the history of the story of the thyroid. So I'll request Dr. B.K. Singh to start his deliberation.
Thank you, Dr. Modi, for your kind words. And first of all, I would like to thanks the organizing committee, especially Dr. Rajiv, for giving me opportunity to speak on this BAPICON 2021. Can I share my slide?
Yeah,
sure.
Is it visible?
Yes.
Not visible yet.
Is it visible?
Now it is visible. Yeah, nice.
Yeah.
Okay. Thank you very much. Thank you very much. First of all, the slides are moving. Yes. First of all, if you see that the interpretation of the thyroid function test is very important. And
यहाँ पे connectivity का जुगाड़ करो, नहीं तो हम
sorry.
Dr. B.K. Singh, please unmute yourself.
Yes. Actually, slides are not moving. Again, sharing my slide.
Okay.
Thyroid disease are one of the most common endocrine disease worldwide. It is estimated that about 42 million people in India suffer from thyroid disease. Although thyroid disease in its most florid form is easily recognized, most of the patient, when it is hyperthyroidism or hypothyroidism, it is easily recognized if it is in florid form. means it is in advanced part, but many patients often manifest symptoms and or signs that are very non-specific in nature. So we need very high clinical index of suspicion to diagnose these patients. And the confirmation of the diagnosis usually depends on accurate measurement and interpretation of the thyroid function test. In most cases, the result of the thyroid function test are straightforward and present a familiar pattern that is easy to recognize. However, in an important subgroup of the patient, they can seem confusing. By virtue of being discordant with the clinical finding, means the findings are not matching with the clinical picture. First of all, I want to give some highlights on the regulation of the thyroid function. Every individual have its own HPT axis set point. And the hypothalamus, pituitary, and thyroid, all three have very beautiful role in this thyroid hormone secretions. The hypothalamus gives signals to the anterior pituitary through the TRH and thyroid releasing hormone, and this anterior pituitary releases the TSS to activate the thyroid gland, and this thyroid gland produces the T4 and T3, which goes to the peripheral circulation to the tissues for metabolic actions. This is a nutshell. If you can see the picture on the right side, this is the typical follicular cell of a thyroid gland. The TSH, it is a TSH combined with the follicular cells, it increases the cyclic AMP and that releases the thyroglobulins. And this thyroglobulin, with the help of the TPO, here TPO has the role, it combines us with the iodine, which has been absorbed by the thyroid gland, and this iodinations and the combination gives to the thyroglobulin MIT or DIT more complete, and this thyroid MIT and DIT globulin being stored in the thyroid gland, and later it is released in the, as a thyroid hormone like T4 and T3, and the most of the release is by the exocytosis, the thyroid T4, and the lesser amount in the T3. And all this thyroid hormone is bound with the 99% is bound with this thyroid binding globulin and transthyretin and albumin, and most of the in 70 to 80% is the thyroid binding globulins, and the rest amount are in the free level as free T4 or T3. This is in nutshell the physiology of thyroid hormone. If the thyroid hormones in the blood suppression is more, it gives negative feedback to the pituitary and to the hypothalamus, and so the thyroid hormone increases comes. In general consideration, if you consider that any given individual, the thyroid hormone levels remain relatively constant and reflect the set point of the hypothalamic pituitary thyroid axis in that particular individual. And the changes in the thyroid status are typically associated with the concordant changes in thyroid hormone and TSH level. Beautifully. And however, the population reference ranges for TH are relatively wide, and changes in the thyroid hormone level sufficient to render a patient hypo and hyperthyroid might not necessarily be associated with the numerical abnormality. Therefore, the TSH has traditionally been recommended as a frontline screening test for thyroid dysfunction, because relatively modest change in the TSH level are associated with marked excursion in the TSH level. So this particular content, that the TS is the traditionally routine first line screening test for thyroid dysfunction. However, screening exclusively with the TSS means that some patient will be misdiagnosed, whereas the other condition might be missed altogether, that is the central hypothyroidism, non-thyroid illness, and recent treatment of thyroidopsicosis. It is also important to consider whether total or free TSS level are being preserved. If the former, that is the total, then changes in binding protein can confound interpretation of result. So the T4 and T3 are heavily protein bound. Thus, total but not free hormone measured are affected by the alteration in the binding protein status. For example, the exogenous estrogen therapy or the pregnancy increases the total thyroxine level, now the elevation of T4 binding globulin. So in pregnancy where the TBC is increased, there is a total thyroid toxin elevated, but not the free. So if there are many special considerations if you are prescribing a thyroid function test to any patient. First of all, you have to look the thyroid status of the patient. Ideally, the result of the thyroid function test confirms one's clinical suspicions. Namely, the patient is euthyroid, hypothyroid, or hyperthyroid. And reassessment of clinical status is particularly important when faced with an unexpected thyroid function test result because it provides an important test, TSS, T4 or T3, that is likely to be discordant and guide further investigation. So thyroid status should be checked initially. Second point is the levothyroxine therapy. Anomalous and discordant TFT are not infrequently seen in patients being treated with the levothyroxine and can have several causes including the poor absorption, the increased clearance, and resistance to the thyroid hormones. The third point is the medication. Several commonly prescribed drugs can cause thyroid dysfunction as an adverse effect, and a careful medication history should be taken in all patients with a thyroid disease. That is one important molecule is the amiodarone, which is used in the in arrhythmias, either supraventricular or ventricular arrhythmia, and the lithium, which is used in the psychotic drug. And the tyrosine kinase inhibitors and some immune modulators also affect the TSH levels. So other agents can interfere with some laboratory measurement, producing an apparently discordant TFT picture. For example, both fractionated and unfractionated heparin in active endothelial lipoprotein lipase with hydrolysis of triglyceride and increase in circulating free fatty acid level, that is in some individuals lead to the displacement of the T4 and T3 from the TBD, thus raising free but not the total TSH level. So interesting, such changes are not generally associated with the clinical thyroid excesses and TSH usually normal. So other point is the hypothalamic pituitary disease. In the presence of the suspected or confirmed central hypothalamic pituitary thyroid dysfunction, the TSH should not be considered to be a reliable marker of thyroid status, and the free T4 or free T3 level must be used to guide management. That is very important point. And non-thyroid illness, very important subject. And many of the patients, if you come to your clinic, have a very discordant picture of this thyroid dysfunction, thyroid TFT dysfunction. Intercurrent illness can affect the thyroid function in several different ways. So you must first consider that whether the patient has recent history of any morbidity or not. So commonly TSH is low, normal, or partially separate with low, normal, free THs. Therefore, it is generally advisable only to check thyroid function in those patients in whom primary disturbance of one or other part of HPTHC is suspected. Pregnancy, important point. The physiological alteration during pregnancy lead to changes in the thyroid hormone and TSH level. Accordingly, time structure specific reference rates for TSH and thyroid hormone and the TSH should be used when possible. The other important point is the assay interference. In any patient in whom anomalous or discordant thyroid function tests are not readily explained by the above consideration must be given to whether or one other laboratory results verifies. If you see that the patient is having a discordant thyroid function test, so don't go for only the other laboratory test. It may be possible that the other laboratory may have some changes. But the genetic and acquired causes of interference in both THS and TSS are well recognized and can be screened for. For example, the cross-reacting heterophilous antibody causing falsely low or elevated TSS are readily detected through TSS dialysis studies. It is important to note that simply sending a sample to another laboratory does not necessarily exclude assay interference. Some interference can affect different assay platform, and specialty laboratory and or endocrine advice should be sought in very suspected cases. So come to the point, our point of discussion is that the high TSS level, these are the all 6 or 7 parameters I want to discuss. First parameter is the high TSS and low T4. This combination of TFT suggests primary hypothyroidism. Clear-cut case that there is a high TSS level and too low free thyroxine level. And it is most usually the result of autoimmune thyroiditis like Hashimoto disease or the atrophic thyroiditis, or follows the radio iodine or thyroid. It's clear cut. You can diagnose very easily. Second point is the low TSH and high free T4. Low TSH, very low TSH and high thyroxine level. Picture is clear. This is the picture of primary hyperthyroidism, and in this context, TSH is usually undetectable, typically less than 0.03 microunit per liter for modern ultrasensitive TSH assay. And the Graves' disease and the toxic multinodular goiter are the two most common causes of this low TSH and high free thyroxine level or free T3 level. The third point is high TSH. It is a high TSH or the normal free thyroxine level or thyroid level. This pattern, the thyroxine level, the T3 and T4 or free 3 and P3 is normal, but the TSS level is high. This pattern of result are signifies the so-called subclinical hypothyroidism. And the measurement of anti-thyroid peroxidase antibody titer is useful again to help guide decision making. So in subclinical thyroidism, if the TSH level is more than 10, no problem, you start the treatment. If the TSH level is less than 10, then you have to go for the anti-thyroid peroxidase antibody test. If the TSH is persistently raised, T4 replacement is generally advised in certain circumstances, particularly younger patients, especially when symptomatic. Women who wish to become pregnant or who are pregnant. Patient with positive TPO and TT, as I already said, in the rising trend in serial TSH level and the presence of marked hypercholesterolemia. These are the indications of T4 replacement therapy. Raised TSH with normal TH level is also seen with assay interference. This is a very important point. It is not only the subclinical hypothyroidism. It may be that the raised TSH and normal TH level, the raised TSH and normal TH level is also seen with assay interference, and in patient taking exogenous T4, where it might reflect malabsorption, altered metabolism, and the poor compliance. That is one of the important point. The fourth scene you see the clinical practice is the low TSH and the normal thyroxine level, normal free T4 or free T3. This is one of the causes subclinical hyperthyroidism. Clearly, it's characterized usually by the normal TSH level but low TSH level, very low not, it is a low TSS level. Although within the reference range, the TH level in these individuals are higher than the usual set point of the HPT-Hs. I have already said that the HPT exit of every individual is different. Resulting in the TSH suppression, there is a greatest evidence of adverse sequelae. If this subclinical hyperthyroidism is there, there is a chances, there is a greatest evidence of adverse sequelae, that is atrial fibrillation and osteoporosis if the TSH remain suppressed in long term. In whom, especially in the postmenopausal women and patient older than the 65 years of age. That is important point. If the TSH level is suppressed for longer time in these two particular group of the patient, in postmenopausal and the aged population more than 65 years, there is a chances of atrial fibrillation and osteoporosis. When TSH is not fully separated, a period of surveillance can be adopted. All the emerging evidence suggests that even these individuals will have greater morbidity in longer term. So, however, in a significant proportion of patients with subnormal TSH values, they will return to normal during the follow-up without intervention. So, you must be careful and watchful in that particular group of patients. And the second point in the low TSH normal T4 level is the non-thyroid illness. Is another common cause of transiently low. Transiently, the question is transiently low, but not fully suppressed TSH. With resolution following recovery and emphasizes the importance of not acting on a single TSH result. In this case, sequencing the follow-up TSH levels is important. And in cases of exogenous T4 administration, it is generally desirable to avoid full TSH suppression with a notable exception of thyroid. The fifth point is the low free thyroxine with inappropriately normal or low TSH level. This is a common clinical practice, and you have to you're confused what to do and what not to do. This combination of TFT also seen in the non-thyroid illness and resolved with the recovery, no problem. However, in the absence of the clear alternative diagnosis, in this particular group, central hypothyroidism must be considered, and a full pituitary hormone profile, including assessment for the secondary hypoadrenalism, is mandatory. Because why hypoadrenalism is mandatory? Because T4 therapy in patient with untreated hypocorticotism can be a life-threatening, and failure to recognize a large pituitary mass compressing the optic chiasma can result in the irreversible visual loss. So this, if there is a low FT4 level with inappropriately normal or low TSH, you should have keep in mind of the central hypothyroidism. The last point is the high FT4 level with inappropriately normal or high TSH. High FT4 and high TSH. High FT4 or non-normal TSH. This is unusual pattern of TFT and is usually most common accounted for in assay intervals. This is most common in assay intervals. And confounding effect of drug like amiodarone, heparin, or the T4 replacement therapy, including non-compliance, is also very important. Once these had been excluded, once the amiodarone, the drug therapy, and the thyroid replacement therapy is included, there is two rare findings are there that must be distinguished in this particular group of the patient. That is the resistance to the THS or the TSH secreting pituitary adenoma, the TH adenoma. And this group of the patient, if you are confused and the patient is not responding, then referral to a specialist endocrine center is advisable. So friends, now the conclusion is that the result of thyroid function test must always be interpreted in light of your clinical status of the patient, whether the patient is hypothyroid, euthyroid, or hyperthyroid. And you must consider the other factors of non-thyroid illness, like the drug history and the other finding which I have already mentioned. and awareness of the condition and or disorder that can be associated with the different pattern of the thyroid function and guide further investigation and management. Intercurrent non-thyroid illness or medications should be excluded before embarking on further biochemical, radiological, and genetic testing. Screening for interference of thyroid hormone and or thyroid laboratory assay should be considered in any patient with apparently anomalous or discordant thyroid function test. And the last, referral to a specialist laboratory and or endocrine service is required when anomalous or discordant TAP cannot be readily explained by confounding intercurrent illness, medication, or assay interference. Thanks a lot for patient hearing.
Hello.
Hello. Kindly start my video, sir. Yes. It was really a very nice deliberation, Dr. Vicky Singh, and you could really gave a clear-cut message that how to interpret a thyroid function test. And truly speaking, it is not a science only, but it is an art to interpret thyroid function. You could nicely spoke about the pituitary thyroid axis. You could explain about this thyroid binding globulins, and there was a clear message that TSH alone can able to diagnose 90% of the thyroid disorder. And you told about non-thyroid illness, which is a common entity in our day-to-day practice. And if you know the details, only then we can start a T4 replacement. So is there any question?
Sir, good afternoon, sir. Abhishek here.
Yeah.
Sir, please just focus on a few tips on interpretation of TSH in severely obese patient, if no other symptoms are present.
Obesity, I don't know actually what obesity can cause the thyroid function test, but definitely the obesity is one of the, you can see that the many obese persons have the subclinical hypothyroid features. Exactly, I don't know whether the obesity, one finding I have already said that the hypercholesteremia is one of the finding where you can have the subclinical hypothyroidism. So exactly considering the obesity and the causes of this thyroid dysfunction, exactly I don't know if anyone can address this issue. But what I have said, the hypercholesteremia is one of the finding where you can suspect that this is associated with the subclinical picture of the subclinical hypothyroidism.
I just want to add something. If obesity is associated with subclinical hypothyroidism, in that case, we can consider that obesity may be a marker of hypothyroidism itself. Then we may start medication. And if it is being supported by anti-TPO antibody, or if the antibodies are positive and even the TSH values are not very high, and we suspect hypothyroidism, then we can start with T4 replacement.
Exactly, the treatment is started in any of the parameter. This subclinical, suppose your patient is having subclinical hypothyroidism and the T4 TSH T3 level is the normal, and the TSH level is more than 10, nothing to worry. If the TSH level is more than 10, you have to start the replacement therapy, T4 replacement therapy. But if the TSH level is in between the 5 or what is the reference, upper reference line to the 10, then the decision is very difficult to consider. And you have to consider many findings, many things in that particular group of the patient. The obesity is one of the findings. If your patient is obese, you already said that in clinical practice that the most of the patient coming to your clinic of hypothyroidism, particularly they are obese, and some myxodemus changes if the florid presentation is there. But most of the subclinical hypothyroidism have the obesity in feature. And one of the finding is that the hypercholesteremia is if there is a severe hypercholesteremia, the TFT, if the TFT is in all the hypothyroid patient, if you find out the lipid profile, that lipid profile is normal, but you have not to start the anti-lipid drugs unless other you have to fully control the TSH level or the thyroid dysfunction. Because if you control the thyroid dysfunction, the cholesterol or other parameter of the lipid profile comes down to the normal.
नहीं आप अपना टाइम पे स्टार्ट करें, नो प्रॉब्लम.
Dr. BK Singh sir, sometimes we ask for measurement of
लिंक नहीं मिल रहा.
free T3 and free T4. Like in pregnancy also, if we have abnormal binding and the result may be T4 or T3 may mislead us. So sometimes we go for only assessment of free T4 and TSH that will add up in our diagnosis. And sometimes we only ask about free T3 assessment. So can you tell me one indication where?
Moderator sir, please see the time also.
Yeah. This is the last question.
We are already late.
Yeah.
So actually, there is two findings. One is that you can go the physiology of the thyroid hormone. The most of the thyroid hormone is bind to the proteins. That is only the TPZ and the transthyretin and the albumin. And if there is any abnormality in this thyroid hormone binding globulins, that leads to the erroneous diagnosis. So in pregnancy, there is already TPZ level is high. So in pregnancy, you already advise that to go for the free thyroid hormones, free T4 or free T3. But many of the few conditions is there where the total thyroxine is important, but the free is not important. One is the condition where there is if you unfractionated hemarine or if you advised it is already been going on, that displaces the thyroxine from the protein and give rise to the false free T4 or T3 level. In that particular group of the patient, the total thyroid total thyroxine level is important. But in clinical practice, you usually prescribe the free T4 if the pregnancy and other comorbid condition is there.
So now, nice presentation, Dr. BK Singh sir. Now we have to move on the other second topic of today's in diabetes session. And our speaker is Dr. Mahavir Thakur, brilliant speaker, and he'll be speaking about pre-diabetes and its importance for coronary artery disease. Dr. Mahavir sir?
Yeah. Start my video.
Yeah.
Good afternoon to everybody. Thanks, Chairman, sir, for nice words. And at the outset, I would like to thank. Am I audible? Yeah, thank you. So at the outset, I would like to thank the organizing team, organizing secretary, Dr. Rajiv Ranjan, and other office bearers for giving me an opportunity to address this August gathering. My topic is no diabetes, pre-diabetes and cardiovascular risk. So this is very important step to curtail the risk and so many complications of diabetes. If you pick up this point, and the patient at this point, we can save many of the complications. Not only that, we can save many money, and particularly for my country. So this will be very important. And we know that diabetes at the time of diagnosis, 50% of islet cell is already lost. Full screen, full screen, full screen. So by the time diabetes is diagnosed, 50% of pancreatic islet pancreas lost. And in pre-diabetic stage, 40% is lost by postpartum studies. And there is some common soil theory. The diabetes and cardiac problem starts with the same pathophysiology. So it is said that by the time of diagnosis of diabetes, cardiovascular problem starts well before, at least 5-6 years before the onset diagnosis of diabetes. So now it is called diabetes cardiovascular problem. Now moving ahead, pre-diabetic is a state characterized by impaired fasting glucose, impaired glucose tolerance level. The physiological defects underlying pre-diabetic include insulin resistance, alpha and beta cell dysfunction, increased lipolysis, inflammation, and suboptimal insulin effect. As per recent studies, the long-term complications of diabetes and people with pre-diabetic are like micro and macrovascular complications. Same with diabetes. And type 2 diabetes, I talked, is one of the major causes of premature morbidity and mortality worldwide. According to report in 2014, WHO reported 1 in every 10 adults suffering from diabetes. It's a very precarious situation. And about equal number, 80 million are suffering from pre-diabetic also, the same number. So if you combine together, altogether 160 million population is in India is suffering from this, this is sitting on the volcano, having the great complications ahead. So diabetes rights also imposes a huge drain in developing a country on national health budget. Of these macrovascular complications, the largest contributor, the direct indirect cost of the diabetes. The development of type 2 diabetes is punctuated by interlude of pre-diabetes itself a toxic state that is associated with development of macrovascular and microvascular complications. So the same theory, if you start with normoglycemia, coming to dysglycemia and diabetes. So we get the chance, if you screen the society of metabolic syndrome, we'll get the chance to screen out pre-diabetic and prevent the diabetic at this stage, at least to minimize the complications. So the prelude to diabetes is pre-diabetic, that is continuous from normoglycemia through worsening dysglycemia. As per ADA, as per ADA, as per ADA, just a minute. Thank you. As per ADA, impaired glucose tolerance is defined as 2-hour plasma glucose value after 75 gram of oral glucose tolerance test of 140 to 199. I mean 7.8 millimole to 11 millimole. So any value between 140 to 199 is pre-diabetic. Likewise, the impaired fasting is defined as fasting plasma glucose of 100 to 125. So in pre-diabetic, HbA1c is 5.7 to 6.4. So it raise up year when the HbA1c crosses 5.7. Because it has been seen after 5 HbA1c with the rise of 1 HbA1c, one value, 1% value, raise of value, there is a 10% risk of cardiovascular problem. So we should be cautious to start with. But certain pitfalls of HbA1c we must keep in mind, like anemia, chronic kidney disease, other systemic illness, and hematological disorders which affects HbA1c. So we should look after HbA1c also, and as well blood sugar level also to conclude or to start the management. Hence, it is also prudent to confirm diagnosis with actual blood glucose measurement and as well as side by side HbA1c. Worldwide, there are 400 million pre-diabetic, and by 2030, projections were 470 million. Just like diabetes, this is just going side by side. The diabetic and pre-diabetic equal number in the world scenario also. And many studies across the globe have pointed out that the risk of many comorbidities are same in pre-diabetic as well as pre-diabetic can affect all age groups. So, friends, we should pick at this stage. The natural progression of dysglycemia involves increasing insulin resistance and loss of beta cell function. And significant defect in insulin's action and secretion have been demonstrated in this pre-diabetic state. Other coming to a landmark longitudinal study has shown transition from normal glucose tolerance to pre-diabetic was associated with increase in body weight, increase in insulin resistance, and decrease in endogenous insulin secretion. So any metabolic state, first screen for pre-diabetic, and if you prevent or curtail or put the measures to contain this, I think the number of diabetic will be less, as well as the complications also. Just one postmortem study reported 40% decrease in relative beta cell volume in the individuals with pre-diabetic compared to those with normal fasting glucose concentration. Imagine 40% reduction in beta cell mass. And also there is increased lipolysis, decreased endogenous glucagon-like peptide, GLP-1, impaired postprandial suppression of glucagon by alpha cells, aberrant expression of pro-inflammatory cytokines, low adiponectin level, elevated intracellular adhesion moleculon, and tumor necrosis factor 2, and disturbed gut biota, all are responsible for pre-diabetes, and ultimately this lead to the frank diabetes. So the increasing glucanopeptide, increasing levels, lipolysis, they are very important, and this can be addressed to start with. The macrovascular disorder associated with pre-diabetic include cardiovascular disease, stroke, and peripheral vascular disease. In fact, the traditional risk factors like dyslipidemia, obesity, hypertension, quite prevalent among pre-diabetic also. So the signals are emerging from various. So as per recent meta-analysis based on 35 studies, atherosclerosis, coronary artery disease, myocardial infarction, congestive heart failure has been reported in pre-diabetic. As per EPIC Norfolk study, a 1% in HbA1c within normal range, even in normal range, below 5.7, if there is one increase, they associate 10%, 10 years cardiovascular mortality, the increasement. So by Paris, coming to many evidences, Paris prospective cohort study showed doubling of cardiovascular disease mortality in impaired glucose tolerance as compared to normal glucose tolerance. MESTA study also showed pre-diabetic state is associated with threefold higher prevalence of unrecognized myocardial infarction as compared to normal glucose tolerance. So most patients with pre-diabetic further harbor features of insulin resistance, upper body obesity, hypertriglyceridemia, decreased HDL cholesterol, the typical diabetic dyslipidemia, increased hypertriglyceride and decreased HDL, and as well as associated hypertension also. And the components of metabolic syndrome often can be identified in pre-diabetic several years before the diagnosis of type 2 mellitus. So friends, we can the patient gives signal, we can pick up these patients before the diagnosis, full-blown picture of diabetes or full-blown complications of diabetes. These features are translated with advanced atherosclerotic vascular changes, which are often preceded by impairment of endothelial dependent vasodilation, vascular smooth muscle dysfunction, and increased artery stiffness. So all these changes take place in pre-diabetic also. And when we diagnose diabetes, we have cardiovascular problem, many cardiovascular problem. And if you combine this, if diabetes alone is allowed, is set as a cardiovascular problem. In the San Antonio heart study, there was evidence that risk for cardiovascular disease starts to increase long before the onset of clinical diabetes. I elaborated this to start with. Obesity and overweight has been frequently associated with low-grade chronic systemic inflammation characterized by increased level of pro-inflammatory markers like TNF-alpha, interleukin-6, and increased CRP level. And also obese people with pre-diabetic often have dyslipidemia, that is typical diabetes, high triglyceride and low HDL. Hypertension is frequently associated in pre-diabetic also. Diabetes prevention program reported long rates of incident hypertension among pre-diabetic individuals randomized to the intensive lifestyle arm as compared to placebo arm. So how can you prevent? We get lot of time to screen the patient with the family history of diabetes, the siblings, and the offsprings can be screened in the diabetic family or history of diabetes in the family. So lifestyle modification, various studies have shown the decreased blood pressure, increased HDL, total cholesterol level, and reduction of more atherogenic small dense LDL can prevent this pre-diabetic. In Mediterranean diet, there is a 40% reduction in incidence of type 2 diabetes mellitus. Weight loss, improved and that leads to also weight loss and improved inflammatory markers with Mediterranean diet. Prevention of type 2 diabetes mellitus also prevents related cardiovascular disease. Now, individuals with pre-diabetic have an increased risk of cerebrovascular disease like TIA, stroke, and recurrent stroke. Just by a recent study by Tanaka and colleagues demonstrated that pre-diabetics were associated with poor outcome in early 30 days after acute ischemic stroke. So not only diabetes, if the blood sugar is more than 140, or it is dictum to bring the blood sugar near 140 in stroke patients. So whatever maybe diabetic range or pre-diabetic range, the target should be 140 in a stroke patient. The recent CORA MRI study have shown pre-diabetic has an increased risk for carotid plaque and adverse functional carotid cardiac parameters. Also commonly in patients with perivascular disease, this with associated with pre-diabetic. So friends, to conclude my talk, the pre-diabetic is a toxic metabolic state associated with increased risk for microvascular and macrovascular complications. Physicians should screen patients routinely for pre-diabetic. They give a lot of chances to screen out the siblings, offsprings, relatives, near relatives. They all can be screened for pre-diabetic. And the goal is to achieve and maintain more than 5% weight loss through calorie restriction and increased physical activity. Pre-diabetic period presents an opportunity to intervene by education, increase awareness, care coordination, organization, and novel reimbursement mechanism at multiple levels. So we can prevent, coming to preventive aspect, we can prevent many patients developing, landing into diabetes, full-blown diabetes mellitus, and as well as we can prevent the complications. So complications are not only in the established diabetic, but even pre-diabetic also, as shown by the various studies and evidences. So thank you all. Recently. Dr. Modi, please.
Hello.
Yeah.
Yeah. Start my video. Okay. Yeah. It was really a nice deliberation, Dr. Mahavirji, and you could clearly give a big task to all physicians that we should pick up pre-diabetes from our practice, and we should advise them to lose weight, because obesity is one of the important factor which contributes to insulin resistance as well as to pre-diabetes and so other many complications. So it is a duty. So since paucity of time, we may allow a few questions from Dr. Mahavir Thakur.
Yes.
Sir, have you any study of pre-diabetics in India?
Not aware. I have shown the abroad studies, so especially dedicated to pre-diabetic. I don't know.
I think the pre-diabetics are more in India.
Yeah, I have shown equal
As
number.
we are
Equal number.
just
Yeah,
watching
80
that.
million, 80 million diabetic and 80 million pre-diabetic. So equal number are pre-diabetic. So if you combine this, so far as cardiovascular risk is concerned, it's 160 million population, 16 crore. So very high figure, and most of the time they are associated with hypertension. So the combine this, more than 65% or 70% patients are suffering for this hypertension, dyslipidemia, and this diabetes.
Sir, why, may I ask one question?
Yeah, sure.
Yeah. Yeah.
Why pre-diabetics? Why abnormal glucose value increases the cardiovascular risk?
I have shown the different inflammatory markers, and are already deranged or increased in this. So this inflammation, and so this one. One thing is important. This is common soil theory. I have said the diabetes, when the diabetes is diagnosed, cardiac problem is already set in. So the pre-diabetic stage, cardiovascular problem is already started due to different cardiovascular markers, sometimes with obesity and hypertension, and so many conditions I have elaborated.
One thing is, I have come across in the study that ACE2 enzyme, which is related with this complication, because in many of the cases, when you control the diabetes, it does not control your cardiovascular risk.
No, that is, I don't have time, but I would like to put up 4 important studies. One is UKPDS, one is VADIT, ACCORD, and advanced study. So you already know this 4 important study. And what was the sample size of all 4 studies? UKPDS, the intervention was to the start with, so no complication, later complications. And all 3, the intervention bringing back the glucose normal was after 7 years, 8 years, or even 11 years. So a lot of complications happen. My message is to pick up the patient in pre-diabetic state and start all the measures like this. So even if you want to prescribe some patient metformin or even pioglitazone, you can do it to prevent crossing over to the boundary or fence.
Before prescribing medication, we can advise them to have a proper lifestyle.
Yeah, definitely. LSM is first.
They should go for medical nutrition therapy.
LSM is first, then after meal.
One thing is that if you go through the cardiovascular complication due to hyperglycemia, the most important factor in that particular is the first thing is deranged is the ACE2 enzyme. The ACE2 enzyme, which converted this angiotensin 2 to the inactive angiotensin 17
and 19
enzyme, 17 or 19 enzyme. And this 17 enzyme is a protective phenomenon. And if you increase the level of this enzyme level, the 17, that will prevent the atherosclerotic changes in the coronary artery. My perception is that if you I don't know whether study is there or not, if you SE inhibitors are prescribed in low dose.
That's why the first choice is inhibitor.
SE inhibitor is prescribed even in non-diabetic patient. If there is a pre-diabetic stage, in non-hypertensive patient in pre-diabetic stage, can it decreases the chances of cardiovascular? I don't know.
Definitely. That's why the level of blood pressure has been kept low.
That is my point to stress at that particular time. Wonderful sessions, Dr. Mahavi Thakur sir. Very important topic, pre-diabetic and the cardiovascular complication. Wonderful, sir.
Thank you very much, everyone, for
Thank you.
This nice deliberation and discussion. Over to Dr. Rajiv ji.
Thank you, sir.
Yeah. Sir, for the next session, moderator is none other than Dr. A.K. Das. He will conduct 3 talks in this session, and that is also on hypoglycemic agents. So over to Dr. A.K. Das, sir.
Thank you, Dr. Rajiv, for the introduction of the next session. We have diabetes going on. The train of diabetes is too long, but we have smart people talking on diabetes. We have chairpersons for this, and we have 2 important sessions by the name of GLP-1 receptor agonist by Dr. Shaival Guha, and a very, one of our key speakers, Dr. S.C. Jha, is going to talk on intermittent fasting facts. Dr. C.B. Prasad is going to talk on the role of sulfonylurea relevance in current practices of OHA. So over to the chairpersons.
Yeah. So the first talk is, Dr. Saurabh. Yes.
Dr. Shaival Guha. Very, very good afternoon, dear friends, ladies and gentlemen. Now we have a very important session on diabetes, rather continuing with that pre-diabetes. Now we are coming to diabetes itself. And we all know that we are marching towards many new inventions and many new introductions, starting with insulin, then oral hypoglycemics like sulfonylurea, bigonides, thiazolidines, and then meglitimides, and then coming to the incretin group of drugs. So the DPP-4 inhibitor and analogs, that is the GLP-RA, which now stands a very important place in the diabetic management. But how much we are using it, it remains a question. So may I request Dr. Shaival Guha to take over for GLP-RA an introduction. Dr. Shaival Guha, please.
Thank you, sir. Good morning, respected.
Most welcome.
Good morning, respected chairpersons.
जी आपका टेस्ट हुआ ना?
जी पूरा करके हुआ. And
sugar fasting thyroid ये वाला sugar. अरे यार.
Are you?
May I request organizers to send the introduction or CV of all these speakers? Dr. Rajiv, please send the CV of each speaker so that we can introduce them.
Presently, actually, I don't have right now, but I know Dr. Shaival is an eminent diabetologist of Bihar, and he has done a lot of research work in diabetes, and he's very academic. I gone through many a time during his talk, and I know as a diabetician, he's very excellent. So over to Dr. Shaival, sir.
Yeah, thank you, Dr. Rajiv, for the kind introduction. And respected chairpersons and dear moderator, warm good morning. And simultaneously, I also wish good morning to all the seniors and colleagues attending the webinar. My talk today is about GLP-1 agonists and introduction. I have no declarations to make, and this talk is not sponsored. I would be talking about the evolving concepts in the treatment of type 2 diabetes, how the advent of the GLP-1 agonists changed the scenario of management of diabetes, and how the recommendations of treating diabetes have changed over time over the last couple of years after the advent of these new molecules, and then we'll summarize the talk. over a period of 100 years, we have been treating diabetes, and we are celebrating 100 years of insulin this year. We have got a number of molecules in our arsenal to treat diabetes, and all these have come up in the last 2 or 3 decades. We have been treating with insulin, sulfonylurea, and metformin only for about 50, 60 years, and then we have got new and new drugs today. But unfortunately, something is grossly wrong with this picture. Despite the availability of so many newer drugs and so many promising treatment, we find that still about 75% of the diabetic patients don't achieve the A1C targets which they should. And that is a pity. We have the drugs, we have the doctors, we have the intention to treat, but something is lacking somewhere. Probably is the inertia on the part of the doctor and inertia on the part of the patient as well, and something which is peculiar to a disease, because a disease doesn't cause any symptoms, unlike that doesn't cause any pain or fever or any other excruciating symptoms for which the patient will rush to the doctor. So something is grossly wrong, and that is the basic problem. And that is the reason why diabetes still remains the 9th major cause of death globally. 50% of patients of diabetes present with microvascular complications, 27% have macrovascular complications, and about 1/4 of them have developed diabetic kidney disease. And if we see the life expectancy, we find it's in the world, the average is about 60 years average, and it comes down by about 6 years if the patient becomes diabetic. And if he has diabetes and also has cardiovascular disease, it comes down further 6 years. So diabetes affects the mortality and morbidity, the life expectancy, and more so if it's accompanied by various risk factors, especially coronary heart disease. The scenario is worse in our context. We Indians, unfortunately, are by nature, we are at a higher risk as compared to the Caucasian population. We have higher liver fat, we have higher waist-hip ratio, we have a higher triglyceride levels, higher level of CRPs, and that is the reason why Indian diabetics have about 2 to 4 times increased risk of coronary artery disease. There is about 10 to 20 years premature, this cardiovascular disease occurs about 10 to 20 years earlier in Indian diabetics. 1/3 of us, of Indian diabetics have increased risk of cardiovascular disease, and more than 50% of them of Indian diabetics are young diabetics, they're less than 50 years of age. So that is the scenario. It's a grim scenario in our country. And the best part is, previously, about 3 decades back, we have been treating diabetes by the numbers. We have been treating the sugar numbers only, treating the sugar levels. But then came the realization that glucocentricity is not the only answer. Cardiovascular safety is important. And then the US FDA and other bodies advised to do cardiovascular outcome trials, and then cardiovascular safety was taken into concern. And then finally, the vascular glucocentric approach came, that all the comorbid factors like blood pressure, LDL cholesterol, and obesity, all these factors were also taken into consideration when treating diabetes. And hence, we are gradually, the treatment has become more holistic. And Dr. DiFronzo has initially put up the ominous octet, and then he revised it to the egregious 11, meaning thereby that there are till date 11 different pathophysiological defects in diabetes, and there may be more, but 11 are the main one which he has highlighted, which consist of impaired insulin secretion, increased hepatic glucose production, impaired appetite regulation, decreased glucose uptake, increased glucagon secretion, decreased incretin effect, and increased lipolysis, and increased glucose reabsorption. And out of this 8, almost 5 to 6 of them are defects which are to some extent counteracted by this class of drugs, the GLP-1 receptor agonists. And that is why these class of drugs have suddenly gone up in importance. And we'll discuss how they have evolved over time and how they have changed the management of diabetes. GLP-1 is a hormone which is secreted in response to meal, in response to glucose in meal, and when the glucose reaches in the small intestine, it stimulates the nucleus tractus solitarius in the brain and stimulates the L cells of the gut, to synthesize this GLP-1 hormone, and the receptors are present in brain and in myocardium, in pancreas, in the arteries and arterioles, and the GIT. So as you can see, this is a hormone which is ubiquitous and works across the body in various different organs. And not surprisingly, what we find is that its effect are there in many different organs, right from the GI tract to the pancreatic alpha cells to the pancreatic beta cells, in the skeletal muscles, adipose tissues, blood vessels, heart, kidneys, livers, and brain. So it's a hormone which acts throughout the body, and we have also seen that it blocks 6 out of the 8 different pathophysiological defects which cause hyperglycemia in glucose. So incretin effect was a term which came up about 3-4 decades ago, and it showed that the insulin response to oral glucose load is far more brisk than the insulin response to IV glucose load. That was the basic crux of the incretin effect, and it showed that in healthy controls, as you can see here, the insulin level went up very briskly after oral glucose load, unlike after IV glucose, where the increase was much more slower. But in type 2 diabetes, this brisk response after oral glucose load is the brisk response of insulin level rise is not there as in the healthy control. So there is a deranged incretin effect, and that is one of the major causes which hampers in the first phase of insulin secretion. And if we see the progressive GLP-1 activity and the GLP-1 dependent actions, we find when we see the physiological effect of the GLP levels, this is a normal level of the GLP-1 which is synthesized in response to food. We have been using DPP-4 inhibitors. They basically inhibit the breakdown of GLP and thus prolong the action of the natural GLP. They can't, however, increase the potential, increase the strength of the action of the natural GLP. However, in case of GLP-1 receptor agonists, when they are injected in the patient, we get supraphysiological action of on the GLP levels and the GLP actions. And that is the reason why GLP-1 agonists are much more potent than the DPP-4 inhibitors. And we see that the natural GLP has very limited clinical value because it's rapidly metabolized within 1.5 to 2 minutes, I'm sorry. And what the DPP-4 inhibitor does is just prevents its degradation and prolong the action. However, when we are giving the analog GLP-1 analogs, the action is far stronger than the natural one because they are more potent and the action is more unsurmountable. There are various different types of molecules exist in this class. The question is, are they all the same? And they are not, as we can see in the subsequent slides. Basically, they can be divided into 2 different types, the GLP-1 based therapies and the exendin based therapies. Exendin was found from the saliva of the Gila monster, and it's about 50% homologous to the human GLP, whereas the GLP-1 analogs are about 80 to 90% homologous to the human GLP-1 molecule. All of them are being used in practice, and there are different types of sub-molecules which are in the 2 categories. And certain molecular structure of the large GLP molecules are interesting. They have been combined with human serum albumin to form albiglutide, where 2 GLP molecules are attached to recombinant albumin, so it makes it a large molecule GLP. Similarly, in case of dulaglutide, it's been 2 GLP-1 molecules are attached to the human IgG4 fragment and also becomes a large molecule. All the actions of the exendin 4 derived agonist and the GLP-1 derived agonists are almost the same, barring that there may be some difference will be there. Like antibody formation is higher for the exendin 4 derived agonist. The exact clinical significance is not clearly known, but probably this may lead to increased injection site side effects or sometimes attenuation of efficacy with time when we are using exendin 4 derived agonists because the antibody levels are higher. And if we classify them according to the molecular weight, we find the short acting ones are according to the half-life and the molecular weight. The exendin and lixisenatide are short acting ones, whereas all dumaglutide, albiglutide, semaglutide, exenatide, extended release, they are the long acting ones. And if we see the molecular size, we find the exenatide, lixisenatide have short molecules, small molecules, whereas dulaglutide and albuglutide have larger molecular weight. And if we see the research work which has been done in this, we have seen that the larger proteins such as albumin do not cross the blood-brain barrier, and hence albuglutide or the large acting molecules, where the research, various publications have come out with this, that if we use the GLP-1 agonist with the large molecules, due to the large molecular size, they do not cross the blood-brain barrier properly, and thus may not access the satiety centers. Hence, GLP-1 analogs with a larger molecular weight may not give the same amount of weight benefit by virtue of their lesser action on the satiety center as compared to the ones with a smaller molecular size. Also, the duration of action is very important. We need the GLP-1 agonist for 24 hours, because if it's for a short duration like 16 hours, after that period, again, the plasma glucose levels come back to normal, to the pre-drug levels. So at 24 hours, GLP-1 level is needed for proper action. If we classify them according to the half-lives, the exenatide and lixisenatide are the short-acting ones. Then we have the intermediate and long-acting ones like liraglutide, dula, albuglutide, semaglutide, and exenatide once-weekly ones. And ITCA 650 is a unique delivery mechanism where exenatide is imbibed in an osmotic mini pump, and it's put up in a subcutaneous space, and it continuous delivery of exenatide is done for 3 to 6 months. So if we see the short-acting versus long-acting and compare their various parameters at a glance, we find that if we see the control of fasting glycemia, it's more strong with the long-acting ones, whereas control of postprandial glycemia is more prominent with the short-acting ones. Frequency of dosage obviously is lesser with the long-acting ones. Combination with basal insulin can be done with both of them, and all of them have a complementary effect. Combination with premix insulin also may be done with both of them. Fasting insulin secretion, there's a strong stimulation with the long-acting one as compared to the short-acting molecules. Similarly, the GI symptoms or the GI side effects are also more with the short-acting ones. GI emptying rate is more prominently lowered with the short-acting ones and gradually wanes out in the long-acting ones. Nausea is slightly more in the short-acting and attenuates later. It attenuates faster in the long-acting molecules. Pulse rate is almost same, but there's a small increase with the short-acting ones. Then use as directly observed therapy can be given with the long-acting ones, where it can be given once a week or so. So these are the basic differences. Various different trials, clinical trials have been done with that. We won't go into the details. We have the different trials and the different molecules here. And GLP-1 is unique because various head-to-head comparative studies have also been done, and 8 major studies need to be mentioned, like the LEAD 6, Duration 6, Harmony 7 study, Award 6 study, the Duration 1 study, Duration 5, Get to Goal X study, and the Award 1 study. So we are not going into the study details now. It's basically an introductory talk. So, and if we compare the A1C reduction, all of them are almost equally good. The point notably, exenatide once weekly and liraglutide lowered the A1C more. If we see the weight loss action, again, liraglutide and exenatide once weekly are quite more potent slightly, but all of them are effective in reducing weight. And if we see the GI side effects, especially the nausea, which is the most prominent side effect among all of this, we find that the long-acting ones, especially the once weekly ones, exenatide, albuglutide, and dulaglutide, have lesser of GI side effects as compared to the short-acting ones. And a comprehensive review head-to-head has shown that liraglutide relatively offers a better A1C and weight reduction, while the once-weekly agents may cause lesser GI side adverse effects compared with the once-weekly ones. Coming to the cardiovascular effects, there are various effects. It increases cardiac output, increases myocardial contractility, increases endothelial function, increases glucose uptake, heart rate, and increased ischemic tolerance, increased cardioprotection, increased plaque stability, reduces blood pressure, reduces arterial stiffness, and reduces vascular inflammation and platelet aggregation. So there are various of actions which, and all of this ultimately lead to various advantages. As we can see in the LEADER trial, there was a 13% reduction in MACE, 22% CV death reduction, 12% non-fatal MI reduction, and 11% reduction in non-fatal stroke. And if we see compare the different cardio-CV outcome trials, we find that the liraglutide and the semaglutide perform better than the others as far as the cardiovascular benefit was seen. And these two molecules show significant risk reduction in all the three categories, whether it's 3-point MACE or cardiovascular death or all-cause mortality. And a lot of noise has been made about the SGLT2 inhibitors and their cardiovascular benefits in the recent years. However, if we see here and compare the CV outcome trials of GLP-1 agonists with those of the SGLT2 inhibitors, we find that more number of patients have been tried in this GLP-1 CVOTs, 56,000 as compared to 42,000 in the SGLT2 trials. And mean risk reduction was 12% with GLP-1 agonists, whereas mean risk reduction was 10% with SGLT2s. So GLP-1 seems to be a silent worker, more beneficial for the heart as compared to the SGLT2. And if this is further corroborated when the number needed to treat is seen, much lesser numbers, just 75 numbers are needed to treat when 3-point MACE reduction over 3 years was studied as compared to 97 for SGLT2. So definitely much more beneficial. And then we know the action by how it works for the heart. Weight reduction, body weight comes down with all of them, and most of the trials have shown a beneficial effect in weight reduction. If we see the renal benefits, there are certain direct effects like natriuresis or hemodynamic effects or reduced oxidative stress or anti-inflammatory effects or anti-fibrotic effects, and certain indirect effects like improved glycemia, improved blood pressure or weight loss. So all of this help in achieving direct or indirect benefit to the kidneys. And that is the reason why some of the trials like the LEADER studies and the SUSTAIN-6 studies have shown definite benefits in the UACR ratio. In the LEADER study have shown that liraglutide reduces UACR. Again, the same has been shown by semaglutide in the SUSTAIN-6 trial. So definite renal benefit by reducing urinary albumin excretion. So that has changed the rules of the game from diabetes, from being the glucocentric ones. Various guidelines have changed over the time. They have now showing personalized treatment and cardiovascular risk focused approach. Now we know that if there is a presence of atherosclerotic risk and the patient is on dual multiple drugs, the guidelines suggest that we should switch over to a GLP-1 agonist or an SGLT2. If the patient already has cardiovascular disease, then irrespective of his presence of metformin or his baseline A1C or his individualized A1C target, we should always start a GLP-1 receptor or an SGLT2, and we may stop some of the old drugs if needed. Then what are the indications of GLP-1 indicators? If the patient has high CV risk or has clinical ASCD risk, in these patients, if the patient is diabetes and there is a diagnosis of clinical ASCVD, we should use GLP-1. Conversely, if the patient has clinical ASCVD and he is diagnosed with diabetes, again, there is a role for GLP-1. And if the patient is discharged from a hospital where he was admitted for ASCVD with or without diabetes, then again, he needs GLP-1. However, there are certain indications where even if the patient doesn't have clinical ASCVD, CKD, or heart failure or diabetes, but even in those cases, GLP-1 is indicated. Those are cases where there is a compelling need to minimize hypoglycemia, or there's a compelling need to minimize weight gain or promote weight loss, or where there needs to intensification to injectable therapy or basal insulin therapy when the patient is already on basal insulin. So in these patients, even if the patient of diabetes who doesn't have clinical ASCVD, GLP-1 agonists are indicated. So coming to summary, to summarize, we know that the prevalence of ASCVD is very high in type 2 diabetes population. And unfortunately, majority of patients are being managed by drugs which don't have proven cardiovascular benefits. And this is all the more bad in the Indian scenario. Indians are at a higher risk for CVD as compared to the West. So in the Indian setting, GLP-1 agonists can be placed much earlier in the therapy of type 2 diabetes to mitigate and minimize these complications, in addition to the benefits across the spectrum which we have seen. And hence the guidelines recently have recommended personalized and cardiovascular and renal risk focus approach, and have much stepped up the position of the GLP-1 agonists as compared to the guidelines 3-4 years back. And then relatively liraglutide and semaglutide are the two GLP-1s which have a better CV risk reduction as compared to the others. So thank you, and I'm open to any queries. But I would like to the questions to come in the chat box in the interest of time. Thank you, everybody.
So, Dr. Shahwal Goa, it's a nice presentation. Thank you for such a elaborate and very fine explanation of all these new GLP-1 receptor agonists. And we hope many of the doubts will have been clarified. Now, may I request our other co-chairpersons to introduce the second speaker of the session, Dr. S.C. Jha, for intermittent fasting, facts and fads. My co-chairperson, Dr. Ravindra Kumar Sinha and Dr. Subodh Kumar. Anyone here? Yes. Dr. Ravindra Kumar Sinha and Dr. Saurabh. Not present. So may I introduce Dr. May I have the opportunity to introduce Dr. S.C. Jha, MBBS from Calcutta Medical College, MD from Patna, DNB Medicine, Associate Professor, Department of Ganga Medical College, Bihar, noted speaker on the state and national forum, publication in different journals, guide to research work of MD students, honored as the best speaker of API Bihar chapter for the year 2018 and 19, in recognition of contribution towards CME under the banner of API Bihar, author of chapters in medicine, update API. So, most welcome, Dr. S.C. Jha.
Honorable colleagues, a very good afternoon, and thank you, Chairperson Dr. P.K. Sinha, for nice introduction, and thanks Dr. Rajiv Ranjan and team for giving me the opportunity to speak in this august audience. Friends, Shahwal Goa had a wonderful presentation. He told one thing, that for 50 to 60 years, diabetes was managed by sulfonylurea and metformin, and it is only in the last 2 to 3 decades that the other medicines have come. Yes, today we have got a large amount of medicines to combat diabetes. Our understanding of pathophysiology and treatment of diabetes and other non-communicable diseases like obesity, cardiovascular disease, cancer has increased. But see the paradox. The understanding has increased, the knowledge has increased, but there is increasing number of cases as well. That is the paradox. So, some link is missing somewhere, as Shahwal said. And hence we are on the constant search for novel methods. Recently, there has been unprecedented global interest and attention in intermittent fasting as a means to reduce weight, especially losing fat and regulate metabolism. However, the topic is very controversial one. While some authorities believe that this is perhaps a new means to control the tsunami of non-communicable disease, others believe that this is just a fad. And with the passing of the time, and with the lack of evidences, it will be thrown into the dustbins of the history. As far as the evidences are concerned, there are rodent studies pointing to good clinical and biochemical outcomes, but paucity of evidence is there in the human beings. If you search the net, it is overloaded with the literature, anecdotal experiences of individuals and a small study. So, let us see what is intermittent fasting. Friends, intermittent fasting is not a type of diet. It is the pattern of eating. Cycle between fasting and feasting. Various schedules have been suggested. It doesn't suggest what we are eating, but when we eat, that is important. Though modifications in recent times have been suggested, taking into consideration newer concepts of intermittent calorie or energy restriction and time restriction feeding. Non-calorie drinks, however, may be allowed during fasting window. Is the concept of intermittent fasting a new one? Of course not. It has been practiced since ancient times by all religions across the world, be it Hindus with Ekadasi, Purnima, Santoshi, Mata Vrat, Navratri, Shivratri, etc. Roja for Muslims, and all religions have their own quota of intermittent fasting. We are directly going into the most popular method. 16/8 is the most popular method. 16/8 means 16 hours fasting window and 8 hours eating window.
5:2 diet, 500 to 600 calories twice a week. Eat that 24 hours fast once or twice a week. Warrior diet, just one meal and big meal and all calories in 4 hours. Factors which are hypothesized to influence metabolic regulation via effects on circadian biology, the gut microbiome, and modifiable lifestyle behavior like sleep, locomotion, energy intake, and consumption. Now, we all know that various organisms on this globe have evolved an endogenous circadian clock over a period of evolution to ensure that certain physiological processes are performed best at optimal times. In mammals, the master biological clock is in the suprachiasmatic nucleus of hypothalamus, which is entrained to light and dark stimuli. Remember the ancient man. He used to hunt all day around in the light time, and in the dark time, when the evening set in, he used to take rest in his cave. Desynchronization of suprachiasmatic nucleus, master clock in the brain, and peripheral circadian clocks, which also exist in the periphery, in like liver, fat, and skeletal muscle cells, may increase the risk of chronic disease. This is the picture which shows we can perform certain functions best at particular period of time. Like great cardiovascular and muscle strength is in the afternoon. Highest blood pressure is in the evening. Highest body temperature around 6 o'clock. Melatonin secretion starts around 8 or 9 p.m. And deepest sleep is around 2 a.m. Like this, so on and so forth. Now, this chart shows us that during wake or feeding period, certain functions are more important. They are more dominant, like in liver, glycogen, cholesterol, and bile acid synthesis, insulin secretion in pancreas, lipogenesis, adiponectin production, glycolytic metabolism. During sleep and fasting time, other features, other metabolic functions are dominant, like gluconeogenesis, glycogenolysis, mitochondrial biogenesis, glucagon secretion, lipid metabolism, and this leptin secretion, etc. Now, it is hypothesized that intermittent fasting regimens synchronizing with 24-hour light-dark cycle may lead to improved oscillations in the circadian clock gene expression and reprogramming of molecular mechanism of energy metabolism and thereby improving body weight regulation. Friends, we all know that insulin sensitivity decreases throughout the day. In other words, insulin resistance increases throughout the day and into the night. And on top of that, there is anti-insulin action of growth hormone. The growth hormone, the pulsatile concentration of which increases at night. That is why meals consumed at night are associated with greater postprandial glucose and insulin exposure. And what that leads to? It leads to increased glycosylated hemoglobin levels and risk of type 2 diabetes. Now, we know now that this gut microbiota, which are approximately 100 trillion in number, they are complex and diverse, and their composition perhaps are very important for optimization of this metabolism. Intermittent fasting may directly influence the gut microbiota. Time-restricted feeding in mice, in which food is available only during the nocturnal active phase, partially restores these physiological cyclical fluctuations in the different studies. So fasting regimens appear to have positive impacts on the microbiota. Now, there was a study in 8 overweight young adults which found that increasing the nightly fasting duration beyond 14 hours resulted in statistically significant decreases in energy intake and weight. Common sense that if the eating window is reduced, naturally energy intake will be reduced. And what that leads to? Sleep satisfaction, satiety at bedtime, and energy levels. Even a one-day fast or 75 calorie restriction was shown to reduce calorie intake by approximately 30% during the subsequent 3 days. Benefit on the day of fasting and even on the subsequent 3 days. And a statistically significant weight reduction was observed in 73% of the trials of intermittent fasting. Now, rodent studies have demonstrated that time-restricted feeding regimens increase locomotion, improve circadian activity rhythms, which are indicator of overall rhythmicity. However, I again remind you that data in human are sparse about whether intermittent fasting regimens impact energy expenditure among free living adults. Nighttime eating is associated with reduced sleep duration and poor sleep quality, which can lead to increased insulin resistance and non-communicable diseases. Eating meals at abnormal circadian times, that is late at night, is hypothesized to lead to circadian desynchronization and subsequent disruption of normal sleep patterns. Now, what are the contraindications? Obviously, we are not going to give it to the pregnant women because that might affect blood sugar level, baby development, and general health. People suffering from heart problems or high blood pressure should not be allowed intermittent fasting. Children and adolescents, because that might impair the nutrients absorption growth. Not suitable for those who have got eating disorder or psychiatric disorders. Now comes the million-dollar question, whether diabetics can fast. Some studies suggest fasting may be helpful for people with diabetes, particularly less than 5 years duration, but it is not a mainstream treatment. American Diabetic Association, for now, doesn't recommend fasting as a technique for diabetes management. Friends, Sawal Guha talked about a lot of molecules coming in last 2 to 3 decades. We have got a lot of modalities of treatment. You just consider all modalities of the treatment and the studies related to that. Is there any modality of the treatment which is more effective than very low calorie diet and bariatric surgery, and which have sometimes resulted in reversal of diabetes? And what that suggests, the success of very low calorie diet and bariatric surgery suggests that solution to this complex disease, ominous octet and whatnot, lies in diet and lifestyle in type 2 diabetes mellitus rather than drugs, and we should aim possibly more at insulin resistance rather than blood glucose. What happens? Metabolic switch is there. If we extend our fasting period to more than 12 hours, there is depletion of glycogen stores in liver. And free fatty acids, beta hydroxybutyrate and acetate in liver energy by beta oxidation. Naturally, when fasting is there and when glucose is not there, it will shift to the fat metabolism. And there will be a reduction in insulin resistance and inflammatory marker. It also promotes cellular repair and autophagy. Friends, autophagy is a very interesting physiological process when your body consumes defective tissue in order to produce new parts. And for this concept, 2016, a Japanese biologist Yoshinori Osumi won a Nobel Prize for discovering this. Loss of weight, particularly fat, lowers bad cholesterol and optimization of metabolism, protection against neurodegenerative diseases like Alzheimer's and Parkinson's, improvement of memory, and boosting brain functions have all been suggested. Each of these effects result in decreased vascular function and would therefore be expected to improve cardiovascular risk and mortality. This was a very small study of 3 cases published in BMJ. The case series documents 3 patients referred to intensive dietary management clinic in Toronto for insulin-dependent type 2 diabetes. It demonstrates the effectiveness of therapeutic fasting to reverse their insulin resistance, cessation of insulin therapy while maintaining optimal glycemic control. In addition, these patients were also able to lose significant amount of body weight, reduce their waist circumference, and also reduce their glycated hemoglobin level. Now, this study, the effects of 1-week fasting therapy in patients with type 2 diabetes mellitus and metabolic syndrome, a randomized control explorative study was done, and that pointed to beneficial metabolic effects of 1-week fasting therapy in persons with type 2 diabetes mellitus over 4 months of period. Larger randomized trials are, however, required because this was a study of only 32 patients. So what are the key learning points? Medically supervised therapeutic fasting regimens may help reverse new type 2 diabetes mellitus and minimize the use of pharma agents. Therapeutic fasting remains an underutilized dietary intervention that can provide superior blood glucose reduction compared with standard therapies. Fasting is a practical dietary strategy, and with proper education and support, we have found compliances to be good. Of course, the studies were very small ones. Patients with diabetes who are interested in intermittent fasting must have guidance from a healthcare practitioner, physicians, assistants, and certified diabetic educators. And special attention must be paid to three considerations: medicine adjustment, particularly when insulin and secretagogues like sulfonylurea are used, and frequency of glucose monitoring should be more so that the patient doesn't pass into the extremes of glucose control. And fluid intake should be taken care for, particularly in molecules like SGLT2 inhibitor, where dehydration is very common. Unless we specifically ask the patient to take additional fluids, we are actually reducing their total fluid intake due to reduced intake of liquid foods such as soups, yogurts, or melons. In this case of risk of dehydration and hypotension increases, we need to reduce or withhold their intake of diuretics, SGLT2 inhibitors, or regulate antihypertensive medications on the days of fasting. So the take-home summary, friends, is the benefits and risk in human remains largely unexplored. Good evidences from epidemiological studies, pilot interventional trials, and a few randomized trials does suggest that benefit of fasting outweigh possibly the potential harms in average individual. Diabetes we should try only when it is a new onset type and with utmost precaution and under close medical supervision. Without proper medication adjustment and self-monitoring, the blood glucose levels low. Intermittent fasting, with proper medicine adjustment should be done. Self-monitoring of blood glucose levels becomes very important, and then intermittent fasting can possibly be encouraged and safely implemented in early diabetes. Take-home summary is old concepts do change. Remember, friends, once upon a time we believed that Earth was flat, and the scientist who said it was not, he was jailed and possibly guillotined. Once upon a time we believed that our arteries contain air, not blood. It was William Harvey who showed it contains blood. So concept may change tomorrow. Intermittent fasting hold promises for a good health. Good evidence-based studies, however, with open minds are welcome. Maybe tomorrow it will emerge as a powerful therapeutic tool against the ever-burgeoning number of patients with non-communicable disease. Thank you.
Well, a very nice talk, elaborative talk on intermittent fasting. Dear friends, ladies and gentlemen, in India, as a customary, we are practicing intermittent fasting in the name of worshipping and likewise, कोई Sunday को तो कोई Monday को तो कोई Tuesday को कोई एतवार कर रहा है. Probably, I think our ancestors have recognized the benefit of the intermittent fasting and so put this in practice in another way. So we must recognize this, the better part of this intermittent fasting, and in future we may be using this as a therapeutic tool, as Dr. Sujha strongly suggests or proved it by the scientific facts. So thank you very much, Dr. Sujha. So we cannot continue with the question and answer session. Now may I again invite our co-chairpersons to go for Dr. C.V. Prasad, Ravindra Kumar Sinha, Subodh Kumar is there? No. So may I welcome Dr. So may I Dr. C.B. Prasad for role or relevance of the current era of OHA. He is the Secretary of API Bihar, Sitamarhi chapter. He is Scientific Secretary API Bihar, Sitamarhi chapter. Joint Secretary API Bihar 2015 to till now. Currently practice at own clinic, Diabetes and Research Center, Sitamarhi Bihar. academic qualification, MBBS from Ranchi 1982, MD again Ranchi 1988, and DT and from Darbhanga, Bihar. He has participated as Secretary of API Bihar. So he is a life member of many associations like ADS, CSI, RSSGI, and executive member of API Bihar, and so many personal details. Well, now may I request or welcome Dr. C.V. Singh on behalf of all the audience and friends and API Bihar. Dr. C.V. Prasad, please.
You are sharing, screen sharing.
Good afternoon, and I thank first of all to our Dr. Rajiv Ranjan for giving the opportunity on this August forum, and I thank Dr. P.K. Sinha for giving me so much of importance. My slide is visible, sir?
Yes, visible. Only enlarge it or slide presentation. No, yes. It is not coming in the format of slide presentation. Go to the cup on the side, yes. No, cup on the side, yes. Cup. Cup by the side, yes.
This one, sir?
Yeah, now.
Now it's visible, sir?
Yeah, it is visible. Nice.
Okay, thank you, sir. Topic assigned to me, good afternoon, and I thank to Dr. Rajiv and API Chapra chapter for giving me the importance, giving me the chance to speak on this August, before August audience. The topic assigned to me, the role and relevance of sulfonylurea in the current era of OHA. Since the last 3 decades, we are having 3 drugs in our armamentarium, that is insulin, metformin, and sulfonylurea. Insulin is always there, and metformin was well established after UKPDS trial, and sulfonylurea was subdued by gliptins and SGLT2 inhibitors. So my talk is regarding the importance of sulfonylurea. I think none of our seniors and respected seniors and colleagues have never ever used sulfonylurea in their practice, clinical practice life. So coming to timeline of major events in evolution of sulfonylurea. Am I audible, sir? First report of hypoglycemic activity of sulfonylurea was seen in 1937, where sulfur drug responsible for stimulation of insulin from pancreatic beta cell established. And coming to first generation of sulfonylurea established, approved in 1950, and after a gap of 45 years, third generation approved. What is the difference between the first and second generation and third generation? First generation was tolbutamide, chlorpropamide, second generation glibencla, gliclazide, and third generation glimepiride and gliclazide MR. So difference between the second and third generation sulfonylurea was 20 to 50% more potent, prolonged half-life, lesser side effect, including hyponatremia and disulfiram effect, lower risk of hypoglycemia. The omnious octet, now it is not omnious, it is a number of number is increased. The pollution and toxic materials, now it is 10 octet, not a omnious octet. The pollution and toxic agent is also causing diabetes mellitus in the modern world and modern society. Then coming to mechanism of action, inhibition of this potassium channel induces beta cell membrane depolarization, which opens voltage dependent calcium channel, leading to an influx of calcium and stimulates insulin secretion via sulfonylurea receptor or SORB. Then PKD and PD profile is almost same, but with the third generation sulfonylurea, the action of the drug is more than 24 hours at 24 hours, where the PK change is not interacted with CYP290 and not significantly change with the renal and kidney problem. What about the placement of the sulfonylurea? Initial therapy when the contraindication to metformin, it is a monotherapy as used. Intolerance to metformin, high blood glucose at the level when the present patients. Second line add-on therapy in inadequate glycemic control. Subsequent add-on therapy add-on to combination inadequate glycemic control with the metformin alone. A special consideration is biological factor age more than 60, renal impairment when the EGFR is up to 30%, neonatal diabetes, MODI theory, almost 10 varieties of different, 10 different variants of MODI is there, but the MODI theory is very much affected by the use of, very much controlled by the use of sulfonylurea. It is seen that some patient, it is well written in the Harrison book, that in some patient of type 1 insulin, that was type 1 insulin, but if it was of MODI 3 variety, the patient respond to sulfonylurea. And regarding psychological factor, Ramadan is there, glucose phenotype when fasting prefer, and postprandial short acting. Various landmark trials have been done with UKPDS, advanced adopt, advance on VAT, and all trials were done. The VAT trial have shown that was used glimepiride as an intensive versus standard care, and there was 2%, more 2% reduction in the glycated hemoglobin HbA1c level. And at the 10 years of time, there was a decreased risk of CV risk. Comparison of various outcome trial with sulfonylurea is control group was done because Severtimi examined trial in all the recent CV outcome trials, the control group having sulfonylurea as a major drug did not show any CV worse CV outcome. It is a modern sulfonylurea is very much cardiovascular safe as examined Impare, Carmelina, Carolina, TICOS leader, and declared TIMI. All trial have shown that more than 50% patients are on sulfonylurea. In the recent cardiovascular outcome trial, have shown that it is a cardiovascular safe trial. Meta-analysis of 14,7 RCT centers reported that sulfonylurea are not associated with increased or all-cause mortality, CV mortality, MI, or stroke. The patient previously receiving gliclazide or glimepiride have improved hospital outcome in compared with older generation glimepiride, first and second generation glimepiride, and no hazard associated with the use of sulfonylurea before an acute episode. Now, glimepiride is not associated with mortality rate in type 2 patient with a CAT. Overall mortality in the subgroup of type 2 patient with CAD treated with SU monotherapy has been very much less. Comparison between mortality and the sulfonylurea comparative first and second generation and third generation, we can see the shifting of the favorable picture. Newer sulfonylurea has been seen shifting towards the safer side of the CV mortality with glimepiride and glimepiride. Risk of associated with the initial treatment with the sulfonylurea, initiating treatment of type 2 patient of gliclazide is associated with increased risk of CAD comparison to gliclazide to glimepiride. When the coming to the long-term effect of the outcome of various trial, UKPDS trial, and all have shown that any diabetes-related endpoint reduced to 9%, microvascular disease 24%, MI 15%, and death cause from all the reasons 13%. So glimepiride have shown continued reduction in the microvascular risk and engage emergent risk reduction in MI and death from any cause during the past 10 years of the post-trial follow-up. Then coming checking the cardiovascular risk and mortality, a systematic review and national meta-work analysis was done. Lower risk of all cause and cardiovascular related mortality was seen with glimepiride in comparison to glimenclamide. From clinical perspective, difference in risk of mortality should be considered. So it should be considered when selecting a sulfonylurea. The most deserving and supportive trial was, this trial Carolina was done for gliptin, linagliptin, to boost up its importance. But after head-to-head trial with sulfonylurea, Carolina study have shown cardiovascular outcome study of Lina versus glimepiride have shown a multinational randomized trial, double-blind active control trial, that in adult with type 2 diabetes, in that 43 countries involved, more than 600 sites involved. Duration of the study was more than 6 years, and the trial have shown that Carolina trial have shown that glimepiride is not inferior to linagliptin. So it, and hazard ratio was 0.9%. Confidence interval was 0.84%. So we can imagine that glimepiride is not less effective or not causing any CV problem as it was thought. So in comparison of linagliptin, glimepiride was safe. So same result were reported with the Carolina trial, and evidence from RCT based on second generation sulfonylurea suggests no CV risk. So UKPDS adopts advanced record and toxicity trial all soon. The baseline characteristic, all the types of patient, 3P MACE, cardiovascular risk patients, atherosclerotic, macro and microvascular patients were taken. In Lina and glimepiride, head-to-head trial was done, but it was found that CV outcome with the glimepiride is not bad with the glimepiride. Same first primary cardiovascular event in outcome trial have shown that it was shown that it was reduced. Then time to 3-piece mesh in point, time to cause all-cause mortality, and 3-piece mesh was lesser with the glimepiride. We can see the red line is glimepiride and blue is the linagliptin. So we can see that 3-piece mesh improvement is there. So Carolina met its primary endpoint defined as non-inferiority of linagliptin as compared to in comparison with the glimepiride in the first occurrence of CV death, non-fatal MI or non-fatal stroke. And linagliptin demonstrated no increased CV risk compared to glimepiride in adult with type 2 study. So it shows that linagliptin is not, glimepiride is not inferior to gliptins or linagliptin. With sulfonylurea, pre-ischemic conditioning was seen. Then its effect on SD segment shift balloon depression after the maximum SD segment depression reduced after repetitive balloon occlusion of coronary versus glimepiride and placebo application, but no change seen during the glimepiride administration. It reduces all-cause CV mortality. A meta-analysis was done. So sulfonylurea, the meta-analysis from 47 RCT centers have shown that it is not associated with increased CV mortality. Same thing is there. We can see the Kaplan-Meier survival analysis. Glimepiride is much more effective than the glibenclamide and rifaglenide. Macrovascular outcome, advanced and head trial have shown that intensive glycolizide MR or glimepiride metformin versus standard care long-term follow-up, there is very much macrovascular complication is not there. We are very much afraid of using sulfonylurea due to its hypoglycemic effect, but it was seen that with third generation sulfonylurea, the response is the incidence of hypoglycemia is 6 to 7 times less with the third generation sulfonylurea in comparison to older first and second generation. Then increase in adenopectin is there. Adenopectin causes high molecular weight increase. Adenopectin is also referred as GPP28 or AdipoQ, is a protein, hormone, and adipokine, which also involve in regulation of the blood glucose level as well fatty acid production. So it increases serum high molecular weight production, and so it causes adenopectin increase, and the glycated hemoglobin is reduced. So effect of glimepiride on biomarkers is there. Fractalkine and MG, GSF, GM all are reduced. Coming to the recommendations, IDF 2017, WHO, ICMR, SAPS all recommend sulfonylurea after metformin if not sufficient. We can't escape from this slide also. ADA has also shown that in the first line therapy with the ASCVD or CKD patient, you have to start with SGLT2 inhibitor. But if HbA1c is not controlled, the sulfonylurea is always there. It is not out of the chart. It is there if the HbA1c is not controlled. We can see in the chart that sulfonylurea, thiazolidines, and gliptins is there if the HbA1c after SGLT2 inhibitor is not controlled. But in India, like a developing country, when cost is a major issue, coming to cost, if the cost, we have to see the pocket of the patient. We can't give patient all the patient SGLT2 inhibitor and DPP4 inhibitors due to cost of the drug. By seeing the and efficacy is there, so if cost is major issue, ADA has recommended sulfonylurea the first drug of choice. But in the chart of this ADA, sulfonylurea is not out of the scene. It is there if with the SGLT2 inhibitors, if the glycated hemoglobin is not controlled, we have to add SGLT2 or thiazolidines. So, colleagues, coming to the conclusion, newer sulfonylurea are not associated with low risk of all-cause and CV mortality. Newer sulfonylurea, third generation, are associated with low risk of CAD. Newer sulfonylurea and especially glimepiride may be preferred in patients with underlying CAD. Among all sulfonylurea, mortality is lower with the glimepiride, and in long-term CV outcome trial, glimepiride-based combination therapy is better than glibenclamide. Myth and busters, low risk of hypoglycemia. We have seen the slide that risk of hypoglycemia with the third generation sulfonylurea is 6 times less with the older generation. And efficacy in micro RCT centers reports that trials have shown, PCOS and adopt and advanced trial have shown that lowering micro and macrovascular combination. One myth was also there, it causes beta cell exhaustion. It results in progressive loss type 2 diabetes when it is detected. 40% of the islet beta cells are already it is destroyed. So it doesn't causes progressive loss in beta cell function. Treatment with some modern sulfonylurea is associated with lower economic burden, and it is cheaper, availability is much more, and accessibility, availability, and the cost is a major issue. Thank you. Thank you. Thanks. I think my time is over.
Thank you, sir. Thank you for your excellent talk. Now, since we are already late, Dr.
Sir, Hall A is continuing with Dr. Shambhu Saran's oration. Dr. A.N. Rai is delivering. And thereafter, we will have this session continued here. So, which is almost about to finish. So, people who are here in this hall can very well continue with the next session, which is an Apollo Symposium. Dr. Rajiv Ranjan, can you call the people who are, responsible for the next session, please? Dr. Devi Ram sir and the chairperson, please.
Okay. Okay, because we are running late, so should we start next session?
Yes, sir. Definitely.
So for this session by Apollo Kolkata Symposium, this is the speakers are Dr. Amarnath Ghosh and Dr. Ramadeep Rai, Dr. Manish Kumar Jain. So all three are eminent speakers. They will speak on different aspects, especially on minimally invasive cardiac surgery, newer innovation and approach by Dr. Amarnath Ghosh. Another talk by Ramadeep Roy is on liver transplant, and next talk is management of CKD by Manish Kumar Jain. So my moderator, Dr. Sanjay Kumar Misra, has joined us. Now I'm giving him opportunity to take this session. Yeah, Dr. Sanjay Kumar Misra, just unmute yourself. Yeah, unmute yourself. Please unmute yourself. Yeah. So Dr. Sanjay Kumar Misra is an eminent gastrosurgeon. Yeah.
Hello.
Yeah.
Hello.
Yeah. We are listening.
Yes.
Yeah.
On behalf of BAPICON 2021, I welcome all of you to city of Chhapra, one of the oldest city in Bihar and in North India. It is a great privilege to welcome all of you. Now, I would like to invite Professor Arvind Kumar. Hello.
Yeah.
I would like to invite Mr. Dr. Amarnath Ghosh will come and deliver a talk on minimally invasive cardiac surgery, newer innovation and approach. I would like to call upon Dr. Arvind Kumar as the chairperson for the above meeting. Am I audible, sir?
Yeah.
I think you are audible, yeah.
I invite Professor Arvind Kumar to come and take seat on the dais. Dr. Amarnath Ghosh as the speaker.
Yeah, Dr. Arvind Kumar is presently not there. So we can continue Dr. Amarnath's talk. Yeah.
I request Dr. Amarnath Ghosh to start delivering the prestigious Kolkata Symposium on the minimally invasive cardiac surgery. I have one sentence to submit. Minimally invasive surgery has really revolutionized the treatment of the cardiac surgery. So as it has done for the abdominal surgery as well. From the days long period of admission to 1 to 2 day care of surgery. And Dr. Amarnath Ghosh has contributed a lot for the above things. It is really nice to watch him. It is really nice to listen to him. May I request Professor Amarnath Ghosh to start delivering the lecture.
Good afternoon, everybody. At the outset, I would like to first of all congratulate and give our sincere thanks to the BAPICON 2021 organizer from Chhapra, because they have organized this conference in such a difficult time. That is my first gratitude I want to pass to them because it's a very extraordinary story. You all remember that this conference was supposed to held in the month of probably April before the preceding second wave. And what a sort of devastation happened after that, we are all aware, particularly from Bihar. A large number of doctors have went down and they died during this second wave. So my sincere condolences to them as well. Thirdly, I have got quite an emotional attachment with Patna and Bihar because I am trained as a doctor from MBBS from Patna Medical College. I did my MS General Surgery under Dr. Narendra Prasad from Patna Medical College. So we have worked with those stalwarts, Dr. Prasad, Dr. Hai, Dr. Anand Prasad Singh, Dr. Motilal Singh. Those are the stalwarts which has actually given us a lot of clear-cut understanding of the subject, their discipline, their dedication, which has helped us to shape our professional career. So my sincere respect and gratitude to those stalwart surgeons. Now with this background, let us come down to minimally invasive cardiac surgery. First of all, can we have the presentation, please? Just 1 second, can we get the presentation? Just give me a second, please. Put it in the slideshow. So first justification is, can everybody see the slides, please? Is the slides visible? Hello? Hello? Dr. Mishra, is the slides visible there?
Yeah.
Okay.
Yeah.
So first of all, we would like to justify that why MICS cardiac surgery is being done. Now, if we try to understand that, can we put the slide on this side that's been covered? Just organize the slide a little this way.
एक ऑपरेशन हम लोगों ने स्किप किया ना, अब टाइम वो हो जाएगा.
Just put on the slide, go there and put it on the slide. Put it on the slide. No, the slides are getting covered. This part is not seen. Okay. So why MICS cardiac surgery? Now we all can understand that complex cardiac diseases, many of them require the final treatment is cardiac surgery. Now this cardiac surgery was being done traditionally by a full sternotomy, that is dividing the sternum into two parts. This procedure was being well tolerated by most of the patients, and this was going on for ages. But lately we realize that this procedure becomes a huge problem for those patients who are having advanced age, poor debilitated conditions, and serious comorbidities. If we elaborate these patients, these are the group of patients, those who have got a long-term steroid use, severe COPD, advanced age, need for other major operative procedure. So these are the, our patient is severely deconditioned. So these are the patients, if they undergo this sort of surgery, they get into trouble. Now, why they get into trouble? Now, let us go back to a little bit of anatomy. When we see our chest cage, then we realize that there are 2-3 things which are integral part of it. One is our sternum, another is our rib, and third is our vertebral column. The rib is attached to the sternum in front, and behind it is attached to the vertebral column. Now, once the sternum is divided, then in that condition, the stability of this chest cage is compromised. As a result, the respiratory dynamics is compromised. So these patients, when we try to take them out from the ventilation, then due to this poor respiratory dynamics, we are unable to do so. So what happens that these patients then put on long-term ventilations, leading to ventilator-associated pneumonias, malnutritions, ventilator dependence. So these are all bad news for a patient, because if this is happening, then these serious patients with comorbidities are likely to have a prolonged hospitalization, complications, and most of them will lead to mortality. So this is the dilemma, that a high-risk patients undergo a cardiac surgery where it should be exposed minimal time for ventilation. Unfortunately, these patients are caught in the prolonged period of ventilations, leading to serious consequences. So how MICS is going to solve this problem? The common sense says, avoid the sternum. Don't cut the sternum. So it will provide the stability. So that is the first thinking. And that's why the MICS approach, when we are doing towards the cardiac part, we are centering our incision on the left or the right side to a small mini thoracotomy between the ribs. That is the one approach. And by chance, if we have to cut the sternum small, minimal. So that's why it's called mini sternum. So these are the two approaches which are helping at the foundation of minimally invasive cardiac surgery. So in short, this justification part, I would like to emphasize very strongly that MICS is not all about cosmetic surgery in cardiac surgical practice. MICS actually approach rather benefits those patients who are at high risk to undergo the procedure through the full stenotomy. So it's extending the benefit of surgery to this high risk of patients through the MICS approach. We all know that CABG is the most commonly performed cardiac surgical operation. So obviously MICS CABG has brought a paradigm shift among the patients requiring CABG. Initially, we were moving very cautiously. We started with a single vessel Lima LED grafting. Then we become a little bolder. We started doing double vessel grafting. Nowadays, we are doing multiple vessel grafting through this particular procedure. But this procedure is not accomplished by the surgeon alone. We need a very good tight team. A role of cardiac anesthetist in this condition is immense. I just give you a small example. When we are doing this procedure, particularly from the left side, or a small thoracotomy, the space is crunched. There's a very small space, and you have to do a very, very highly demanding, technically demanding small anastomosis in the coronary artery. So you need at least an undisturbed space. So we know on the left side that left lung can easily come into the operative area. So how to block this? So this device has been developed called bronchial blocker, which is put by the cardiac anesthetist, and it collapses the left lung. And in this way, it gives an unimpeded area for a surgeon to work and comfortably perform the procedure. Second is transesophageal echo. This is another important tool, because once we are doing the procedure, there is a very small hole, and how the heart is behaving, whether the heart is slowing down, whether the heart is underperforming, this can be picked up through the transesophageal echo. This particular technique of providing the information during the operation is also now mastered by our cardiac anesthetists. This is the second important contribution by cardiac anesthetists during this procedure. Thirdly, my gastro colleagues are also aware that when you are doing a small, minimally invasive procedure, the instrumentation changes. Here also in cardiac surgery, we have to change our instruments. All are now the long shaft instruments, and these instruments are basically very helpful to perform the procedure. Heart-lung machine is an integral part of any cardiac operation. This is always there as a backup whenever we do this surgery. The different cannulations which we are using in open heart surgery, this also changes in cases of MICS. They are long, they are placed very remotely from a different place into the heart in cases of MICS cardiac operations. So there are a couple of photographs. Photographs has to appear. Photographs. So I just wanted to show you, like, this is the approach for a MICS CABG LAD exposure. Now in this, we know that LAD is the main artery on the left side, and you can see that there is only a 2.5 inches small incision on the left side, and through which the LAD is exposed and the grafting can be carried out. The another challenging area all these operations is doing the proximal anastomosis. If we are using a saphenous vein graft, the upper part of the saphenous vein graft is attached to the aorta, and in that condition, this is going to be very challenging because it's not like a normal surgery. Here the aorta is actually in distance. It is in the depth. To control the aorta and do the grafting, the proximal graft is itself very challenging in this condition. So the MICS CABG is going to stay, we are all aware. But when we figure out how many cardiac surgeons are doing it, we surprisingly find that very few surgeons are attempting. The reason is very clear. Why? Because it's a very demanding job. Small hole, small environment can be very taxing. Secondly, issue, as I was just discussing, is the ascending aorta. The site of proximal anastomosis is an area of concern because it's quite inaccessible. And if anything goes there wrong, we can imagine the aorta bleeding can kill the patient on the table. So these are the areas which is still being addressed by newer set of surgeons. So this procedure is slowly growing up. It is taking some time to become more popular among the surgeons. Next is endoscopic vein harvesting. Now we all are aware that when you do a CABG operation, then we need use of saphenous vein, and this is taken from the legs. And generally there is a long incision from the ankle to the almost up to the thigh. So that also becomes a source of a secondary infection. So how to sort out this problem? So this has been sorted out by a beautiful new technique called endoscopic vein harvesting, EVH. Now with the help of that, we actually make a very small cut, say 1 inch cut or 1.5 inches cut in the thigh area. And from there, a full length of the vein, saphenous vein, can be harvested with the help of an endoscope. So this is one of those photographs. You can see I'm placing this endoscope through the hole, and through which the whole length of the vein is being taken out. So the end result is this is got a real game changer, because now finally the patient has a small cut in the chest and a small cut in the leg. So it is a total complete job where there with the 2 small incisions, we are accomplishing such a big operations. And thus it's also preventing the secondary infections in the lower limbs in this critical group of patients. So with this background, many of you must be wondering that, well, you accept that MICS CABG surgery is now being popularized. What are the results? What are the outcome of this procedure when you vis-a-vis compare it with a full sternotomy approach? So I think last 5 years, this particular operation is in overall being popularized. So a lot of literatures have started trickling down. So I am showing you a couple of them which one published in November 2017, which shows very clear cut that the safety profile for the sternotomy versus this MICS CABG is almost equal, and it is giving excellent result as far as MICS CABG is concerned. Similarly, a midterm follow-up of minimally invasive multivessel grafting. This also shows that it can be safely initiated as a minimally invasive multivessel approach to open surgical revascularization with an excellent midterm results. Minimally invasive results are also compared with sternotomy throughout the world nowadays, and there are a lot of trials were going on. Until now, the reports which are trickling in, this given excellent midterm results from the MICS CABG procedures. So, as we are doing the CABG, we have extended the same technique for an aortic valve replacement, either through a small sternotomy or through a right thoracotomy. I'll take you through a few of my patients where I performed this AVR. This aortic valve replacement is through the mini sternotomy. You can see a very small incision. Here I'm performing the procedure. And you see this gentleman, he's only 44 years old. He's not 80 years old. But why we did a mini sternotomy AVR in this case? Because this patient has got a very severe COPD. And with the full sternotomy, he would have never come out of ventilation. So that's why we decided to do this procedure through this with an excellent results. Similarly, we extend this procedure for mitral valve repair and as well as mitral valve replacement. This we do through a right small thoracotomy on the right side. And these are the few pictures of MICS MVR. This is an outcome in a patient of MICS MVR in a 73 years old bioprosthetic valve. Then same thing we are carried on in a case of atrial septal defect closure through MICS. Another patients finally undergoing this procedure, and the closure is done with the help of a pericardial patch. And you can see this performance in a lady where we have placed the incision very nicely in the submammary crease, and practically nobody can make out that this patient has undergone such a major cardiac surgery. Now, before we close down the session, I just wanted to touch upon some modern topics which has come up. Like this a scenario, 80 years old lady, I'm telling you an example, who had, let's say, rheumatoid arthritis, diabetes, frail habitat, but has got a very significant calcific aortic stenosis, 120 millimeter of gradient, very symptomatic, but heart functions are good. What I'm trying to say that this patient wants to leave. Their patients can be made to survive. But seeing this huge amount of comorbidity, are we going to operate this patient? Normally, previously, we would definitely avoid operating this patient. But in now, this decade, the games are changing. Now, what are the options? First option is that I do a MICS AVR. Second option is even better, I do a MICS AVR with a rapid deployment sutureless valve. And third option is even better, that we can attempt transaortic valve implantation called TAVI. Now, these are the TAVI valves and this procedure. This TAVI is performed both by cardiologists and cardiac surgeons. It's the least invasive procedure. There is a small cut in your groin and your valve can be changed. Very good clinical results. Everything is in favor, but one thing is the biggest disadvantage. That is, disadvantage is its prohibitive cost. This particular valve costs around 20 lakhs for the procedure. And even the Indian version is available around 16 lakhs. So in Indian context, it is very difficult that how many people can come out and pay this huge amount to undergo this procedure. So somewhere in between, the compromise and a better solution is that do an MICS AVR with a rapid deployment sutureless aortic valve. If we do this procedure, the cost comes down to only 3.5 to 4 lakhs. And with this special valve, no sutures are used. So the procedure is very quick, very fast. We finish the whole procedure by 1.5 hours. And all these sick patients can undergo this procedure quickly and are almost in the 1/3 cost of a TAVI. So this is that valve, Percival valve, which I was talking about. And the company, Edwards, has also come out with this rapid deployment valve. And so these are the areas which are improving. Now we are using endoscope itself inside the chest cavity to help out to give a better view for mitral valve repair. We are using the robotics nowadays. With the help of robots, we are doing coronary artery bypass grafting, which is getting popularized in India very quickly also. And these are the typical scenes where the robot are assisting the CABG and mitral valve repair. And last thing which I would like to now add, which is a very latest concept, is the concept of heart team. Now, it has realized that whenever we are tackling a very complex cardiac surgical or cardiac problem, it is always better that if we take the input of our cardiologist as well. So now a new concept has come called a heart team concept, where the cardiologist, cardiac surgeons, cardiac anesthetist, intensive care specialists, as well as the imaging specialists like echocardiographers, they are all clubbed into a team called heart team. And they take a very judicious, careful decisions, which is best for the patient's outcome. I will give you two examples of this quickly. Now, this is about an 81-year-old lady. She is having a very severe triple vessel disease. She has a discrete lesion of 90% on circumflex and mid RCA. But in the LAD, there is a 100% chronic total occlusion. And this LAD lesion cannot be tackled by the cardiologist. Now, how a surgeon can help? Surgeon can help by doing a very small MICS operation in this lady and do a single grafting lima to LAD, and rest circumflex and RCA PTCA can be performed by a intensivist, or what we call by the interventional cardiologist. And in this combination of the procedure, the trauma to the patient is very small, the operative time is very small, and this patient do very well in long term. So this type of combination where a cardiac catheterization, angioplasty, and surgery can be done together in a one place, this is called hybrid catheterization lab, which is now being popularized in many centers. Another use is a use of mitra clip. This mitra clip is it's a new technique. Now, what happens that we all are aware that even when the patient has got dilated cardiomyopathy, then these patients develop what we call functional mitral regurgitation. So this functional mitral regurgitation, if we wanted to tackle, then in that condition, the surgery in that condition would be very dangerous for the patient. Then we talk with our cardiologist in our heart team, and we both together take a very conscious decision that we should not do surgery, rather we should do what we call a mitra clip, in which a cardiologist put a clip inside the mitral valve and lock the mitral valve in such a way that mitral regurgitation is reduced and the patient is immensely benefited. So these are the two examples of how the new change concepts are coming as far as the cardiac surgery or cardiology practice is concerned in the near future. So with this, I want to conclude that minimally invasive cardiac surgery represents a safe and effective approach for a variety of cardiac surgical diseases. MICS appears to result in decreased length of hospitalization, no doubt about that, improved pain control, and faster recovery to the normal activities. With that, I want to conclude this particular presentation. Thank you very much for your patient hearing.
Thank you, sir, for your excellent talk, and your experiences are tremendous. We are thankful you have joined us and given your experience to us. That was very nice. Any question, Dr. Misra?
I really appreciate his talk and very innovative approaches for the cardiac surgery. And we wish him all the best for the future and hope to get a lot more researches in the future. Shall we move on to the second paper, sir?
Yeah. So next talk is by Ramadip Rai. He's a liver transplant surgeon. He is MSFRCS Fellowship in Liver Transplant and head of the Division of Liver and Transplant Surgery from Apollo Gilangel Hospital, Kolkata. So his experience is liver transplant surgery. And his talk is liver transplantation, the standard of care today. Yeah, Dr. Ramadip Rai.
Thank you very much. Am I audible?
Yeah, definitely.
Okay. I can start sharing the screen. One second. Hi, is my screen visible? The presentation, first slide.
It is visible.
Okay. Thank you very much for involving me in this forum. I'm Dr. Ramdeep Rai. I head the division of liver transplant and GI hepatopancreatic biliary surgery at the Institute of Gastrosciences at Apollo Gleneagles. And for the 10 years before this, I was working in Delhi and Gurgaon. And now this is our team which does the liver transplantation, the surgical team. And you may, many of you may be aware of the Institute of Gastrosciences led by Professor Mahesh Goenka. That is the institute of which we are a part of. And now we have an in-house full-fledged liver transplant team, the only full-fledged liver transplant team in Eastern India doing liver transplantation regularly. We are talking about patients who suffer endlessly, suffer not just from jaundice and disease, but suffer from the uncertainty and the anxiety of waiting for an organ, not knowing when a liver will be available. We are aware of the sufferings that these patients go through, suffering from ascites, suffering from those veins on their tummies which may bleed, suffering from blockage due to Budd-Chiari syndrome, suffering from upper GI bleed and from bleed from epistaxis. And sometimes when the liver disease stays long enough, it can progress to cancer as well. Fatty livers, some of them progress to fibrosis, a few among them go on to cirrhosis, and then a small section of that progress to cancer. And patients with advanced stages of cirrhosis and early stages of cancer, those are the ones whose livers need to be taken out. These are the livers that need to be taken out. Now, cirrhosis may be due to a multitude of problems, reasons, but basically we are looking at causes like hepatitis B, hepatitis C, alcohol, and non-NASH, a non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, a problem which we all see day in and day out in this part of the world. So for liver disease due to cirrhosis, this is a cirrhotic liver. You can see the nodular cirrhotic liver surface. And also it may be due to acute liver failure. You see the liver here on the other side, which is green, because it is a necrotic liver. These are the livers that need to be taken out. Cirrhosis with decompensations are the ones who are the indicated for transplantation. But how do we decide about when to transplant? The decision is based on certain scores, like the child-pug score, more important than the MELD score. The child score is one of the most important criteria. And for acute liver failure, you look at the King's College criteria. Now, nowadays, no one remembers anything. Memorizing things is obsolete, so long as you have a phone with a good internet connection. So if you have a patient in your outpatient with liver cirrhosis, all you need to do is enter child score calculator, find the first calculator and put in the values of bilirubin, albumin, INR, ascites, and encephalopathy, and you get a child score. If you look at the one I've circled in red, the child score for this patient is 5. And if you look below, it is class A because the scores is 5 or 6. So it's an early stage liver disease. You don't really need to worry too much. But now look at another patient who's got a different set of scores. Low bilirubin, but with ascites and deranged INR, And here is someone with child score 10, which is class C, and therefore should be an indication for early referral for liver transplantation. So based on this, we decide. When it's a patient of acute liver failure, again, you need to Google King's College criteria. And once you have patients who are even nearing the criteria, any patient with acute liver failure, which means jaundice with encephalopathy, should be referred to a transplant center at the earliest possible. Because when the encephalopathy goes into grade 4, then transplantation may become transport for transplantation itself may become very high risk. So patients with acute liver failure, please refer early to a liver transplant center. And once we find that they meet the King's College criteria, immediately we take up the patient for transplantation, as we did only 3-4 days back here. And we have patients who get referred to us from this part of the country regularly, not just from West Bengal, but from Bihar, Jharkhand, Orissa, and Assam and the entire Northeast, who come to us for airlifted very often with acute liver failure with need for transplantation. When the liver is like this, like acute liver failure, and it needs to come out. But where do we go with a begging bowl in hand looking for a new liver? Unfortunately, on Indian roads, these accidents are very common, and unfortunately, very often they lead to death, sometimes brain death. But another tragedy follows, where along with the brain death, there are healthy organs which are burnt alive. If only those organs are all utilized, if only we could all pledge our organs and save lives. Till then, till the organ donation revolution really picks up across the country, the solution is living donor liver transplantation. Now, this is the story of Prometheus and Zeus. Zeus was a Greek god, and Prometheus stole fire from Zeus and gave it to mankind. And Zeus was so angry at Prometheus that he gave a punishment to Prometheus. And this picture is the depiction of that punishment. There is an eagle which has been sent to attack Prometheus, to cause pain to Prometheus. And Prometheus is lying there, chained to a rock. And the eagle comes and tears open his abdomen and eats up a part of the liver and goes away, comes back the next day to see that the liver has grown back. Every day, the eagle would come and eat up a part of the liver and fly away, and every day the liver would grow back. The idea was Prometheus was stuck in eternal pain. Every day he would suffer from pain, but the liver will grow back, preventing his death. But the lesson that we liver transplant surgeons have learned is that the liver grows back. Within a period of a few weeks, the liver grows back to normal size when it is cut significantly. How many livers do we have? We all have the impression that we have one liver. However, we actually have 8 livers, and those 8 small livers are packaged together as one. In fact, when you look at white mice, if you cut up a white mice and see the inside, you will see that all the segments of the liver are separate. They are not even packaged as one. So liver surgery has made giant strides because of this knowledge of anatomy, that the liver is actually 8 segments, and we can go in between with minimal blood loss, minimal bile leak if we stick to these plates. Now, if we are giving it to an adult, we can give the right side to an adult. For a child, smaller section. So what is liver transplantation? In liver transplantation, as depicted in this picture here, we see that there's a cirrhotic liver, and we have cut the connections, the pipes that go into the liver and the pipes that go out of the liver. And this is what happens. The entire diseased liver is then taken out. The cirrhotic liver is taken out, and we get another fresh new liver, and we bring that liver back in and join all the pipes. So the work of a liver transplant surgeon is essentially that of a plumber. We do plumbing, implantation, joining all the pipes. That is the work of a liver transplant surgeon, just that of a plumber doing the implantation. In case of living donor liver transplantation, it is only half a liver, where a living person's liver is divided into 2, and one half, typically the right lobe, is then implanted or joined onto the recipient, whose entire liver is taken out. Unlike in kidney transplantation, in liver transplantation, almost always the diseased liver needs to be taken out. And we have already discussed, in case of living donor liver transplantation, the basic surgery is this, that all the pipes that go into the right side of the liver, that is, I have marked it with gray lines, where the right hepatic artery, the right portal vein, the right bile duct, as well as the right hepatic vein are divided. And the red line across the parenchyma of the liver is where we actually divide the liver by parenchymal transection. And this half liver is then ready to be implanted. And this is living donor liver transplantation. This is an actual liver in which the ischemic plane between the right lobe and the left lobe is marked out. And this is an actual CUSA, which is the instrument by which we divide the liver. And you can see in this video here that the liver is being divided with very little blood loss. So this is the division of the liver into the right and left lobes, while the blood supply to both the right and the left side is maintained. And this is when we have already divided the right and the left side of the liver. Now you see in this video, I am looping the right hepatic artery. You can see the pulsation of the right hepatic artery, and I'm going to take a minute on this video. And here we see that the right hepatic artery is being ligated and about to divide the right hepatic artery. This is the right hepatic artery divided. This is the right hepatic artery, and just behind it, we can see the right portal vein. So that is the artery. There is backflow coming from the artery, and you can see the lumen, the very small lumen of the right hepatic artery. And this is what we are ultimately going to anastomose again. Here is the right portal vein, the portal vein which takes blood to the right side of the liver. We have to be very careful that we cannot damage anything that is going to the left, which is remaining in the donor, because we cannot compromise anything in the donor. Here we see the right portal vein. Now we are ready to divide the right portal vein. This is the living donor surgery where the liver is divided, and now the graft liver is being taken out, and only the veins at the top remain now. The hepatic veins are the ones which take blood away from the liver towards the heart, and here we will be using staplers to divide the hepatic vein. So here you see a stapler which is being used to divide the vein. So we are basically dividing all the pipes that go in and go out from the liver. I will go ahead, and here you see that this is now the same liver, no longer in the donor, but in the recipient. The new liver is already placed, and the new liver is already functioning, getting blood supply. Now, when we were students, you all were students in your college days, this is what the liver used to look like. The liver used to look opaque. But nowadays, this is what actually the liver looks like. It becomes almost transparent. We can see the inside. And this is possible because of radiology. Radiology is what has transformed our image of the liver, and we can see all the structures inside. No longer do we look at CT scan films. CT scan films are completely obsolete. They are like trying to get an idea about an entire 3-hour movie by looking at a few still photographs. So it is obsolete to look at films which are just snapshots. We always look at the videos. We look at the entire CT scan, and we look at the software reconstruction, the 3D reconstruction. And now with those modalities, all the images that we get are exactly like we used to get in our anatomy books. So now we can plan the division of the vessels, the arteries. Here you can see all the veins within the liver, which are not obviously visible, but the CT shows us all the veins within the liver, the portal vein, the ducts because of MRI, and we can get all these kinds of fancy images with intricate details about all the branches, all the tributaries, which we need to either preserve or we need to divide and reconstruct in the recipient. So this is the, sorry. Yeah, so this is done. This is the graft that is out. And here you see that the two lobes of the liver are already separated. And one is the healthy liver, which you can see in the donor remnant. And that is the other graft, which is ready for implantation. In the recipient, now our job, as I said, is that of the plumber. You can see the white tubular structure, that those are the PTFE grafts, the synthetic grafts which we can use to extend the veins, and we are joining it to the inferior vena cava. So most of the surgery, the joining happens on the inferior vena cava. Here is a neo-MHV, a kind of middle hepatic vein extended with that PTFE graft. And in the clamp, you can actually see the hepatic vein orifice, the IVC. So we are joining the MHV to the IVC. Here, we have to check the portal flow. We have to always ensure that there is adequate blood coming in. So we let the portal vein open and see whether there is any thrombus in the portal vein, whether the flow is adequate, because this portal flow is what is going to drive the growth of the liver. And here you can see the portal vein being anastomosed. The posterior layer of the anastomosis is already done, and the portal vein is there. And here you see the right hepatic artery, which is a tiny 2 millimeter artery. Here you can see it's so big under magnification, and it's a very, very important that we have a meticulous attention to detail. And this is the biliary anastomosis. It's a small anastomosis, but you can see the number of sutures that we use. All the sutures are there, placed and ready to be tied, which gives you an idea about how fine these sutures are. And this is the graft. We feel we are not only in the job of changing livers, but we feel that in the process, we are changing a few lives as well. This was a patient with Budd-Chiari syndrome, one of my earliest patients whom I had transplanted when I started off with transplantation. And this is a baby, a 7-month-old baby with biliary atresia who came to us with jaundice, with a failed treatment, and who needed transplantation. This is the same child before surgery. The mother was the donor. You can see the face completely yellow, the faces completely altered. And the same baby you can now see 4 weeks after transplantation. See this picture just 4 weeks after transplantation in the baby. The youngest babies I've done is 5 months of age. The oldest patient we have operated 72 years. But look at the picture 4 weeks before and 4 weeks after, how transplantation can change lives. You get a very good idea. Spare a moment to look at this lady. Think, how much ascites does this lady have? This was a lady from the Middle East. She had this tummy. We thought it would be a lot of ascites, but actually when we did the CT scan, you see here, there is no ascites at all. The entire abdomen is occupied by the liver. The liver is, all the black that you see are hemangiomas. The entire abdomen is filled with hemangiomas, and the white islands of liver tissue remain. And see here, this is the abdomen which has been completely cut open, and you can get an idea about the entire liver and the tumors filled with hemangiomas. It was a very, very difficult surgery, and this is after. And this is the before and after picture 1 month after transplantation. She was 60 kilos before surgery and 29 kilos after surgery. So she lost 31 kilos in the tumor, 60 before surgery and 29 kilos after. Fortunately did well, some of our other younger patients. But I always show this picture, not of a patient whom I operated, but one of the earliest successful liver transplantations from 1967, Thomas Tarsal. This girl had biliary atresia. You see her before surgery and immediately after, and then 46 years later, this lady still doing well. That is the potential of liver transplantation. Look at this young lady. This is a young girl in June 2019, an IT professional. This is the same girl in the July of 2019. And this is the same lady died of brain death in the next month, in August 2019. The father standing there, he was the one who came forward and said, I would like my daughter's organs to be used. Unfortunately, losing her life at a very young age, but her liver, her kidneys, and her heart could be utilized. There's an organ donation movement that's happening right now. In Calcutta itself, we had 5 donations within a period of 3 weeks. And we feel that East India has now come of age, and we can really increase awareness about organ donation. Please, whether you remember anything about liver transplantation or not, doesn't matter, but please go back home, have a discussion with your family members that in the unfortunate event of your death or brain death, would you like your organs to be donated? This message, this discussion needs to spread across India, and definitely needs to really pick up pace in the eastern part of India. Thank you very much. I once again reiterate, you're all ambassadors to the cause of organ donation. Please discuss, think, talk about organ donation. Thank you very much for your time.
Yeah, that should be done, because as for saving of life to anybody else, that is more important. One person is dying, but another person should be saved. Yeah, very nice message. So thank you very much, sir. From my part, Dr. Sanjay Misra, would you like
Yes, sir.
to ask some question?
I really appreciate Dr. Ramandeep Roy for his very illustrative, very educative, and very informative discussion about the liver transplantation. And liver transplantation, as I know, it has revolutionized the treatment of chronic liver disease, whether it is Budd-Chiari syndrome and other problems as well. So much so for even for the malignancy. We really look forward to Dr. Ramandeep Roy for liver transplantation and many more success in his life.
Thank you so much.
Thank you.
So
our next talk is management of CKD by Manish Kumar Jain, and he will join us. Manish Kumar Jain is consultant nephrologist from Apollo, Kolkata.
Hello, everybody.
Yeah, Dr.
Hello.
Manish Kumar Jain, welcome to this platform.
Thank you.
And your talk is management of CKD.
Yes. So should I start now?
Yeah, we can start. No problem.
Good afternoon, everybody. And I'd like to thank the BAPICON team to invite me for this attend this session. And I will discuss today the management of chronic kidney disease. And I will try to discuss in simple language to how so that we can understand and how we can manage these kidney problems. Friends, as you know, the kidney problem is gradually increasing day by day, and in your routine practice, you routinely see patient with altered renal function. And most of the time, we have to identify which patient have acute kidney injury and which have chronic kidney disease. Management of chronic kidney disease is multifactorial, which is required to control the underlying disease as well as prevent the progression of the disease itself.
Yeah, that's good. Yes. Yeah. हॉल ए में हम लोग को your audio is not visible.
Hello.
Hello.
Yes, sir.
Dr. Manish Kumar Jain, video is not audible.
Yes, sir.
So, we can ask some question to our eminent surgeon, liver transplant surgeon. Till then, Dr. Ramadeep Rai. Yeah. So, what is incidence of liver transplant surgery in India? So, Indian patients are coming for this therapeutic model. Yeah.
Yes, I think liver transplantation has come of age in India for quite some time now. And before this, I was at Apollo Delhi and then Artemis Hospital Gurgaon, where we had patients both from abroad and from India. But more and more, there is an understanding among gastroenterologists and physicians, and transplants are being offered earlier. Earlier, the problem was that very often physicians do not refer. They don't even think that the family would consider something as big as transplantation.
Yeah.
But nowadays, it's being done regularly. Even in Calcutta Apollo, we are doing 2-3 transplants every month for the last few months. So more and more the patients are coming. So we need to start referring more and more patients. And with insurance support and sometimes by NGO support, there are families who are not so affording, but even then they can come forward and go ahead with transplantation.
Sir, I would like to ask about prognostic issue. Yeah.
So the transplantation nowadays in any center who's doing transplant regularly, the success rate is claimed to be 90%. It varies between 85 to 92, 93%. And that's a kind of standard which has been established. And because surgery is fairly standardized now, intensive care has improved. And those patients who survive the first 6 months, they actually go on to lead completely normal lives. Absolutely.
Yeah. What is the cost of post-transplant treatment?
So transplantation itself, depending on where you go and do your transplant, varies between 20 to 25 lakh rupees is the usual transplantation cost. And after transplantation, there's a cost of immunosuppression, and the cost varies between 4,000 to 9,000 per month. And that is something that needs to be continued lifelong. And the good thing is that these are costs which keep coming down with time. Earlier, the cost of immunosuppression was higher. Now, because lots of patients had liver transplant, kidney transplant, bone marrow transplants, so the need for medicines like tacrolimus and cyclosporin and mycophenolate, so the companies have really been able to bring down the costs. So with time, these costs will come down.
Yeah.
So,
Dr. Misra, anything you have to ask? Till Dr. Jain is come.
They must be having some technical issues there.
Yeah.
Hello.
Yes. You are
Sir,
audible.
are we able to get the Dr. Manish Kumar Jain's video for CKD management, sir?
Yeah.
That is very
did he
important
join?
topic.
Did he join? Manish Kumar Jain has joined us? Or is there any problem?
Because I personally feel he is going to speak a very important topic, which is very relevant even for physicians, cardiologists, and the surgeons. We do face a lot of problems regarding CKD management. And that is the time when our physician colleagues come for our help. I really appreciate my
CKD is a great issue. Great issue. Because lifestyle diseases are increasing day by day.
And the important thing is that very on and off, we come across CKD patients who come for surgery. And what are the precautions which we have to exercise as surgeon? What are the medicines? I think Dr. Manish Kumar Jain is the best person to speak about.
I just had a talk with the people there, with Manish. So Manish's laptop had just rebooted. So there's no other issue. The laptop had switched off and it's starting again. So I think within a couple of minutes, they will be back online.
Okay.
With you.
So like Dr. Ramandeep, sir,
Ramdeep.
Ramdeep, yes.
Ramdeep sir, like,
yeah,
I am a GI surgeon practicing in place of Chhapra.
Okay.
So, as of today, what are the indications for liver transplantation? What are the viable indications where we can go ahead and do the liver transplantation? And what are the cost factors which are involved, sir? Because that is the biggest issue in the place like Bihar and so much so for Bengal as well. So
Yeah.
could you highlight on these points, sir? Indications, cost factors?
Yes, thank you. Thank you, sir, for bringing.
I think you are the best person to answer all these things, sir.
yeah.
So the first mistake, although this is not directly your question, but the first background mistake we all make is that when we see a patient and we have had the patient has liver cirrhosis, sometimes we assume in your mind, ये तो ऑपरेशन करवा नहीं पाएगा, ये तो ट्रांसप्लांट का सोच ही नहीं सकता है. So this is the biggest mistake we make by not even offering them liver transplantation, because we see time and again that patients who we feel that they would probably be able to afford a transplant, they don't go in for transplant, whereas there are many people who think will not be able to afford a transplant actually go ahead. That is one. So everyone with advanced liver cirrhosis should be offered transplantation. Now, the groups of indications are liver cirrhosis with decompensation. So if someone has liver cirrhosis with ascites, jaundice, coagulopathy, hepatic encephalopathy, any of them, he should be referred for transplantation to a hepatologist or a liver transplant surgeon. And looking at the child Pugh score, he or she can then decide that he's a candidate for transplant now or can come later for transplantation. So that is cirrhosis, liver cirrhosis, which may be due to hepatitis B, C, alcohol, and I think Manish is getting ready. So before he connects to audio, so one is liver cirrhosis, two is liver cancer, provided it is not too advanced, and three, childhood liver diseases like biliary atresia, and lastly, the most dramatic form of liver disease, that is acute liver failure. So acute liver failure, liver cirrhosis with decompensation, and pediatric liver diseases like biliary atresia and hepatocellular cancer. These are the typical indications. The cost of liver transplantation varies between 20 to 25 lakh Indian rupees in different parts. And Manish, are you ready? The moment Manish starts speaking, I will stop speaking. And the results are quite good for transplantation. Any center in India, there are many centers in India now. Ours is the only full-fledged in-house center in East India, but across Delhi NCR, there are many centers. So Manish, then are you ready? I've been holding your fort for a long time.
रितेश को ज्वाइन करवाइए ना.
Yeah.
So Dr. Manish is here. I was talking about liver all this while. Over to you, Manish.
वो टॉक जो है ना,
Thank you, Dr. Rai. I'm very sorry that
ओरेशन है, तो ओरेशन के बाद होगा.
that we have some problem with the connection, and
थोड़ा देर में ओरेशन खत्म हो जाएगा.
Yes.
ठीक है.
वो स्लाइड खोल दो.
हाँ.
ये तो जाएगा ना.
ठीक. हाँ, देखते रहे. ठीक.
Hello.
Yes, you are audible, but your video is not moving. Yes.
Are you getting my voice, sir?
Yeah.
So I'm sorry that we have problem with the connection here. So I'm opening the mobile and I will try to do as early as possible in the proper way.
Okay, no problem.
So as I discussed, I'm just discussing, there's a chronic kidney disease increasing gradually day by day, and in the OPD we are seeing lot of the patient with chronic kidney disease. But whenever the patient comes to us with altered renal function, first.
तुम जाके बोलो डॉक्टर रितेश अग्रवाल उड़ीसा से ज्वाइन करना चाह रहे हैं, उसमें ओरेशन के बाद उनको ज्वाइन कराएं. रितेश
we have to diagnose whether it is after diagnosing the
wants to join after A Prakash ओरेशन के बाद वो ज्वाइन करना चाहते हैं, उसमें जो हॉल मैनेजर हम बोल वीडियो फिर रुक गया, चल नहीं रहा।
We have to reach kidney disease based.
Sir, you are muted. Your video is not playing. हॉली में डॉक्टर रितेश कुमार अग्रवाल है, एंडोक्राइनोलॉजिस्ट उड़ीसा के हैं, वो ज्वाइन करना चाहते हैं। ओरेशन के बाद उनका लेक्चर करवा दीजिएगा, थोड़ा सा मैसेज कन्वे करना है ओरेशन के बाद। हाँ, ओरेशन में तो कुछ डिस्टर्ब हॉल है, ये मैसेज कन्वे।
पूछ भी रहे थे व्हाट्सएप करके।
हाँ, हम भी बोले, लेकिन वो थोड़ा सा पहले ही पूछ रहे थे। देखे दास को बोले ना। अच्छा हाँ, मैसेज भी तो किया जा सकता है। अच्छा
अदर पार्टिसिपेंट शेयर और कोई नया सेशन चालू हो गया ना?
Yeah, Dr. Manish, you can continue your lecture.
Yes. Are you hearing me?
Yeah.
Okay. So I am sorry that there is a lot of connection problem. So I think
It's
now,
all right. It's all right.
So now I already have discussed the chronic kidney disease, how we can diagnose the chronic kidney disease. ये फिर नहीं कर रहा है. Slides में. So these are the stages of chronic kidney disease. According to GFR, we divide the chronic kidney into 5 stages, and we add T if patient is kidney transplant recipient, and if we add D if patient for dialysis, means a patient of creatinine stage 3, then we say CKD is stage 3, and if transplant is there, then CKD is stage 3T. And if patient dialysis, generally you know the patient with end stage of disease, the dialysis, so we say CKD 5D. Then another method of staging of chronic kidney disease, that is according to GFR plus urine ACR or urine proteinuria. In this, you can see that proteinuria can be divided into mild, moderate, and severe. And staging is according to GFR is 1 to 5 same. But stage 3 is further divided into the stage 3A and 3B. In the diagram, you can see the patient who are in the stage of with colored yellow or red, a very bad prognosis. Then the patient who are in the stage of green color and the yellow color. So which are the patients who have high risk of development of chronic kidney disease? Patients with diabetes, hypertension, patients with cardiovascular disease, patients with obesity, metabolic syndrome, family history of CKD, patients with some infection like B, HIV, or C, and have high chance of development of chronic kidney diseases. Now we come to what is the common causes of chronic kidney disease. Patient diabetic cause of chronic kidney disease, and the another group is the non-diabetic group, that is the glomerular disease, tubular interstitial diseases, including patients with analgesic nephropathy, reflux nephropathy, obstructive nephropathy, vascular causes like vasculitis, hypertension, cystic causes like DPKD. Patients with transplantation generally we consider CKD because generally their GFR is about 60 or 90 or less than 60. We can see in this slide that the most of the patients have chronic kidney disease because most common cause of chronic kidney disease is diabetes. In the all group, as well as there's some specific group, include the wide group of patients, black patient, Asian group, and the American Indian group. So diabetes is the most common cause of chronic kidney disease. Along with that, after that hypertension, then chronic glomerular diseases. In this diagram, in this slide, you can see that in early 80, the diabetes, hypertension, and the glomerular disease are the same, more or less same, which leads to chronic kidney disease. But as the time passes, years and years, the diabetes become more common cause of chronic kidney disease, followed by the hypertension, and then the glomerulonephritic illnesses. Now we come to what are the manifestations of the chronic kidney disease. You can see in this slide is a lot of the presentation why with the chronic kidney disease patient presents like hypertension, edema, hyperkalemia, anemia, metabolic acidosis, cardiac dysfunction. Many times patient may present with advanced calcium phosphate metabolic abnormalities, including pleuritis, arthalgia, hyperparathyroidism. This slide shows how management of chronic kidney disease can prolong the life of the kidney. If a treatment start early, like in the GFR 75, then we can extend life of the patient by the 8 year or 9 year. But if they delay the treatment, then chance of survival of this patient or their kidney is very less. You can easily see in this diagram that when patient diagnosed late stage like GFR less than 50, and if we don't treat this patient, then they develop ESRD by the 7 year, and we still treat this patient, then they develop ESRD by 9 year, and we diagnose early and treat this patient, then they develop ESRD after the 11 years. Now, main important thing is how you manage this chronic kidney disease patient. First, we have to diagnose the underlying disease, which leads to the chronic kidney disease, and we have to diagnose the CKD itself. There is a lot of gap between the diagnosis of the chronic kidney disease. As you can see this slide, appropriately tested patient, a regular diagnosis done only 12% patient of total chronic kidney disease. Otherwise, most of the patients either they are not appropriately tested, or if they are appropriately tested, then they are not diagnosed as CKD. I am skipping this slide. Then evaluation of the chronic kidney disease. We have, for evaluation of chronic disease, we have to do some tests like serum urea creatinine, urine routine, and the ACR and the ultrasonography to diagnose disease. And then we have to do some etiological tests. So diagnose which conditions that lead to CKD, including the vasculitis markers, as serum protein electrophoresis, urinary electrophoresis, and many times in the kidney size normal, then we have to do kidney biopsy also. For diagnosis of any disease, kidney disease, we need some measurement of GFR that we can do in some blood tests like serum creatinine, cystatin C. We can do some, and by putting in this formula like CKD EPI or MDRD, we can measure the GFR. Gold standard test for measurement of GFR, the inulin and iothalamate. So GFR measurement of GFR can also be considered as a screening tool, because a lot of the patients which are asymptomatic are generally not detected until unless they are evaluated for some other disease. But the patient who high risk group, like patient diabetes, hypertension, family history of CKD, we can do regularly GFR, then we can diagnose their renal problem much earlier. The National Kidney Foundation recommends using the CKD EPI creatinine equation to estimate GFR. Other useful calculators related to kidney disease include the MDRD and cockroach plot. This is the diagram showing the urine in the jar, and urine examination is a very important test for the evaluation of any patient of renal disease. And because the urine examination can be done easily by dipstick or by the laboratory, and very cheap test, we consider as the biopsy, poor man's biopsy. Now the goal, what is our goal in the care of CKD? One most important goal is the slow the decline in the kidney function. First, we have to control the blood pressure. Our target of blood pressure in this group of the patient is, if ACR less than 30, then it should be 140-90 mmHg. If ACR is 30 to 300, then it should be at 130-80 mmHg. And even if ACR more than 300, then target should be 120-75. We have to target individualize the targets and agents according to age, coexistent coronary cardiovascular disease, and other comorbidities. But most of the patient, we try to use ACRB, which is a time-tested drug, to preservation of the GFR as well as the proteinuria, control of the proteinuria. When we starting ACRB, is the risk benefit should be carefully assessed in the elderly patient and medically fragile patient. After starting the drug, we should check the creatinine after 7 days. If the rise in the creatinine less than 25%, we should continue these drugs and monitor them. If we more than 25% increase in the creatinine, then we should stop these drugs and we should rule out if the renal artery stenosis is there or not. And if we are continue these drugs, we should monitor regularly with both potassium and the creatinine. In this group of the patient, we should ensure that patients should have a low sodium diet, and many times we can need to add diuretics. We should avoid the volume depletion, because when the volume depletion is there, a patient or ACRB, it will further lead to development of the AKI in this group of patient. Then glucose control. You know that diabetes is the most common cause of chronic kidney disease. So we have to control the blood sugar level as much as it can be possible. Our target HbA1c should be 7%, but it can be extended according to comorbidities or limited life expectancy of the patient and according to risk of hypoglycemia. In the patient with the diabetes and who develop chronic kidney disease, hypoglycemia is very common because in this particular patient, the appetite is less, they have vomiting, there is absorption of glucose is erratic from the intestine because of the uremia and edema, and the insulin metabolism also decrease. Because of that, the lifespan of insulin increase and this leads to hypoglycemia repeatedly in this group of patient. Or better to say, when a patient with diabetes will start to develop hypoglycemia, generally I expect that this patient develop some form of renal disease. And in the diabetic patient, we should also assess the drugs which we are giving to treat the blood sugar level. We should give only these medicines which are safe including glizide, glipizide, and liragliptins, and many times pioglitazone and the insulin. Then control of the anemia. Anemia is a very important complication of the chronic kidney disease. Anemia itself impairs the lifestyle of the patient and also leads to progressive renal disease. Anemia starts from the stage 2 onwards and most common in the patient who has GFR less than 15. If patient in a stage 4 or 5, 90% of patients have some form of anemia. And anemia in the CKD patient is because of the due to decreased erythropoietin production. We have to treat the anemia to not only improve the lifestyle of the patient and to decrease the symptoms of the patient because of anemia, as well as to prevent the progression of renal disease. Our target should be 11 to 12 gram per deciliter. It should not exceed the 13 gram per deciliter. Because in patient with hemoglobin level more than 13 gram, it increases the mortality as per COIR study. But during the treatment, we should ensure the proper iron supplement of these patients. Then treatment of hyperphosphatemia. Treatment of hyperphosphatemia is also important part because the hyperphosphatemia not only leads to decrease in the kidney function, but also leads to the cardiovascular complications. And these cardiovascular complications are important part of the morbidity and mortality in the CKD patient. Hyperphosphatemia will lead to pruritus, calcification of the synovial membranes, blood vessels, and even cardiac valves. Our target is we should, for treatment of phosphatemia, our target should be less than 5 of the phosphorus level. And initially, we should add the diet style modification, especially in the stage 2 and 3. And we should add the phosphate binder. Generally, we add calcium carbonate, lanthanum, sevelamer carbonate, or hydrochloride. Many patients with chronic disease develop CKD MBD, that is a chronic disease metabolic bone diseases. And one is important manifestation, the hyperparathyroidism. In this condition, the phosphorus PTH level is very high, generally more than 300 milligram per picogram. Our target should be between 100 to 500 picogram per deciliter. Phosphorus and calcium should be maintained in the normal region. For treatment of hyperparathyroidism, we use the vitamin D. Many times we have to use calcium, especially the PTH level more than 800, or patients' calcium and phosphorus level not maintained in the normal level despite the proper treatment. Or many times patients develop the calcification of the vessel wall or uremic calciphylaxis. Then we have to treat the other complication of chronic kidney disease like metabolic acidosis. Treatment of metabolic acidosis will decrease the progression of renal disease itself, which has been seen in various trials, as well as it also leads to decrease the metabolic bone diseases. Our target of BACA should be more than 22 millicurie per liter. Then we should take care of the hyperkalemia also. You know that hyperkalemia is the catastrophic complication of the chronic kidney disease, and many times leads to the death of the patient if it is not treated properly. Generally, in the dialysis patient, potassium can be managed during dialysis by and dietary modifications. But we should keep in the patient who are not on dialysis, we should advise them strict dietary potassium restriction. We should avoid those salts which contain the potassium. And many times we need to stop beta blockers and ACRB, which leads to hyperkalemia. Then other important part of the management of this chronic kidney disease is the avoid the dehydration. When a patient dehydration because of the nausea, vomiting, or the loose motion, that will lead to the decrease in the GFR. And many times patient may land the dialysis. Similarly, we should avoid those medications which lead to progression of the disease, including the aminoglycoside, NSAID, and those investigations will need to reduce contrast agents which further leads to damage the kidney disease. Many times, some kidney disease like tubular disease, where is dehydration common because the urinary concentration is very less in these patients. So we should keep care of their hydration status, and we should use proper dosing of drugs like allopurinol, which increase the tubular diseases and progression of renal disease. And when kidney disease patient, the important question is what is the dosing of the drugs? You know, in the patient of chronic disease, there is pharmacokinesis and pharmacokinesis both affected in these patients. There is decrease in the absorption, or absorption may be impaired in the patient because of the intestinal edema or erratic absorption from the uremic environment. There is impairment in the phosphate metabolism. There is impaired protein binding of the drugs. Because of this, in small amount of drugs may develop toxin, like toxicity of these drugs, like dilantin. They change in the volume of distribution of these drugs, and with some of the drugs or drugs which are excreted by kidney, when kidney function is less, then side effect will be increasing. Like even we provide the normal dose of drugs will increase the nephrotoxicity in CKD patient like erlopirinol. So we need to modify the dose of the drugs. Or similarly, in the patient with chronic kidney disease, when you use the other drugs which have main where there are other toxicity rather than renal disease like vancomycin, we should modify these drugs. Modification of dose can be done either a reduction in the dose of drugs, or many times we have to increase the dosing interval of the drugs. Then the important part of management of these drugs, the preparation of the renal replacement therapy. Education is very important of the patient of chronic disease for their dialysis and transplantation. For dialysis, we should educate them regarding the hemodialysis and peritoneal dialysis. Many times, a patient may not be present at that city where dialysis facility present. Then we have to educate about them about the peritoneal dialysis, and we should also educate them about the venipuncture and insertion and the arms to preserve the peripheral veins, especially when JFI less than 60. So early education about these is very important, especially in the female patient, old age patient, to protect their peripheral veins. And we educate them to when they should place their vascular access or PD catheter. In the non-dialysis diabetic patients, generally we prefer to put the vascular access either AV fistula or AV graft when the GFR is less than 10, or when patient diabetes, we should prepare the AV fistula or GFR when the GFR is less than 20. Then what are the indication of renal dialysis? When the patient lands in the advanced stage of renal disease, they will need either dialysis or transplantation. So what are the indication of renal replacement therapy? Either is uncontrolled hyperkalemia, metabolic acidosis, uncontrolled hypervolemia, and pulmonary edema, pericarditis, and bleeding diathesis. There is some relative indication when that may not be an absolute indication or may not be life-threatening, but may need to start dialysis like nausea, vomiting, poor nutrition, loss of the weight, metabolic acidosis, lethargy, and malaise, and many times worsening of renal function like GFR less than 10 ml per minute or less than 15 ml per minute in the diabetic patients. Then the renal transplantation. This is the renal transplantation basically the definitive treatment in the CKD patient. Transplantation can be done preemptive. Preemptive means that when we started, we did transplant well before the start of dialysis. That improved the both patient and graft survival. Then, then we can the donor can be either it is cadaver donor, or it can be live related, or maybe many times unrelated donor may be there. But graft survival is always better in the living donor than the cadaver donor. In our zone, still cadaver donation is early stage, and we should promote the donor cadaver transplantation because the number of the patients who require transplant is much greater than the donor availability there. If we can improve the donation from the cadaver, then we can do transplant a lot of the patients which are not getting their kidney from their live related donors, and we can save this patient. In the kidney transplantation, immunosuppression is always a must, and we should educate the patient before being transplanted that so they adhere properly to their medications. Friends, I will like to say that you should, as a primary care physician, you should always educate the patient about the kidney transplantation. When you get a patient of kidney disease, then you should educate their family members or other patients which come to you, or especially their family members about the donation of the kidney and other organ, as our Dr. Ramdev already discussed with the organ donation in their facility like liver. So in kidney also, cadaver donation should be promoted. In the transplantation, after transplantation, patient may face some problems, especially the recurrence of the disease like FSGS, chance of infection, cardiovascular complication, and bone disease. There is some group of patients which are not a candidate for the renal transplantation, like patient with malignancy, patient with current infections, patient with severe extrarenal disease like COPD, cardiac complications, and some patients who are addicted to some medications, we have some psychological problem. Then during the treatment of the CKD patient, we have to take care of the other organ, as well as the cardiovascular system, because the mortality on the CKD patient is because of generally with cardiovascular disease. So we should ask them to stop the smoking, they to do regular exercise. Regular exercise is very important to keep them patient fit, even after transplantation or after starting the dialysis. Then weight reduction should be done in up to optimum targets. And lipid lowering therapy is also important to prevent the cardiovascular complication of these patients. Aspirin generally indicated for secondary, but not the primary prevention. Then the very important thing is who should be involved in the patient safety approach to CKD patient. I will say primary care practice is the most important part of the management discussion, because in the setup or in our country or our zone, we have scarcity of nephrologists and primary care physician which are staying in the remote area or in the second or third tier city. They can properly manage this patient by their proper education, their adherence to the management, as well as their referral to the nephrologist whenever required. And this proper referral as well as the nephrology involvement improve their morbidity, improve their life of the patient as well as the kidney. So the patient and other socially, and then we should need patient involvement, primary care physician, nephrologist, and we also need other specialties like cardiovascular system, cardiologist, and cardiothoracic surgeon for creative AV fistula. We require surgeon to many times we require surgeon to put the PD catheters, and many times we require urologist to treat the obstructive renal diseases. Now, what are the indications for the referral of specialist kidney care services? Like acute kidney injury for patients who have rapidly fallen the GFR, when the GFR is less than 30 ml per minute. Then when there is persistent albuminuria more than 300 milligram per gram. Then many times there is atypical progressive chronic disease. When the urine sediment, active urine sediments are present, like RBC more than 20 per IFR field, or sustained or not readily expand. When there is hypertension which is refractory to treatment, then there is persistent abnormality of serum potassium. When patient have recurrent extensive nephrolithiasis and the hereditary kidney diseases. Then what is the advantage of proper early nephrology consultation, which have been seen in various studies, that if early referral is improve the morbidity of patient, 1 year mortality of this patient. Hospital length also decrease when the proper nephrology referral done. Serum albumin at the start of RRT also better with early referral, and the hemoglobin at the start of RRT are also better. So when the early nephrology referral is there, the patient's morbidity improve, and their long-term prognosis is also better. So I would like to conclude with that in increasing prevalence of CKD in the population, early detection and prevention is important part to prevent the progression of disease. Early involvement of nephrologists in the care is important to prevent the progression and prepare these patients for their further treatment. We need further treatment of manifestation as well as complication, and then renal therapy, including timely referral for access and timely transport. Thank you very much for kind listening. I am very happy we have some questions. Thank you.
So thank you very much, Dr. Manish. Your talk was very nice, and I have no question after listening this lecture. My all question has been answered properly, and it was really nice. One thing I would like to ask, we are usually facing in the problem while patients are critically ill or going for surgery. So what precaution one should take while GFR is between 30 to 50?
30 to 15.
Yeah. 30 to 50. If GFR is like that, what precaution we should take, because surgery, most of the time surgery are very important for the patient as for living, saving their lives. So
yes,
in that situation,
yes.
what we should do as a
First,
physician?
when patient is referred to us for the surgery, we should see the medication which we are running to these patients. If a patient have like ACURB, we should stop them before immediately surgery, because during the surgery there is some hemodynamic changes takes place, and this ACRB will be impact these changes. One thing, we should stop the ACRB, and we, if required, we should ask to control the blood pressure with other safer medications. That's the one thing we should do before the surgery. During surgery, we should ask them, the surgeon, to keep the hydration properly, because the important cause of further renal function is the hydration. And hydration is very important, because you know that during the surgery, there is a lot of the toxins, myoglobins are released, and if there is hydration proper, then it will pass through urine properly. Then third thing, we should avoid any painkillers like NSAIDs. Fourth thing, we should avoid the stopping of the beta blockers, because they help to the cardiovascular system. And fifth, we should avoid any nephrotoxic medication, especially the antibiotics like aminoglycoside and vancomycin. And we should also check the potassium properly, because in this group of the patient, the potassium will rise immediately. So during surgery and after surgery, we should check potassium. Which, if required, we should give appropriate treatment and many times dialysis because of the high potassium, which will not improve by medical management. One thing I also like to discuss the patient party, that this type of patient may need dialysis after the surgery, and 1 to 2% chance that this patient may remain on dialysis if the kidney not improve.
Yeah. Few common problems we are facing day-to-day practice. One is COPD with exacerbation. Those patients are coming with CKD. And another group of patient is dilated cardiomyopathy with CKD changes. They are mild, moderate in this range, because lifestyle diseases, diabetes is increasing like anything. So in that situation, what precaution, what is your message to practitioners? What should we take care?
In COPD patient with chronic kidney disease, we have to take care of their hydration part, very important, because if the patient have only COPD, no cardiac problem, then we can easily manage. And COPD we can do with the bronchodilators and the other things. And but we should avoid the nephrotoxic medication. The another challenging groups is the patient with renal disease and the cardiomyopathy or poor LV function. In this group of patients, when we are treating them with the diuretics, the creatinine starts to rise. But new studies suggest we should not avoid the diuretics in these cases, because which we call it permissive AKI, means that we should allow the K to rise, but we try to stabilize the patient. Because after stabilization, when we start to use the diuretics, the kidney function will be improved. Another question, some will be asked what to do about ACRB or beta blocker. Should we start or not in this group of patients? But generally, I will say, if required, we should, because ACRB is important to prevent the progression of the cardiovascular diseases as well as CKD patient. So in this other patient, we can start, but we should measure the GFR. If the GFR is rise rapidly, more than 25%, then we should stop them. But if it's not rising, then we should continuously with the ACRB, and we should check the potassium. But generally which ask is the patient with cardiac disease, renal disease, when comes in emergency, we use diuretics, and this will rise the creatinine. This will happen, but because first we have to stabilize the patient. So we have to allow this. And many times a patient with cardiac disease is not improve with the diuretics also, then we can go for the isolated ultrafiltration with dialysis machine. So that will improve the morbidity and mortality.
So anemia management is a challenging task in CKD patients. So
Yes,
what level of hemoglobin should we keep? Because most of the time, if you give iron or erythropoietin, hemoglobin is not rising. So what level is satisfactory for a patient? Yeah.
Yes. So, the recommendations is that we should try to keep hemoglobin between the 11 to 12 gram per liter. Because where studies, I already discussed my slide also, where studies suggest when the hemoglobin is high, more than 13, that will lead to cardiovascular complications and as a closer to fistula patient dialysis. So our target should be 11 to 12. It can be 10, that is acceptable. Yes, your question is valid. That many times the patient is not improve their hemoglobin despite the idea of erythropoiesis. In this condition, we should identify the other condition that leads to this anemia. Yes, in the non-dialysis patient, we should see metanix, what is the iron level, what is the B12 level, what is the folic acid level. Then we should see there is patient losing some blood in their intestine or some other cause of the blood loss is there or not. There may be many times secondary hyperparathyroidism that will impair the absorption, impair the hemoglobin, impair the action of the erythropoietin in the bone marrow cells. So that we should rule out. Then there is, the CKD is the inflammatory condition. The inflammatory itself leads to the impaired iron absorption and impair the action of the erythropoietin and leads to the anemia. Then we should rule out other hematological abnormality like beta thalassemia and hemolytic anemia. Other conditions we should rule out, and we should concern hematologist also if required.
Thank you so much. Thank you so much, Dr. Manish, for your excellent presentation and very useful talk for all of us. Thank you.
Thank you, sir. Thank you very much, sir. कनेक्शन हो गया, खत्म हो गया। एक्चुअली वो इजी इसलिए बन गया ना क्योंकि सब लोग का गाँव में सब लोग नहीं मैनेज करते थे। इनके एप्लीकेशन यहाँ नहीं है।
For next session, moderator for this session is Dr. Om Kumar. He's a famous nephrologist and head of the Department of Nephrology, IGIMS Patna. And today's our chairpersons are Dr. Manish Kumar, Dr. C.B. Prasad, and Dr. S.C. Jha. So if someone is there and hearing my sound, if Dr. Om Kumar sir is not there due to his commitment, since time has on, so should we continue the lecture of Dr. B.N. Jha sir? He's eminent physician as well as he's a rheumatologist, and his lecture is very much important for us. So his lecture is spondyloarthritis, what the physician needs to know. So over to our eminent speaker, Dr. B.N. Jha sir. So unmute, sir. Unmute yourself. Yeah. Unmute yourselves.
Yeah, I'm unmuted.
Yeah.
Can you see my slides?
Yes, yes. You can
but I can't see it. Yeah. So should I start now?
Yeah.
Should I start?
Yes, yes, sir.
Audible?
Slideshow. Put it in slideshow, sir.
Put it in slideshow, sir. Slideshow.
Okay. Now fine?
Yeah. That's good.
Thanks, chairpersons, for kind words.
Yeah.
And good evening, delegates.
Yeah.
My brief today is to talk about what the physicians should know about spondyloarthritis. Before we tackle this issue, let's tackle another issue as to why physicians should know about spondyloarthritis. Why at all should know about spondyloarthritis? And for this, I would like to present two cases for discussion. In my first case, a 40-year-old lady presents with joint pains of 2 years duration. Her 4 metacarpophalangeal and 3 proximal interphalangeal joints of both the hands, both the wrists and knees are symptomatic. So altogether 9 small and 2 bigger joints are involved. Morning stiffness stays for more than an hour. She is rheumatoid factor negative and acute phase ejectants are within normal limits. X-rays don't show any erosions. So what is the diagnosis? Is it a case of rheumatoid arthritis? But radiology, serology, and biochemistry are negative. So is it a case of seronegative rheumatoid arthritis? Let's find out by applying ACR 2010 classification criteria, which is a gold standard for diagnosis. In joint involvement domain, our patient has got 10 joint involvement. And if more than 10 joints are involved, out of which at least one is a small joint, the patient scores 5 points. So in our case, the lady had 11 joint involvement, out of which 9 was small, so she gets 5 points. In serology and acute phase reactant domain, she doesn't get any, but in symptom duration, again, she gets 1 point because symptom is for more than 6 weeks. So 5 plus 1 is 6. And for a definite diagnosis of rheumatoid arthritis, one has to have 6 or more. So we were correct. She was a case of rheumatoid arthritis. But a physician's life is always not that easy. Here is another case. Here a young man of 30 years again presents with 2 years joint pains. His right wrist, left metacarpophalangeal joint, right knee and left ankle are symptomatic. Additionally, he has got a back pain as well. All his joints and the back pain are stiff for more than an hour in the morning. He is rheumatoid factor negative and CRP is raised. X-rays are again non-contributory. Now, what is the diagnosis? Is it again a case of rheumatoid arthritis? Let's again apply the gold standard. In joint involvement domain, the young man has got 2 small joint involvement, so he gets 2 points. In serology, he gets nothing. In acute phase reactant, again, he gets 1 point, and in symptom duration, he gets 1. So 2 plus 1 is 4. See, it is less than 6. So it is unlikely that the young man is suffering from rheumatoid arthritis. Well, rheumatoid is generally a disease of middle-aged ladies who present with symmetrical polyarthritis with seropositivity and involvement of small joints of the hands. Here, we have got a young man who has got asymmetrical polyarthritis with involvement of the bigger joints of the lower limbs with seronegativity. Additionally, and more importantly, the young man has got lower back pain. Mind you, in rheumatoid arthritis, if at all the spine is involved, it is cervical. Never the lower spine is involved. So, are we dealing with spondyloarthritis instead of rheumatoid arthritis? It is for this reason that we should know something about spondyloarthritis as well. Let's explore what spondyloarthritis is. Spondyloarthritis is a group of chronic inflammatory arthritis with overlapping pathological and clinical features. Mainly a spine and the sacroiliac joints are involved, but in many cases, peripheral joints and cases too are involved. There are then extra articular features as well. Cardinal features of spondyloarthritis are quite different from that of rheumatoid arthritis. Instead of seropositivity, here the patients are seronegative because rheumatoid factor and anti-CCP antibodies are negative. As opposed to rheumatoid arthritis, which is a disease of middle-aged ladies, spondyloarthritis generally affects younger males. There is strong association with HLA-B27 genes, and generally the axial joints are involved, but in many cases, peripheral joints too are involved. You will appreciate that the highlighted points are present in our yet undiagnosed young man. As opposed to symmetrical polyarticular involvement in rheumatoid arthritis, SPA patients generally present as asymmetrical oligoarthritis, meaning thereby less than 5 joints are involved. Painful inflammation of enthesis is a hallmark of spondyloarthritis. By dactylitis, we mean inflammation of the entire digit, including skin, muscle, soft tissue, tendon, sheath, and joint. This gives the digit a typical deformity known as sausage digit. And in many cases, there are psoriasis and inflammatory bowel disease as well. This is how we traditionally classify spondyloarthritis. Ankylosing spondylitis is the prototype of ankylosing spondyloarthritis, and it is characterized by involvement of the spine and the sacroiliac joints. But in more than 40% of the cases, peripheral joints too are involved. It is of 2 types, non-radiographic axial spondyloarthritis and ankylosing spondylitis. In fact, the 2 are a continuum. Non-radiographic form is an earlier stage of the disease. 10% of psoriasis cases get psoriatic arthritis, which is characterized by oligo or polyarthritis, dactylitis, and most of the cases have got psoriasis of skin and the nail. When arthritis follows infection elsewhere in the body, primarily gastrointestinal and genitourinary, it is known as reactive arthritis, characterized by oligoarthritis, which is mainly involving bigger joints of the lower limbs. Enteropathic arthritis is associated with inflammatory bowel disease, Crohn's, and ulcerative colitis. And when SPA involves or SPA is found in children less than 14 years of age, it is known as juvenile SPA. Then there are undifferentiated cases as well. But this cartoon illustrates 4 important features of spondyloarthritis. And the first is that different varieties of spondyloarthritis can have either predominant axial manifestations or predominant peripheral manifestations. Second, that the most prevalent form of spondyloarthritis is axial spondyloarthritis, which is of 2 types, non-radiographic and radiographic. Third, the less prevalent forms are reactive arthritis, psoriatic arthritis, arthritis associated with IBD, and then undifferentiated spondyloarthritis. Last but not the least, that these subtypes of spondyloarthritis are interrelated and overlapping on themselves as far as their manifestations are concerned. So, depending upon the clinical presentation, spondyloarthritis can be divided into two broad groups. First is predominantly axial spondyloarthritis, where the manifestations are generally axial. It has got two types, non-radiographic and ankylosing spondylitis. Second group is predominantly peripheral spondyloarthritis, and this consists of reactive arthritis, psoriatic arthritis, arthritis with IBD, and undifferentiated spondyloarthritis. Now, this classification is more suitable for management purposes. How? We will see later. These images illustrate advancement of ankylosing spondylitis over the years. On the extreme left is a young man who is unable to obliterate his lumbar lordosis because of the stiffness of a spine. Subsequent images show increasing kyphosis with passage of years. On the extreme right is a typical bamboo spine found in 40% of the late cases of ankylosing spondylitis. Well, you will not get any credit for diagnosing ankylosing spondylitis with this X-ray because it is quite late in the natural history of the disease. In a study having 847 cases of ankylosing spondylitis, it was found that extra-articular features were present in 42% of them at some time during the study. And most commonest articular feature found in 51% of those cases was acute anterior uveitis shown with blue color. Mind you, this anterior uveitis is not a benign condition. If not treated expertly and urgently, it has got vision-threatening potentials. These images show different clinical features of psoriatic arthritis. On the extreme left, we see typical psoriatic plaques on the palm and fingers. Middle picture depicts dactylitis of the right middle finger, which has been arrowed. You can see it is uniformly swollen, known as sausage digit. Just opposite to that, in rheumatoid arthritis, we get spindle deformity because only synovial joint is involved. On the extreme right, we can see the typical nail changes found in almost 90% of cases of psoriatic arthritis. In diagnosis, the bottom line is to diagnose early. Why should one diagnose early? Because late diagnosis is a lost opportunity as far as effective treatment is concerned. Because of the unabated inflammation, deformities, and functional impairment which are brought about can't be undone if diagnosis is late and treatment is instituted later. Let's take example of axial spondyloarthritis. In its earliest non-radiographic form, patient complains of inflammatory back pain, but sacroiliitis can only be detected on MRI and not on X-ray, hence the name. As the disease advances, radiographic sacroiliitis also appears, and still later, syndesmophytes are found on the spine. Now, progression from non-radiographic stage to radiographic stage takes about 7 to 10 years. And by the time, scope for effective treatment is lost. So, it needs to be diagnosed early in non-radiographic stage only. Hence, early diagnosis is essential. But how can we diagnose early? We can take help of ASS classification criteria for axial and peripheral disease. So let's concentrate on axial spondyloarthritis. What is the entry criteria? The patient should have back pain for 3 months or more, and the age of onset should be less than 45 years. Once the patient has gained entry, he should qualify for either imaging arm or HLA-B27 arm for diagnosis. What is imaging arm? The imaging arm is that a sacroiliitis should be detected either on X-ray or on MRI, plus the patient should have one or more spondyloarthritis features. If the patient doesn't qualify this, he can still be diagnosed as spondyloarthritis axial if he has got HLA-B27 positive and 2 or more SPA features. Now, what are these SPA features? They are all 11 of them given on the left side. Now, let us see if our yet undiagnosed young man can qualify for this classification. Yes, he qualifies because he has got back pain of more than 3 months and the age of onset is 30 years. Now, he could not qualify for imaging arm as X-ray was negative and MRI could not be done at a smaller place because non-ability at Sitamarhi. So we shifted to HLA-B positive arm. HLA-B27 was found to be positive, and let us see how many SPA features did he have. He had inflammatory back pain, he had arthritis of 4 joints, he had good response to NSAIDs whenever he was put on NSAIDs, and then he had elevated CRP. So with this classification, our young man was diagnosed as a case of axial spondyloarthritis. All the features found in the young man has been highlighted with yellow color. We will not discuss peripheral disease because of time constraint. We have been talking about inflammatory back pain. What does it mean? If your patient complains of back pain late in the night or early in the morning and it improves with activity, in all probability you are dealing with an inflammatory back pain. Important is that pain improves with exercise and deteriorates with rest. Even after that, if you are not sure, you can apply this ASS inflammatory back pain criteria. This is how active sacroiliitis looks on MRI. Bright spots on either side of the sacroiliac joint, which have been arrowed red, are spots of bone marrow edema, which is suggestive of active sacroiliitis. In brief, see, part of the rationale behind dividing spondyloarthritis into axial and peripheral lies in the different treatment options available for the two. As opposed to axial spondyloarthritis, where conventional synthetic DMARDs like methotrexate, sulfasalazine, and leflunomide are ineffective, and NSAIDs are the only conventional treatment available. These conventional DMARDs are effective in the peripheral manifestations of the disease. Well, this is the most important thing in treatment. Now let's go to the individual modalities. Physiotherapy is the most crucial non-pharmacological intervention, prevents deformity in axial disease. NSAID is the cornerstone of treatment for both the axial and peripheral disease. It improves the pain and stiffness in 48 to 72 hours. The effect is so pronounced and quick that good effect of NSAID has been kept as one of the diagnostic criteria in ASS classification. It is quite interesting to note that other anti-inflammatory agents like glucocorticoids and conventional DMARDs in axial disease are much less effective than they are in rheumatoid arthritis. Systemic use of glucocorticoid has got no role in the treatment of spondyloarthritis. Its role is limited to topical intra-articular injection to a symptomatic joint. About conventional synthetic DMARDs, let me re-emphasize that these agents are ineffective in axial disease, whereas they are effective in the peripheral manifestations. Maximal evidence is found for sulfasalazine, but methotrexate and leflunomide can also be used with equal efficacy. Biological disease modifying agents are very, very effective in both types of axial spondyloarthritis. But here again, there is a difference from rheumatoid, that in rheumatoid, a variety of biologicals are effective, but in spondyloarthritis, only biological which is effective is TNF inhibitors, others are not. Let's go back to our case number 2 and put our knowledge of spondyloarthritis to the benefit of the young man. Diagnosis is axial spondyloarthritis with peripheral manifestations. And what treatment we will give? We'll start with NSAIDs. They are very effective in 60 to 70% of the cases if given in appropriate doses. A long-acting agent should be added at bedtime to cover for the morning stiffness. intra-articular glucocorticoids should be given to an overly symptomatic joint. In disease-modifying agents, we can start with sulfasalazine, which will cover for peripheral symptoms, but don't expect that it will work on axial symptom where TNF inhibitors will work. So, to conclude, ladies and gentlemen, a physician should know that spondyloarthritis are a constellation of inflammatory arthritis with overlapping features. For management purposes, it is better to classify them as axial and peripheral spondyloarthritis than in individual diseases. Early diagnosis is imperative because by late diagnosis, we cannot prevent deformities and functional impairment. And to this end, ASS classification serves the purpose well. In treatment, the treatment of axial and peripheral spondyloarthritis differs as far as the role of conventional synthetic DMARDs are concerned. These conventional synthetic disease-modifying agents are effective in the treatment of peripheral spondyloarthritis, but they are not effective in the treatment of axial spondyloarthritis, where once NSAIDs fail, then one should go to the TNF inhibitor. Thank you very much for your kind attention. I conclude.
Thank you, sir, for your excellent talk. This is very common problem where physicians are lacking behind. So you have cleared so many things about spondyloarthritis, and we are very thankful to you for your excellent lectures.
Thank you.
Thank you. Is there any question? I am requesting Dr. Rajan Kumar. He is associate professor in medicine department, and he is working on rheumatology in PMCH. I welcome Dr. Rajan Kumar to participation for his participation in BAPICON, and his talk is ANA in rheumatology. So over to Dr. Rajan Kumar, sir. So after this session, we will, after this session, we will continue the question.
Yeah, good evening. All Dr. Bienja, Sudhir, and others, also Rajiv and Prafula. So today I am going to talk about this ANA. ANA is a very important thing. It's a very important parameter and marker in the rheumatology. So everybody has to know about it in the details, when to advise, when not to advise, and how to interpret it. That is the main. Today's learning is that when we have to start, when the other associated tests we have to go for, and how to interpret, whether it is important for prognosis or identifying the syndromes associated with it. So it was first described in 1948. It is the foundation for the diagnosis of connective tissue disease, but it can be positive without any connective tissue disease in 20 to 30% of healthy persons. And NA comes from two types of the antigen. One is from the nuclear material, another is from the DNA and the histones which is present in the nucleus. So why it is important? Some of the diseases, connective tissues such as SLE, systemic sclerosis, we need ANA for the diagnosis. It is helpful for that. And disease, it may be helpful for the prognosis, such as juvenile idiopathic arthritis. Prognosis becomes not good. Antiphospholipid, again, a syndrome, then if it is present in ANA, it may be secondary one, not the primary one. So other things may come up. So prognosis can be judged about this with the help of presence of the ANA. Disease in which the ANA is required for the diagnosis. That is the drug-induced lupus. You must have the ANA, and the secondary one is the antihistone antibody. mixed connective tissue disorder. Again, we need ANA and UNRP. E1 NRP, we need it. And some disease where the ANA is typically present but not useful, such as fibromyalgia, multiple sclerosis, thyroid disease, infectious disease. It can be present in malaria, it can be present in anemia, so may not be very much important. May not be important in these two diagnoses. So let us look first in the how they are produced. In the SLE or any other connective tissue disease, the dying cells, body try to clear it, and when they decrease ability to clear it, they remain persistent for long time, and the antigens in the cell, in the nucleus and the cytoplasm, they get exposed through the blephs, exposed through the direct exposure, and then lead to formation of antibodies. And the bodies which are not scavenging those antibodies, so they become remaining persistent in the body, and antigen antibody complex will lead to deposit in the various tissues, and they will lead to development of connective tissue disease. So what are the methods to test it? Indirect immunofluorescence is the gold standard. Other is the enzyme link. We use it, but lesser than the indirect one. And titration, 1:60. We usually say positive, but it is not very much significant unless until it is more than 160. And also we have to look on the staining pattern. Staining pattern of the nucleus, how it is stained. Whole of the nucleus is stained, nucleolus is stained, this dot is there. So we have to look about this. The pattern gives rise to different types of the antigens. So fluorescent antinuclear antibody assay, human cell line, HEP2 is used, and various dilution over the prefixed slide, in the various dilution we take when it is 1:40, 20 to 30% in normal cases will be positive. So suppose the titer is increasing and we take it a positive. If it is more than 160, only 5% normal will come into it. And 320, 1:320, then only 3%. So specificity increases if it increase the titer. 160, we usually take the cutoff. This is the method of which I am not going to over it in the detail. Some of the antigens which can pass with the HEP2 substrate. When the patient have got the clinical presentation with the connective tissue disease, arthritis, arthralgia, body ache, difficulty in rising up, other organ damage, so they may be present because it has bypassed the HEP2 cells. One of the antigen is RO60 antigen. So in this case, we say that it is NA, this is the SLE is the seronegative one, just like seronegative rheumatoid arthritis. So do we need further testing? We got the 160 positivity in the ANA. Do we need? Yes, we do need, because to classify in the different types of the connective tissue which have got the ANA positive. So that test is known as the ANA reflex or cascade. It is the positive initial, that is the ANA, secondary test based on the predefined rules applied to the information system. So titer, if it is 1:160, then we have to go for it. Otherwise, all tests will be, the ENA test will be negative, so it will not be of much value. So important to identify which type of disorder we need that. So when to advise the reflex test? High degree of suspicion, go for a ANA, you have got it ANA. Even if it is negative, even if it is low titer, if the patient have got the features suggestive of connective tissue disease, such as Raynaud's phenomena, photosensitive or malar rash, persistent oral or rashes, oral ulcers, or ocular dryness, leukopenia, lymphopenia, increase in CPK, persistent arthritis, thrombotic events, recurrent miscarriage. So you have got high suspicions for the connective tissue disease. Even the ANA is negative, even ANA is the low titer, you have to go for. You don't wait for the cutoff of 1:160. So you go for the reflex test and you will get the result, and accordingly you classify in the groups, in which group the patient comes, and accordingly he or she will be treated. So there are three types of staining pattern. One is nuclear, cell cycle associated, and cytoplasmic. So four common type of ANA staining pattern are associated with different types of the disease. We use this is the homogeneous pattern. All of the nucleus is diffusely stained. Chromosomes at the metaphase are also stained. So you can see the whole of the nucleus is stained in the cell. And this homogeneous pattern comes due to the presence of histone proteins, double stranded DNA, single stranded DNA, and the disease will be associated disease will be SLE, systemic sclerosis, scleroderma, and rheumatoid arthritis. So these will be diseases which are associated with the homogeneous pattern. Another is a speckled one. Here the very small uniform dots throughout the nucleus are present and no staining of the chromosome. Where the previous one, the chromosome were also stained in the region of dividing cell. Nucleoli may or may not be stained. So this is the speckle. Where we get a speckle? The speckle are the three types: fine, coarse, and dense fine speckled one. So fine is RO60, LA, and tropoisomerase, and broad spectrum autoimmune disease are there. Coarse spectral, U1, RNP, and SM antibody is present. Anti-Smith antibody is present, so we can diagnose SLE and MCTD if this type of coarse spectral pattern is there. But another important is dense spectral pattern. Dense spectral pattern is the one thing if it comes, you have to again ask the pathologist whether it is there or not, confirm it. If it confirms, if there is no systemic system or clinical feature suggestive of the connective tissue disease, so it rules out the connective tissue disease if dense fine speckled pattern is there. Sometimes what happens, this dense speckle in the nucleus superimposed over the other pattern. So you have to take into account whether the clinical feature is there or not. If they are there, then again go for the reflex test. If there is no clinical feature, then it's almost rule out the connective tissue disease. Even the titer is 1:640 or higher. So this is the anti-DF possible marker ruling out the diagnosis of systemic connective tissue disease. And centromere pattern, 30 to 60 dot distributed throughout the nucleus in the resting cell. Dot localizes chromosome at the metaphase plate in the dividing cell. What it suggests? It suggests centromere proteins, ABC antigens. And what we can diagnose with the limited systemic sclerosis, which has got calcinosis, pulmonary hypertension, isolated Raynaud's phenomena, or primary biliary cirrhosis. Then comes the nucleolar staining pattern. Homogeneous nucleolar staining is there, we can see here, and that gives rise to the polymyositis or SCL complex or U3 RNP known as the fibrillin, and 72 RNP they are there at THCO. We will come later on the what is the significance of these antibodies. So what are the disease associated with it? Are the SLE, rheumatoid, systemic sclerosis, polymyositis, dermatomyositis, MCTD, and Raynaud's phenomena, maybe primary one. MCTD is the overlap of these three diseases. And how diagnose? We diagnose with the U1 RNP. If they are present in the reflex one, we can consider about this. Superimpose upon the basis of superimposed features, we treat them. If the systemic SLE features are there, renal disease, and confirm the diagnosis of SLE. If UNRP, you confirm the diagnosis of MCT. Anti-ribosomal P means Anti-gyronormal P means neuropsychiatric manifestation and renal disease. Anti-ROSA say neonatal lupus. Anti-Smith, it has got no clinical significance but confirm the diagnosis of SLE. Sjogren, you will get anti-ROSSA or anti-LA or SSB titers. Scleroderma, SCL3 or anti-centromere antibody we may get. Myositis, anti-Jo1 antibody will be present. So with the reflex, we can categorize different types of connective tissue disease in different groups, and we have they have got different modalities of the treatment prognosis, so we can judge them and treat them. So then comes the drug induced. It is always ANA is positive. Sometimes you make us get NTR and SSA positivity. One or more suspect drugs, at least 1 month or more is used, then it develops. And gold standard of diagnosis is resolution within several weeks to months after the offending drug has been discontinued. So this is the gold standard for the diagnosis, but it can confirm by the antihistamine antibody. And treatment has to be done accordingly in the same manner as the SLE. But if the SLE is there, whether we have to give these drugs which are predisposing to the SLE, the guidelines are doubtful. These are the drugs which can lead to development of drug-induced SLE. And COVID, sometimes in the COVID, persons who were treating it may have seen that they developed ANA, particularly in the acute illness. Those persons who have got the ANA, they are not good, they were having not good prognosis. And this is due to the exuberant response from the immune system. If in some patients, they may also have got the antiphospholipid antibodies, and they may disappear later on with the treatment. But with the presence of the antiphospholipid antibody, so chances of thrombosis were more. So one case history, one or two. A 25-year-old female came to OPD with no recurrent recent illness, but does admit that feeling of fatigue and anxious about beginning her new job next week. Her vital signs are within normal limits. Her physical exams reveals no pertinent finding. She requests her anti-nuclear antibody titer to be drawn since she read online that the fatigue is associated with lupus. When the result are returned, her NA level was mildly. So what is the next best step to the workup? Don't have to do anything. Rashes are there, so your reflex will be negative. So no further workup is necessary at this time. Only 30% of average healthy population has increased titers of ANA. In the absence of related clinical manifestation, no further testing is recommended. Case 2 is there. A 55-year-old man complained of joint pain, easy fatiguability, chest pain for the past week. No complaints of fever, palpitation, or shortness of breath. Hypertension, type 2 diabetes mellitus, or hypercholesteremia, and congestive heart failure. He was having a comorbid disease and associated disease were there. His current medicine included atorvastatin, ramipril, metformin, hydralazine, and spironolactone. And the physical exams revealed that fixed rub on the cardiac auscultation, and lungs are clear to auscultation. So this patient has probably deteriorated due to the heart failure, due to the hydralazine, leading to the development of drug-induced SLE. So drug-induced lupus most likely from the hydralazine, and the recent exhaustion of the heart failure was due to this hydralazine, and we have to look for the antihistamine antibodies in addition to the ANA. So in the take-home message, ANA is not always indicative of autoimmune rheumatic disease. Reflective test must be ordered if you have got the clinical features and if you have got the high titer. They help in categorizing the disease and organizing the treatment according to them. And always interpret results in relation to the clinical features present. Thank you for listening.
Thank you, sir, for your excellent talk. And we have solved so many problems for general practitioners and physicians. So these are the issues which we are commonly facing in our clinics. So now our chairperson, sir, Dr. C.V. Prasad, would you like to ask anything? Doctor, unmute yourself, sir. Please unmute.
Yeah, it was excellent presentation by Dr. Rajan Kumar. I think he has explained everything about the disease. And some clinical cases he has also presented. So nothing, I think, nothing important is going, I am going to ask.
Thank you, sir. Thank you.
Thank you.
So next talk is Dr. Sudhir Kumar. He is an additional professor in Department of Medicine. And he's also a rheumatologist working in rheumatology, field of rheumatology. And he's our secretary, API Bihar also. And under his umbrella, we are doing all preparation for BAPICON. Welcome, Dr. Sudhir, sir. Your talk is undifferentiated connective tissue disorder and mixed connective tissue disorder overlap. So this is difficult for any physician and GPs to differentiate between two. So let us start your talk, and we are eager to hear your talk. Thank you. So Dr. Sudhir, please unmute yourself. Yeah.
Thank you, Dr. Rajiv, sir,
Yeah,
giving me opportunity to deliver a talk in this prestigious BAPICON. I would like to thank our great colleague here. Dr. Rajan sir was my teacher during my post-graduation. Good evening, sir. Today I am going to talk about certain different terms which is used in rheumatology, that are undifferentiated connective tissue disease, overlap, and mixed connective tissue disease. First, I will briefly talk about the importance of all these terminology, then briefly discuss all the three terms like UCTD, overlap, and MCTD. Friends, we all know that certain set of signs, symptoms, and autoantibodies define any specific connective tissue disease. In our daily practice, we usually find it a challenge to diagnose any specific rheumatic disease because many of the patients come to us with the signs, symptoms, and lab markers which are often non-specific and may be found in normal and abnormal scenario. In one study, it was found that more than 25% of the patients referred to the tertiary care center do not carry any diagnosis of specific connective tissue disease. In our practice, we see mainly three sets of patients who are not coming with any specific connective tissue disorder. Some patients have the symptoms and the lab finding consistent with a connective tissue disease, but they do not meet the classification criteria of any particular disease. Some of the patients with the signs symptoms of connective tissue disorder fulfill the classification criteria, but they fulfill the classification criteria of two or more than two diseases, either simultaneously or sequentially. Some patients may present with the signs symptoms and multiple connective tissue disorder signs symptoms, but they are having some specific autoantibody. So they are the different types of patients. So understanding and differentiating certain well-known terms like undifferentiated connective tissue disease, overlap, and mixed connective tissue disease is very essential. Friends, we all know that at present, the criteria for classification is available for only 5 well-defined connective tissue disease. These are SLE, scleroderma, polymyositis, dermatomyositis, rheumatoid arthritis, and primary Sjogren syndrome. First, I will describe about undifferentiated connective tissue disorder. Patients who have the symptoms and the lab finding consistent with the connective tissue disease, but they do not meet the criteria for classification of any particular disease, they are often considered to have undifferentiated connective tissue disorder. This concept was initially proposed by Leroy and colleagues in 1980 to refer to the early phases of connective tissue disorder that were initially undefined. So, undifferentiated connective tissue disease is considered when a patient is having signs, symptoms of any or multiple connective tissue disorder, but they do not fulfill the classification criteria of any one of them. So most of the UCTD cases belong to one of the following categories. First category, patient presenting with new onset, few rheumatic signs and symptoms with or without autoantibodies. Second set, patient with many clinical and serological features of multiple rheumatic diseases. And third one, patients with features strongly favoring a specific rheumatic disease, but they are fail to fulfill the classification criteria. In one study, it was found that the typical presenting symptoms of the patient with undifferentiated connective tissue disorder are mainly Raynaud's phenomenon, followed by arthralgia and arthritis. Sika syndrome is seen in 25% of the cases, followed by malar rash, photosensitivity, sclerodactyly, and hematological manifestations like leukopenia, thrombocytopenia, and anemia. But you have to put a strict vigil on this type of patient because this entity may evolve into a specific disease or may persist unchanged over years, and some of them may even disappear. In a prospective study of 143% of undifferentiated connective tissue disease done by Williams et al. In 1999, he found that after a mean follow-up of 10 years, it was observed that of UCTD was persisted in 65% of the patient. 15% fulfill the criteria of systemic sclerosis and 13% of SLE, 1% of MCTD. While it was observed that 6% of the patient developed complete remission. In patients with UCTD, the average 5 and 10 year survival rates are around 83 and 76% respectively. From management point of view, the management of UCTD is mainly symptomatic and based on the presentation of the sign and symptoms. One should closely follow the patient for a long time, and it is very important, and treat specifically if the patient develops any specific connective tissue disorder in future. In two scenarios, strict vigil on the patient is very important. First, if the UCTD patient comes with the Raynaud's phenomenon, you should closely follow the patient for the development of pulmonary arterial hypertension. And if the UCTD patient comes with the signs symptoms of SLE, then you should closely follow him for the development of dreaded glomerulonephritis. Now, second term is overlap syndrome. Overlap syndromes are generally defined as meeting classification criteria for more than one classic disease, connective tissue disease. Patient may present with evidence of more than one disease simultaneously or sequentially. Virtually any combination can be possible, but some combinations are more common. Overlap of different diseases like SLE, rheumatoid, scleroderma, dermatomyositis, polymyositis, and others in various combinations are seen in overlap syndrome. Lupus syndrome is a well-known overlap of rheumatoid arthritis and SLE. Lupus syndrome classically presents with the development of erosive polyarthritis or rheumatoid nodules in the patient with SLE. Extra-articular manifestations of SLE are less common and less severe among lupus patients. So Rufus syndrome is a combination of features of both RA and SLE, and Rufus patient fulfill the classification criteria of both RA and SLE. Polymyositis is one of the disease which can present with the overlap syndrome frequently. Among patients with polymyositis systemic sclerosis overlap is most common. Anti-PMSCL antibody and anti-Q antibody are associated with polymyositis systemic sclerosis overlap in different populations. Rheumatoid arthritis systemic sclerosis overlap is also common, and most of these patients have limited systemic sclerosis. Raynaud's phenomenon is generally most common extra-articular manifestation among these patients. Owing to small patient number and poor definition of the overlap syndrome, separate guideline to treat overlap syndrome is not available. So they are treated according to the disease presentation, and whatever the disease classification criteria they fulfill, we have to treat the diseases accordingly. Lastly, mixed connective tissue disease. Mixed connective tissue disease is a rare autoimmune separate entity. It is diagnosed when a specific antibody known as anti-U1 RNP is present, and there are features of many connective tissue diseases like SLE, systemic sclerosis, polymyositis, dermatomyositis, rheumatoid arthritis, and others. Since the initial description by Sharp, several rheumatologists expressed their doubt over the concept of MCTD as a separate clinical entity. But certain different characteristics and the association of the MCTD with a specific set of autoantibody, association with certain different HLA, and a specific clinical manifestation make it a distinct disease entity. MCTD was first described by Sharp et al. As a distinct clinical syndrome in which the combination of features similar to those found in SLE, systemic sclerosis, dermatomyositis, polymyositis, and rheumatoid arthritis was found. This disease was considered unique as it was associated with autoantibody to U1 RNP. MCTD is now recognized to occur throughout the world. It is a rare disease, but predominantly affect females with the female to male ratio of 16:1. It's a disease of mainly of younger and middle age group. A high titer of anti-RNP antibody in a patient with UCTD is a powerful predictor for a later evolution into MCTD. So whenever a patient of UCTD come to us with anti-RNP antibody, we should closely follow the patient for the development of MCTD. There are some different or specific characteristics of MCTD. Clinically, MCTD patient presents with the signs symptoms of arthritis, swollen hands, Raynaud's phenomenon, abnormal esophageal motility, sclerodactyly, myositis, and pulmonary arterial hypertension. When we talk about in terms of immunology, high titer anti-U1 RNP, particularly against 70 kilodalton molecule, is very specific. Genetically, it is more associated with HLA-DR4 and DR2. Immune complex levels are often very low in case of MCTD than SLE. Histopathologically, proliferative vasculopathy in the absence of fibrosis is seen in MCTD, while in systemic sclerosis, proliferative vasculopathy with fibrosis is often seen. Patients with MCTD very rarely develop the life-threatening complication like glomerulonephritis, psychosis, or seizure, which is commonly seen in SLE. Patients with MCTD develop Raynaud's phenomenon earlier, and nail hole capillary pattern changes seen as it is seen in scleroderma, but very different from classical SLE. Patients with MCTD more likely to develop pulmonary arterial hypertension than the patient with classical SLE or scleroderma. And lastly, patients with MCTD are more likely than SLE patient to be rheumatoid factor and develop an erosive arthritis. So MCDD is a clinical entity, separate clinical entity, which have the features of SLE, SSC, RA, polymyositis, along with a specific autoantibody against U1RNP. So, due to presence of the non-specific symptoms and different organ involvement, differential diagnoses are multiple. These include SLE, rheumatoid arthritis, polymyositis, dermatomyositis, scleroderma, IPF, pulmonary primary renal disease. There are multiple diagnostic criteria, not classification criteria. Multiple diagnostic criteria are available for MCDD, and Alarcon-Segovia criteria is one of common diagnostic criteria which is used in clinical scenario. It consists of two parts, clinical criteria and serological criteria. Clinical criteria are swollen hands, acrosclerosis, Raynaud's phenomena, myositis, and synovitis. And serological criteria is high titer of anti-U1 RNP. So diagnosis of MCDD is made when clinical immunological criteria, that is high titer of U1 RNP, is present along with 3 or more than 3 clinical criteria. This criteria is 63% sensitive and 86% specific. Now, management. The management of patient with MCDD generally rests upon the known effectiveness of specific therapy or similar problem seen in different diseases like SLE, scleroderma, and polymyositis. We all know MCDD is an inflammatory disease, so anti-inflammatory medications are main treatment. Most of the inflammatory manifestations respond very well to anti-inflammatory drugs, while features like Raynaud's phenomena and GI manifestations are unresponsive. Myalgia due to myositis respond very well to corticosteroids. When we talk about the prognosis of the MCDD, almost 1/3 of the patients of MCDD undergo complete resolution, while 1/3 develop life-threatening complications. Prognosis depends upon the organ which is affected, the degree of inflammation, and the rate of progression of the disease. Pulmonary hypertension is the most common cause of death. Interstitial lung disease, infection, CVD, and malignancies are the other causes. So, lastly, take-home messages. Many patients present with the signs symptoms of connective tissue disease, but can't be classified as any specific connective tissue disorder. So, understanding UCDD overlap and MCDD is important for patient management. Proper follow-up the patient with UCDD is very important, and many of them develop specific connective tissue disease in future. Overlap syndrome fulfill the classification criteria of more than one connective tissue disease and present as different combination. MCDD is separate disease entity with a specific autoantibody. Thank you.
Thank you, sir. Actually, it was a difficult topic, but you have nicely presented this topic, and that too before time. Yes, that is very nice thing. So, Dr. Jha, is there any question? So, yeah, you are listening this. Dr. C.V. Prasad, sir. Yeah. So, Dr. Sudhir, what is the incidence of such type of rare cases? Yeah.
These all are not rare cases. UCDD is very common.
Yeah.
Undifferentiated connective tissue disorder is very common. I think almost 30 to 40% of the cases we see in our OPD are of UCDD type. While MCDD is very uncommon disease, and overlap is also uncommon disease.
So at what age most of the cases are coming in these patients?
MCDD is very often seen in our country. We, in our daily practice, I think in 1 year, in my OPD, I usually see 10 to 15% of MCDD. Yeah. UCDD is, as I told, it's very, very common. You can see all the physicians, they see UCTD patient very often. And overlap is somewhat more uncommon. I have seen lupus patient, 3 cases of lupus patient till now. So UCTD and overlap are uncommon diseases, while UCTD is very common.
So, have you seen the multiple system involvement like pulmonary fibrosis and renal involvement in such type of cases?
Yes. In the late stage, many of the patients coming with multiple organ involvement, and most of them are in the stage lung involvement or in the stage renal involvement. Many of them are a patient of SLE or patient of systemic sclerosis come like this in last stage of diseases.
Nice, very nice, very nice. So, Dr. Rajan sir, what is take-home message regarding the ANA titer?
ANA titer 1:40. Usually the lab gives the positive one, but don't have any clinical features, arthritis, rash, any other system suggestive of Raynaud's phenomena, interstitial lung disease, nephritis. If they are not there, you don't move further. Okay.
Yes.
We will not get anything in the reflex ANA test. Usually they come negative. But if the clinical features are there, even if you have got the low titer, then you must go for the reflex, and accordingly you categorize the patient. If the ANA is positive, it can be any diffuse systemic generalized connective tissue disease, whether it will be MCTD, whether it will be the scleroderma, whether it will be the Sjogren syndrome, rheumatoid arthritis, anything can be there. But if you have got the ANA positive, if you have got the RA positive, you must look for NTCCP. If you got the NTCCP, it is always rheumatoid arthritis, not the SLE or lupus. Second, if you got the MCTD, you must go for the other lab tests. As the UNRP, if you get that, the Raynaud's phenomena, UNRP will be there, synthetase, and other will be there. So your reflex test will decide the diagnosis of the correct syndrome which is associated, and different syndrome has got different management and different problem and different organs involvement.
Thank you, sir. Thank you. Sir, Dr. B.N. Jha, sir, what is your message regarding just to physicians when we suspect spondyloarthritis? Is there any pinpointed words for physicians to see for spondyloarthritis? Because that is also common. Most of the time we always miss that case.
Sir, unmute, sir.
Unmute yourself.
Most of the time in general practice, we see polyarthritis cases. And since rheumatoid arthritis is the commonest chronic inflammatory polyarthritis, one diagnoses rheumatoid arthritis. Message is that it is not always rheumatoid arthritis. If the patient is a young male who starts having back pain or the pain in the buttocks, and then other peripheral joints are also involved, one should think about spondyloarthritis as well. And taken together, if you take all these 5 spondyloarthritis subtypes, they are more common than rheumatoid arthritis is. So if a patient comes with a back pain, which is an inflammatory back pain, by inflammatory I mean that pain is maximum in the later part of the night or early morning, and he's a young male, and he has got other peripheral joints involvement as well, then one should go for investigation for spondyloarthritis.
Thank you very much, sir. Thank you.
Thank you.
Thank you. So over to Dr. C.V. Prasad, sir.
He has explained everything regarding the But my question is only in case of rheumatoid arthritis. The question is not pertinent over here. What is the role of biologicals, sir? Dr. Rajan Kumar.
Yeah, biologics, when we have to use, there are the, if you are treating with the NSAID and the DMARD, okay? You are treating a patient with a DMARD and the patient develops, is not being controlled, even if you are giving the low dose steroid for 3 months, if you have escalated DMRD, I added another one, then after the 3 months, we call it as a failure. Failure of your DMARD, failure of your steroid. So then in that case, you will need biologics. So biologics may be the targeted one, maybe the biologics TNF blocker and other one. We can use at that time. After 3 months, if the patient has not responded, then we say DMARD has failed. Once the DMARD has failed, you have to escalate or you have to add it. Again, if it has failed, then you have to add the biologics. And biologics works just like the other DMARD. If you withdraw, the same thing will come. Biologics is not anything which gives surprise to the patient that he will go on the remission for the permanent.
Thank you. Any addition, Dr. Sudhir Kumar or Dr. Bienja?
Addition to what? Your question?
Yeah, about Dr. Rajan Kumar, what he said about the biologicals.
Well, my addition is that introduction of JAK inhibitors have in fact sounded the death knell for biologics. Because JAK inhibitors are also as effective as biologics are, and their introduction and administration is quite easy. Secondly, monitoring is also not as, much as they are done with biologics. And generally, all the biologics are to be given IV, whereas this is given orally. Recently, now they are telling that biologics can be used in spondyloarthritis as well. But results are still not out, but reports are very good. So, my opinion is that instead of going to biologics, once the conventional DMARDs fail or their combinations also fail, then one should switch over to JAK inhibitors. We have got baricitinib and tofacitinib, and they give very good results. I've got very limited experience with that because I belong to a place where people generally don't afford these drugs, but I have used the JAK inhibitors in 2 or 3 cases with very good results.
Yeah, I'm adding over it. JAK inhibitors, I already told that it is targeted DMARDs and it works just like other steroid. So it gives good result. You don't have to give a steroid with it, otherwise secondary will come up.
Yes. What have been said by Dr. Jha and Dr. Rajan sir, quite correct. And want to add one more thing. Whenever we use biologicals, if the patient develop any resistance or no benefit, then we should change the biologics, because there is nothing terms like biological resistance. But we can switch off the biological, different biologicals are there, and we can switch off the drugs whenever necessary.
3 months is the time when we say it is failure. You add another group of the same group. If a fails, then go for the another group. That is the guideline.
Yes. And one more point, that whenever you use biologics in rheumatoid arthritis, always give the patient along with methotrexate. Methotrexate should not be withdrawn.
Correct.
Thank you, our eminent speakers in rheumatology session. You all have completed your talk very nicely, very well, and all questions have been answered. Thank you very much, Dr. B.N. Jha sir, Dr. Rajan sir, and Dr. Sudhir Kumar sir, and not Dr. C.V. Prasad sir for conducting this session very nicely. Thank you, sir. Thank you for joining.
Thank you very much.
Thank you,
Yeah.
Rajiv.
you.
Thank you, sir.
Yeah,
Thank you, Rajiv.
You will meet in GB meeting, sir.
Okay.
Yeah.
Thank you.
At what time?
6 o'clock, sir.
6
Yeah.
o'clock. Oh.
Thank you, sir. वो बोलने वाले हाँ, अरे वहां से बोलना पड़ेगा, उस लेक्चर को बोलना पड़ेगा, उनको बोलना पड़ेगा कि हॉल बी में ज्वाइन करवाओ।
अच्छा, उनको हॉल ए से हॉल बी में
हाँ,
कर देंगे।
और यहाँ पे प्ले कर। हाँ, अभी ऑन ही रखो बाबा, एक और लेक्चर आ रहा है उधर, जीबी मीटिंग।